عشان الاونلاين. ايوه عشان احنا البانل الاونلاين عشان اتفضل كده. لا لا خليني كده وانا معاك كده.
مش ما اشتغل. صحيح. كنا سيبناه يعمل ابديت بقى براحته. بيفتح ويقفل.
ثاني اشتغل مني.
وبعد كده تفتحها لي كلمه انترودكشن على القفل. افرقه تحت المظله عشان افرقه.
لا حاشا لله.
كلنا بس لازم التركيز شغالين. القفل ده محتاج يعني في حاجه يعني الكتروني هو ما عندهمش الكتروني ما يعرفش كده يعني. الناس بتيجي جاي لها رينا سيلر والطيب وخلاص السلام عليكم. طيب لو حته فيها اكيوت يبعتوه ساعات في دول كده في وسط افريقيا يبعتوه دوله ثانيه يعمل دياليسيس ولا يروح الهند يزرع ولا ايه. دي عايزه حد
ساعدها.
يابجريد الاول خالص بس التركيز على التكنولوجي براكتس.
كيف في الابديت ده؟ الابديت سيبه. انه فتح. هو فتح. امال بيعمل ايه؟
اللي هم شغالين عارفين هم اللي فين الباقيين ده 51 دوله.
كم دوله بيعملوا ناس كلام؟
15 واحد. وكل دوله هي عندها اكسبيرينس بسيطه جدا. الباقي دول
بس عندهم بفلوس. الدايلسيس اللي بتبقى
في حتت كتير
يعني بير سيشن مش عارفه 30 دولار او حاجه. زامبيا او حاجه.
اقول لحضرتك حاجه. كل دوله sometimes they not pay for dialysis because it is not there.
انا فاكر السنه اللي فاتت
في حتت ما يعرفوش.
كل دوله بيدفعوا مبلغ جنب.
ما انا بقول لحضرتك ده في مثلا في العاصمه تلاقي مستشفى فيها مكانتين اللي حضرتك اللي بيدفعوا. بقيه اللي في العاصمه وبقيه البلاد كله اتكل على الله. وعندهم رينال فيلير او ملاريا بالهبل والاكيوت بالهبل وكله مع السلامه. اي حد اكيد انتهينا.
عندهم بي دي اي ثينك يعني.
والله كل دوله تشوف الكريمه بتاعت افريقيا.
وديك ان احنا برضه عندنا معجزه ان الدايلسيس فري. دي معجزه.
لا احنا عندنا مش بس معجزه. اتس اوتستاندينج ان مفيش سنجل بيشنت يتشخص ان هو رينال فيلير ومحتاج دايلسيس وهيز نوت سبونسر 100% سبونسر. حتى لو السيرفيس مش 100% بيرفكت يعني مش مهم
الكواليتي بس هو
مش مهم الكواليتي. ديفينيت الكواليتي مش ممتازه قوي بس مفيش عيان is left.
ما يحسنش.
never. ما
صحيح.
تلاقيش عيان في حته احتاج ده. For the second day of the African Society of Organ Transplantation Congress. I am really privileged and honored to be among the executive panel for this session, and it's a real form of panelists rather than chairpersons. We are privileged to have Professor Riyad Saeed among the panelists, Professor Mohammed Ghanaimat, Professor Dawlat Bilal, Professor Adam Gaber, and Professor Mohammed Hani Hafiz. This is actually a peculiar and a special session about the inauguration of the Egyptian transplantation guidelines. It's a real breakthrough achievement, and it was led and performed by our dear professor and colleague, the icon of nephrology in Egypt and the Middle East and Africa, Professor Rashad Barsoum. He established this guidelines, and it's of paramount importance to consider having your own suitable management procedures and guidelines to manage your patients according to your facilities, according to your knowledge, according to your patients, which varies from one community to the other. So this is, I consider a breakthrough achievement to establish the Egyptian guidelines. Moreover, we might need more regional approaches and regional considerations in this issue. Professor Ghanaimat, would you have a comment about this, please?
So, good morning, everyone. Assalamu alaikum wa rahmatullah. Thank you very much, Professor Gamal Saadi, for this introduction. And I'm very honored and privileged to be among these distinguished panelists in this early morning. And I'm very proud of my dear friends and colleagues in Egypt for having these guidelines. I hope that we can at one time reach to a stage of having an Arab guidelines rather than a very individualized guidelines for each country. And this applies to transplantation, this applies to dialysis, this applies to our healthcare system in general. So I would love to see in the near future and under the umbrella of Egypt, البلد الأكبر والأكثر علما among all Arab countries. We wish that you can back us up and start this initiative. Professor Jamal and Professor Hani Hafiz and the rest of the Egyptian colleagues to start having an Arab guidelines for transplantation and for dialysis. And I will hand it to Professor Muhammad Hani Hafiz to give the Africa.
Thank you very much. It's I'm very honored to be in this distinguished panel. The problem with Africa actually is beyond the transplantation. It goes among the basic nephrology that it has been published that the mortality rate of acute kidney injury in Africa and in developing country goes vice versa to the GDP and the expenditure on health. And it is very frustrating that we find that people with acute kidney injury don't find dialysis facility except in big cities, in the capitals, and up to 35% of them only reach dialysis facility. When we speak about transplantation, of course, we have few countries in the continent performing transplantation since many years, but the majority of African, more than 52 countries, don't have established transplantation facilities. So they need to start programs. They need to depend on themselves instead of sending their patients to be transplanted abroad. And of course, guidelines will come after that to suit the cheapest immunosuppression, which goes with their limited budget. Thank you.
I believe we need now to start to listen to our dear Professor Rashad, and please, all the panelists, if you have any comments or ideas, please write it to have a consensus out of this meeting and explore more fields in the guidelines. We can consider renewal of the guidelines every year and so on. So the notices you will have will be collecting, and to consider also having the Arab view about establishing this guidelines among the Arab world. So please have your comments written in paper and give it to me to collect it later on. We can start now the talk of Professor Rashad.
Respectable chairs, distinguished audience, I'd like to start my presentation this morning by thanking Professor Gamal Saadi for inviting me to present the recent Egyptian guidelines for kidney transplantation that was published in January last year in the Arab Journal of Urology. I am presenting this on behalf of the work group and must acknowledge all the panels that reviewed and revised this guideline until it became a reality. The first question that can come to mind is whether there is a need for having an Egyptian guidelines while there are plenty of guidelines all over the world. But the most important four areas where guidelines are developed include the United States and Canada, Europe, including the United Kingdom and France and other countries, and in Australia and New Zealand. But when you look at this map, you will see that guidelines are developed in the rich countries, which can afford developing a guideline as it should be, while the rest of the world cannot afford doing all the work that is necessary to produce the academic level of a good guideline, and the circumstances around kidney transplantation in the majority of the world's countries are very specific. There are certain genetic factors, pharmacogenetics. There are comorbid conditions, parasitic diseases, infections, and some metabolic disorders and so on that can modify the course of transplantation or the effects of drugs in transplantation. And of course, there is the issue of costs, where certain drugs are too expensive to be spent within the limited health priorities available in these countries. So from the very beginning of developing any guideline all over the world, there is always a disclaimer that tells that each country should take these guidelines as guidelines, not as rules, and modify them according to their prevailing circumstances. So the need for every country to critically analyze the existing international guidelines and see how can they modify it. But they can't modify evidence. They can't modify scientific academic evidence. they can modify the recommendation for using this evidence and to what extent and for which particular patients. And that is an important task when you develop a local guideline. The scope of our guideline includes 30 sections addressing pre-transplant workup for both donor and recipient, medico-legal aspects, vaccination policies, surgical aspects, immunosuppression, antimicrobial prophylaxis, post-transplant monitoring, complications, including the immunological and non-immunological complications of transplantation and immunosuppression, and a word about special populations like the aged, pregnant women, children, and so on. Our resources were as follows. We started by looking into 6 international guidelines and read them very critically. We also read position statements and institutional protocols from different parts of the world, from the leading institutions in kidney transplantation. We made a survey online inviting senior Egyptian experts, surgeons and physicians, to give their opinion on particular well-defined points that will eventually form the items of the guideline. This was an online survey for which we used the commercially available program online. And we invited 40 of the current and previous chairs of the transplant centers approved by the Ministry of Health of Egypt. Of these, 28 responded to the questionnaire. We also reviewed Egyptian publications about kidney transplantation produced on the Egyptian populations, different Egyptian populations. And then we had an Egyptian panel of experts, actually 2 panels, that reviewed these guidelines independently. And eventually the Egyptian Society of Nephrology and Transplantation reviewed the guidelines and included them in the guideline section of the society. So it is now the official guideline of the ESNT. In order to properly express the importance of each guideline, we gave each one a marker composed of a letter and a number. The letters represent the quality, the academic quality of evidence, high quality RCT, specific relevance to kidney transplantation or particular sections in the guideline. B is moderate quality RCT, of broad relevance, not very specific to the item we are talking about, or a meta-analysis. And C are registry data, which, as you know, have got their limitations, patient cohorts and case control studies. And D are case reports, narrative reviews, and experts' opinion. This is science. This cannot be changed. And evidence A has to remain A because it is based on these criteria, and so on. But the strengths of clinical recommendation, whether we are going to use A as our first priority or not, depending on the cost, on the applicability to the population in our country, to known co-infections, and so on. So we are a little bit more free to modify these 1, 2, 3, and NG, not graded, according to these factors. So you can have an A1 in America, but it can be an A3 in Egypt if you can't afford the price of the medications mentioned in the A1, and so on. We can do it the other way around. We can be happy with an opinion, expert's opinion, because it is practical and applicable and so on, and then you will have a G1 recommendation. And to show you this as an actual example, here is how one of the guidelines says. We recommend. So recommend is here, that is a level 2 evidence, clinical evidence, and here it is. But it is based on high quality evidence. So it takes the A of the evidence quality and 2 of the clinical recommendation. It becomes 2A. We recommend including induction therapy with a biological agent as part of the initial immunosuppressive regimen in kidney transplant recipients, and that is the reference. one of the important references, except in Caucasians with two haplotype identical living related donors. And so once you read a certain item in the guidelines, you can always see the basis of putting it this way. The highlights of our guidelines includes 5 points that we addressed in more detail and more depth, including vaccination, which is a recently emerging topic in many of the guidelines, recipients' risk categorization, immunization, individualization of immunosuppressive treatment according to the risk, antibody-mediated rejection, again, a hot point in many guidelines, most guidelines, and post-transplant monitoring that is meant to prolong as much as possible the life of a transplant and avoid complications of the transplant itself or of immunosuppressive or other drugs used in the process. I start by vaccination, and here is the key vaccination here that we strongly recommend, which means A1, which means a 1 recommendation, although it is a C academic level. I recommend all kidney transplant candidates to receive the inactive immunization vaccine and boosters prior to transplantation, And these are the 5 recommended infections: B, hepatitis B, Haemophilus influenza, seasonal influenza, meningococcus, and pneumococcus. We also recommend kidney transplant recipients to start or resume immunization vaccines or boosters 6 months post-transplantation, except for seasonal flu, which is permissible after 1 month before the onset of influenza season, and then annually. We strongly recommend avoiding all live vaccines because they can be activated due to immunosuppression and can lead to serious consequences, as with yellow fever, for example. We suggest considering family and caregiver immunization for enhancing protection because they are close contacts and they can transmit an infection if not immunized against it. So these hard lines are really very important to remember when we consider vaccination in the transplant recipient. The second important point is recipient risk categorization. We strongly recommend pre-transplant assessment of the recipient's past and present immunological risk factors, including donor-specific antibodies. And we recommend using the recipient's immunological risk for individualization of the immunosuppressive therapy and we categorized all our recipients into 5 categories. Category A is the highest risk, which is a positive flow cytometric cross-match, positive cytotoxic cross-match, mean channel index, and positive DSA, donor-specific antibodies, with a high titer of 17 RIS. Of course, how to calculate these, how to interpret these are detailed in the guideline itself when you read it. These patients are not fit for transplantation and are not fit for desensitization. You waste your time and money, and eventually you can never reverse these things. So A is not transplantable. We have to look for another donor. B is very high risk, requires desensitization because of the parameters by flow cytometry and because of the presence of donor-specific antibodies in a high titer or a historically positive donor-specific antibodies. So category B is mainly concerned with anti-HLA antibodies that are specific to the donor. C and D look into donor-specific antibodies, but also on HLA antibodies that are not donor-specific. And these patients are hypersensitive, hyperreactive, and therefore they are a high risk, although they don't have preformed donor-specific antibodies. It says here, previous graft failure due to rejection during the first post-transplant year, retransplant previous HLA antigens which are not avoided in the new transplant, full HLA mismatches, high non-DSA antibodies, and high calculated pan-reactive antibodies. This is a relatively new term that is done before the transplantation on a large panel, almost nationwide panel, showing that the chances of the particular patient to find a matching donor with no antibodies is high or low. And therefore, you can categorize your recipient's risk before transplantation by using the CPRA. While when you have a donor, you can now measure whether there are antibodies against the HLA system of the donor. And you can also know whether they are donor specific or non-donor specific by looking into the antigens themselves, which is sometimes called a virtual cross-match. The intermediate one is less intensive than this one. So C and D are transplantable, but it is preferred by many people to desensitize C, while you don't need to desensitize D. But you usually do induction therapy even for the D. You may or may not use it for E, although the guideline says that everybody except Caucasians, related Caucasians first degree, you can avoid induction. So pre-sensitization is indicated in B and preferred in C, and may be done in other circumstances like a very high mismatch and so on in D. But induction is done in all except A, where you shouldn't transplant at all. Now, how can we individualize the immune suppressive treatment? In order to understand the rationale of immune suppressive protocols, it's important to review the targets. And the targets of immune suppression include cells and molecules. Here is the antigen presenting cell of the donor. And here are the recipient cells that are going to communicate with the APC of the donor to stimulate the immune system and reject the graft. So you have helper T cells that have the CD3 receptor as the only normally expressed receptor in the quiescent lymphocyte. There are other types of lymphocytes like the killer ones, the natural killer ones, the memory cells and so on, and B lymphocytes of a similar distribution. There are the T regulatory cells which check the activity of these lymphocytes, and the B regs which do the same for the B lymphocytes. And when the donor kidney is transplanted, the APCs inside the kidney will reach the access to the circulation of the recipient. They will attract chemokines, lead to attraction of the T lymphocytes to engage the CD3 receptor of the lymphocytes and the HLA system, which is expressed on the surface of the APC. It is the major antigen which is expressed on the donor cell. And once this happens, there are lots of reactions here, cytokines, chemokines, and chemoattractants, and so on. I am just going to allude to them in a minute. But when this happens, other lymphocytes approach the T helper cell to get the signals and then get attached to respond to orders by the helper cell. Then the reg cells also approach the T lymphocytes and the B lymphocytes. And out of all this complex assembly of cells, you get stimuli that affect the cell cycle, which is all important in inducing proliferation of clones of these cells to reject the graft. But normally, this cell cycle is quiescent unless stimulated by an antigen. They are all in the G0 stage, which is resting. But once they are activated, the G0 goes to the G1, G1 goes to synthesis, and G2 and mitosis, which is division of the cell. So you get a proliferation process. But normally, GO does not go to G1 because of a block by certain cytokines at this arrow, and because of the presence of what is called CYP proteins, which are protein kinase inhibitors, they block at different levels. But the most important block occurs in between the G1 and the S phases, which is induced by a CYP protein called P27. This is a key protein that I'm going to allude to in a minute. So that is the cells that you want to address in this situation. But that is how the picture looks like when the ligands and the receptors get attached, making this microenvironment in between the APC and the lymphocyte. And that actually is an important step for localizing the reactions, for localizing the talk between these two cells by creating a microenvironment, which is very economical for the amount of cytokines that you need to produce, and also to make sure that the signals are transmitted effectively. So you have all these, and each of these, of course, has its own importance. And there are also two important receptors and ligands. Here is the protein, C52 protein, which attaches the B lymphocyte to the T lymphocyte, and also has a role in other attachments like these two cells or these two cells and so on. And the second important product of this reaction is the interleukin-2, which releases the inhibition of transformation of the G0 to G1 on one hand, and also leaves the cell through the close attachment of the killer cell, for example, and the helper cell, by attaching to a receptor called interleukin-2 receptor. So interleukin-2 attaches itself to the CD25, this receptor, and that produces a downstream cascade that activates c-MICE, which is important in inducing tolerance at the end of the day, and mTOR, which releases the inhibition of P27, and therefore the cycle goes on, and you have developed a proliferating clone. Now, understanding this helps us to understand how we modify the response to the transplantation antigenicity generated at the first place by the antigen presenting cell. There are two approaches here. One is the induction, which means you give a drug that interrupts a surface receptor. It prevents the attachment itself, and therefore it is always taken before or at the time of transplantation to stop the whole reaction at the very beginning. And these include methylprednisolone, which inhibits this pathway, interleukin-1 receptor and NF-kappa B. T cell depletion like anti-CD3 monoclonal antibodies, anti-lymphocyte globulin, anti-thymocyte globulins, and so on. The basiliximab, which is an anti-CD25, anti-interleukin-2 receptor that blocks interleukin-2 from going into this pathway, and the limtuzimab, which is a CAMPA, that is a protein that stops the reaction of CD52 and therefore stops antibody formation by the B lymphocyte. So these are the four strategies for induction, which, as I said, are very helpful in all patients, but particularly the high-risk immunological risk patients. But you need maintenance so far for life in order to maintain an inhibited system and avoid proliferation of the cell cycle. These include prednisolone, again inhibiting this pathway, CNIs, which inhibit calcineurin, that is a key protein in the cell that transmits the first signal of attachment of the APC to the lymphocyte. We have the proliferation signal inhibitors, mTOR inhibitors, which when they do, they activate the protein of P27. When they are not there, they are active. So they will block the P27. And the anti-proliferations, mofetyl mycophenolate or sodium mycophenolate, or azathioprine, or pyrimidines, and so on. And these stop the synthesis phase of the cycle. So you block the cycle at least in two sites when you use maintenance immunosuppression. Now, the guidelines address both induction and maintenance. For induction, we recommend including induction with a biological agent as a part of the initial immunosuppressive regimen in kidney transplant recipients, except occasions with two haplotype identical living-related donors. And for the maintenance, we strongly recommend starting a combination of immunosuppressive medications before or at the time of kidney transplantation. You can start 1 or 2 days before or start at the time of transplantation. This is a 1A recommendation all over the world. We strongly recommend initial triple immunosuppression with CNI, tacrolimus, mycophenolate, proliferation inhibitor, and prednisolone in the high therapeutic range, regardless of the recipient's immunological risk. And this is a 1A. And by that, I mean for the first 3 months after transplantation, the highest therapeutic range recommended by the manufacturer should be used regardless of the immunological risk. You will modify later on, but for the first 3 months, you have to keep the doses fixed as much as you can. And the doses, as you see, and the target level decrease with time. And here is an example of the FK level in trough level. You start in the first 3 months by a blood level of 8 to 12 nanograms per liter. But after 4 months, you can go to 5 to 8, 5 to 8, 5 to 6, and so on. And if you use cyclosporin, the same occurs. You can go down to 75 to 125. So this slide is meant to tell you that this is a very critical area where you cannot reduce immune suppression except if you have a serious side effect that you can't stand. You can modify maintenance immune suppression by in stable grafts by continue CNIs in a low dose rather than withdraw them, because so far CNI free protocols are a little bit risky for inducing acute rejection. We recommend females to, who want to become pregnant to stop mycophenolate and switch to AZA. Female recipients must switch to mycophenolate once discovered. You do this 6 weeks before the transplant, but if you discover they are already pregnant, you have to stop immediately. Suggest reducing CNI blood level targets above age 65. And if a steroid elimination protocol is contemplated, we recommend limiting its use to low-risk KTRs, kidney transplant recipients, using biological induction and complete steroid withdrawal by the first week post-transplantation. Sorry for the spelling mistake. And to be considered for pediatric recipients who often don't like steroids in children. Then we go to the issue of antibody-mediated rejection. Cytotoxic antibodies are anti-HLA, anti-major histocompatibility antigens, which are expressed class 1 and class 2 at the surface of the protoplasm of most cells, particularly the antigen-presenting cells. And these can be specific to the donor or not specific to the donor, as I mentioned earlier. And there are non-HLA antibodies of maybe some importance in many patients, but they are not routine. The minor histocompatibility antigens, which are expressed on the surface as well. The MICA antigens, which are the MHC class 1 related chain A, they look like this at the surface of the cell. H and Y antigens are related to gender of the patient, and there is some evidence that there are gender-specific antibodies that can affect the outcome of the graft. But these are not very important. Anti-HLA antibodies can preform, that is pre-sensitization. You can see them before doing the transplant, or de novo in patients who had no antibodies before the transplant. But as you do a follow-up for these patients, you can find antibodies developing along the course of the transplant as a result of stimulation by donor antigens. Preformed antibodies, as I have already shown you, I'm just bringing this again to show you that preformed antibodies can be extensive where you don't transplant. They can be positive DSAs, but within limits of quantity B, and this is the desensitization. High risk and intermediate risk C and D, and you don't have any antibodies in E. So these are the rules of handling for antibodies, with clear distinction between DSA and non-DSA. Desensitization is essential when you do a transplant to B, and that we suggest avoiding desensitization in class A. We recommend offering desensitization to high or very high, B and C, immunological risk. And we advise individual transplant units to set their own acceptable immunological targets. What are the levels that you're going to accept? Before proceeding to transplantation, you have to check that your desensitization protocol has actually reached the level that you have set for your center as acceptable. And we suggest escalation of the individual desensitization process. If you don't reach the target by a certain protocol, you have to have a backup protocol or 2 protocols until you reach the target. We suggest to follow up donor-specific antibodies after transplantation in any desensitized patient to make sure that they don't recur. They do have consequences if they do recur. De novo antibodies are risky because they can induce 3 syndromes. They can be subclinical. You detect them only by doing routine tests, but there are no sequelae on clinical level. Or they can induce an acute antibody-mediated rejection. Or they can induce a chronic active antibody rejection. And here is the usual scale that we use. We suggest monitoring post-transplant antibodies to be performed in very high risk and high risk, which are B and C. A is not transplanted, so B and C. You do this monthly during the first 2 years post-transplant. We suggest screening for anti-HLA antibodies in intermediate and low risk after 3 months of the transplant, and then once a year for the first 2 years. So you see how the scoring here makes a difference in the follow-up protocol. We recommend serum samples should be sent at the time of renal biopsy for acute or chronic graft dysfunction to look for anti-HLA specific antibodies. We suggest screening for anti-HLA antibodies in recipients under minimization protocols every 3 months for 1 year. Acute ABMR, which looks like this, typically characterized by endothelial activation and deposition of C4D antibodies, and by peritubular capillaritis. Of course, the basement membrane will be split in those patients as a result of the endothelial activation. These are the major pathological criteria for anti-BMR. Acute ABMR is recommended. We recommend treating this with IVIG and plasma exchange with or without anti-CD20, corticosteroids, or lymphocyte depleting antibodies. But the 2 major things, particularly when you have anti-CD20, when you have C4D deposits, to use anti-CD20, which inhibits the lymphocytes. There is little to do to chronic active ABMR except increasing the steroid a little bit, but this kidneys, as far as we know today, will progress to end stage sooner or later. Protocol biopsy is another way of looking for antibodies in addition to serological tests. We suggest that all very high risk and high risk B and C kidney transplant recipients to undergo a scheduled graft biopsy with staining for C4D at 3 to 6 months post-transplant and 1 to 3 times thereafter for the first 2 years. We suggest at least 1 protocol biopsy with staining for C4D in intermediate risk during the first year, but you don't need to do this for the low risk. We suggest that any kidney transplant recipient with detected de novo antibodies or 1 biopsy, these are the 2 ways of searching for antibodies, biopsy-proven ABMR episode, or evidence of non-adherence to undergo at least 1 protocol biopsy to see what happens. Non-adherence is usually the most common finding in patients who develop de novo antibodies. Lastly, we move on to the post-transplant monitoring, and in the interest of time, I'm not going to provide full detail about this. It includes several issues if you really want to follow up your patient properly. You have to follow the graft functions, drug adverse reactions, infection, diabetes, cardiovascular disease, bone disease, glomerulonephritis, de novo or recurrent, and malignancy. Acute graft dysfunction, this is an important recommendation. We recommend considering the diagnosis of acute rejection as well as other causes of decline in graft functions. Not every decline in graft function is a rejection. And therefore, you have to stick by criteria of AKI and apply criteria of other diagnoses in order to know that this is a rejection or not, for which reason you have to take a graft biopsy to confirm the clinical diagnosis and score the degree of rejection by a Banff classification. We recommend that 2 cohorts of renal tissue should be obtained at transplant biopsy to increase the sensitivity of the investigation, like staining for C4D or other antiviral markers and so on. We recommend early testing for serum anti-HLA antibodies in patients with acute rejection, even if it looks like a T-cell mediated rejection, because there is no real cut-off line between these 2 types of rejection. Suggest testing for non-HLA antibodies in patients with biopsy evidence of microvascular inflammation, mostly glomerular or peritubular, without C4D deposits and negative serum antibodies. So sometimes you have to make this diagnosis even in sorry, even in the absence of C4D deposits. Chronic graft dysfunction, we suggest standard clinical laboratory and imaging workup to see the reason for chronic graft dysfunction. Suggest graft biopsy in kidney transplant recipients with non-obstructive progressive decline in kidney function. We recommend testing for anti-HLA antibodies in kidney transplant recipients with histological evidence of chronic active rejection. And we suggest staging of CKD because they flex on the conservative management of these patients who are eventually going to lose their grafts. You have to look for adverse drug reactions, particularly CNIs, by measuring the blood levels. Suggest routine checking for potential adverse reactions of the immunosuppressive agents. Infections, we check for previous known infection, a tuberculous patient or patient with chronic pyelonephritis and so on. So this has to be followed up because it can get reactivated by immunosuppression. There are detailed criteria in the guideline about checking for cytomegalo, for BK polyomavirus, for Epstein-Barr virus, and hepatitis C. You have to check in non-diabetic kidney transplant recipients and look for a new onset of diabetes. You may have to increase the dose of CNIs or dose of insulin for CNIs, mTORs, or corticosteroid therapy patients. You have to measure the blood pressure in every visit to the patient and make sure that the cardiovascular system is okay by assessment of cardiovascular risk and obesity, which tends to occur in patients on corticosteroids. Bone disease, you have to use the lowest therapeutic dose of immunosuppressive drugs that have a negative impact on bone health, measuring serum calcium and phosphate, measuring serum vitamin D and parathormone, and measuring bone mineral density. The frequency and methods are detailed in the guideline. Post-transplant glomerulonephritis is now a much more important cause of graft loss than chronic rejection. And these are the 4 types of GN that recur or develop de novo: mesenteroproliferative, membranous, FSGS, and IgA. And you can see the very high contribution of GGN compared to other causes of graft loss, up to 70% in mesenteroproliferative GN. And this shows the time of development of these types of glomerulonephritis. And you can see that focal segmental sclerosis is the earliest to start developing, as everybody knows. We suggest considering recurrence of the original disease or de novo glomerulonephritis in patients who develop proteinuria or other urinary abnormalities and or progressive deterioration of function. We suggest performing non-invasive lab tests, anti-PLAR, anti-GBM, ANCA, and so on, rather than obtaining biopsies very early in the course. We suggest obtaining graft biopsy when recurrence of the de novo GN is suspected or if sustained new onset proteinuria develops. There are so many malignancies that you have to consider. Unfortunately, we have tumor markers that can be used to make sure routinely to make sure that the patient has not developed the malignancy which is as high as 1% of all transplants and up to 25% in case of lymphomas. We recommend pre-transplant at least one annual post-transplant tumor screening by clinical examination, including dermatological and nodes, fecal blood, and tumor markers as per local guidelines. This should include chest imaging even before the transplant, screening for renal cell carcinoma for patients who are susceptible to develop it, like those on long-time dialysis, family history of renal cancer, acquired cystic disease, and analgesic nephropathy. Screening for bladder carcinoma in patients who have schistosomiasis, previous use of cyclophosphamide, or heavy smoking. Screening for hepatocellular carcinoma and kidney transplant recipients with cirrhosis prior to transplantation, particularly associated with HCV and HBV. Screening for bowel cancer in patients with inflammatory bowel disease. Screening for cervical cancer by pap smear, and breast cancer by clinical and imaging techniques. So, ladies and gentlemen, allow me to conclude. The Egyptian guideline is a consensus document derived from leading international resources coupled with Egyptian publications and experience. The guideline covers both surgical and medical aspects related to standard donor and recipient management. This talk is focused on the nephrologist's role. It highlights 5 fundamental aspects, namely vaccination, recipient risk categorization, individualization of immunosuppressive treatment on the basis of this risk categorization, antibody-mediated rejection, and post-transplant long-term monitoring. Thank you.
Actually, this is a very highly appreciable achievement performed by Professor Rashad Barsoum and the group who shared performing these guidelines. And I am sure, as in all guidelines, this will pave the way for building up on this first issue of the guidelines, to have it renewed probably every 2 years or every 3 years, according to the development and updates in science. I would have the comments of the panelists, please, about the recommendations about these guidelines. Dr. Ahmed Gaber.
Ahmed Adam, thank you, Professor. I got 3 tiny points. First of all, your group is inventing 3 points of clinical strength, 1, 2, 3, and the invention of number 1 is strongly recommend. I realize that you have the right to do though, but I don't know the reasoning in comparison to the other guideline, which just mention recommend and suggest. Do you have any example that strongly recommend will make a difference? The second thing is box 1, including plain X-ray, which to me, for more than a decade, it is obsolete. So I don't know why it is putting in 2020 or 2021. And the third one, which may be debatable, is a donor-specific antibody, which you make it 1D. Strongly recommend, although the evidence is very slim, to do it for all recipient of transplant. And correct me, my professor, if I am wrong. If the recipient is naive, not multibara, no blood transfusion, nothing, and he got a related donor, and I do cross-matching by many different things, I don't think there is a need to do it for universal recipient, although I accept that the immunological risk will affect the long-term outcome. And thank you very much.
I think the points you are raising, Professor Ahmed, are very strongly considered, and please have it written and give me your recommendations to discuss among the group to see how we can take in consideration changing these points you are mentioning. So I need it written, please, and we'll have a meeting, inshallah, with Professor Rashad to revise these points. Dr. Ahmed Fathy. دكتور دولت بعتذر حضرتك ممكن رجل حضرتك بس. لا هو لافف على رجل الدكتور دولت. حضرتك ارفعي رجليكي بس، ارفعي رجليكي. خلاص. السلام عليكم ورحمة الله. I'm very honored and pleased to be among the panelists and the magnificent lecture by Professor Barsoum. And I'm honored as well to be one among the reviewer of these guidelines. Actually, I would like to put some comments to be further taken on. We are now moving toward, if we are allowed to say, the marginal donors. And we should include the part about the risk stratification for the donor, because after all, our donors are all alive and most of them are young age. And we have to take in consideration what's going to happen to the donor. So we should include a donor risk stratification according to our Egyptian population and whether or not to accept the donor, even on
You mean before transplantation?
Before transplantation, of course.
And I think we need to have post-donation criteria or follow-up
yes,
as well.
Let's
consider having this together, because this is a very valid point.
Okay. The second thing is which I would put a point as you know, in the first session yesterday, we won the prize one for the best abstract, which was on MMF monotherapy on identical sibling transplantation, and they were never induced. So they have no induction, and they have only monotherapy from the start. So this point should be taken in consideration in our Egyptian population. Should we give, because we're not Caucasian after all. And in the guideline, in the Egyptian guidelines, we mentioned that only 2 haplotype identical Caucasian should be omitted from the induction. So should we give induction to all our patients with a full match from a sibling or from a mother with a full match?
So I believe full match is different than semi-identical, and we have experiences, in particular in children, that even with induction therapies, we get a high rate of rejections. So
in children, of course, because the immune system.
I mean, this should be considered not only considering the HLA and disregarding other factors of immunologic risks as well.
Yes.
So you need risk stratification, as Professor
of course,
his excellent talk yesterday, and as well individualization in special situations. And this is one of the points which I have written, that we need to have practice consensus points in addition to the guidelines.
That's good. So we have to address this point of induction to everyone. This is another point. The third point would be the start of a maintenance treatment, and this is a part of a philosophical point. Since we all have a pre-dated adjustment for the operation, and we have all liver-related donation well scheduled a long time before usually, why not to start a couple of weeks earlier instead of only 2 days? And the benefit would be that you would look for the side effects or the intolerance of the drug in those patients, and give more time for the steady state concentration to be in the blood of the patient. Previously, we used to be afraid from the early CNI toxicity when you put the graft and so on. But for example, for a standard patient, why not to start standard like we do for the people who are a little bit sensitized? You give him the triple immunosuppression therapy far behind.
But let me discuss with you this issue. We are considering practice guidelines.
Yes.
What you are mentioning is a different protocol for assessment. We need to assess this different protocol before considering it as a guideline. So this is a bit different from the guideline issue.
You know, I mean, because Professor Barsoum mentioned that they recommend or suggest starting the maintenance treatment at or before by 2 days. This was a mentioned statement in the guidelines.
This is a different issue from starting before 2 weeks before transplantation. This requires an assessment protocol, which to be considered different from the already ongoing guidelines.
Okay.
The other one would be what is the rationale for starting the classical triple immunosuppressive therapy for everyone for the first 3 months, because we know that some of the complications would happen in the first 3 months, like for example, CMV infection, like herpes simplex, like even early post-transplant diabetes with huge doses of steroids and the CNI. So if we're going to taper down because of level E in the risk profile of the patient, or for very, very low immunological risk, we should not emphasize that everyone should receive triple immunosuppressive therapy for 3 months.
I believe we should add to this point in particular an individualization factor. We need
Yes, individualization.
You should add it to this aspect. We need to have
I'm
these
rich- I'm-
points, and we
I've
will have a
taken this in
meeting to
point.
revise all these.
Yes, maybe
points,
the
please.
last point is,
Yes.
should we have a statement about including DQ? Because not all the labs are addressing the HLA typing in full, specifically when we are looking for the DSA and we're having value of the DQ as a TSA. And so should we address it as a point for the labs?
I believe this is a very important point, but we should not generalize it. So we might consider having in retransplantation or high-risk individuals to perform the DP and the DQ, and probably introduce an HLA matchmaker, but not for the general transplant population.
For the highly sensitized.
You can't generalize this in our Egyptian transplantation practice. You can have it in a specialized situation for individualized situations as well. In high-risk individuals for retransplantation, you can recommend it for a special category, but not as a general practice. الميكروفون للدكتور محمد صلاح أو
CW as well.
Yes, whatever you can.
Now is about, and also we can add, or consider the DQ or CW or all other antigens like these antigens. If you have it in the PRA pre-transplant, I mean, if the patient have DQ sensitized to DQ or CW or whatever, we should look for it. I mean, it's not.
This is what I'm mentioning, that in special situations we can have this recommendation, not for the general transplantation practice. I can't ask from all the candidates for transplantation to perform the DP, the DQ, and all the procedures.
But all of them should perform PRA. So when you perform a PRA and you have a positive DQ or a positive CW, you should search.
This is the special situation I'm speaking about, but you should not make it. You should not perform it for all cases preliminary.
Not for the. Yes. With the PRA.
Probably you can have these points written to be considered, and we might discuss it with our clinical pathologists.
And maybe
as
this
well.
might answer Dr. Ahmed Adam's question about should we perform a PRA for everyone? Yes, we should.
PRA, I think yes.
Dr.
PRA
Ahmed
assessment.
was wondering about this, I think.
Yes. Can I comment?
Uh-huh.
Correct me if I am wrong. If you got a very naive recipient and this patient has no blood transfusion, nothing to make it immunologically vulnerable, and you got a related donor, and you do the cross-matching by whatever mean, Luminex, flow cytometry, and all is good. So why to do PRA for every patient?
Because
although I accept that the high PRA will make it immunologically vulnerable, but this patient, particularly from this donor, will not be vulnerable.
actually we've seen يعني a good deal of patients. طب ثانية واحدة بس يعني we have seen a lot of patients who are naive and first transplant and never had pregnancy and never had males كل الحاجات دي, and then you still find them to have a PRA and for unknown reason. Yes, this is very common على فكرة. It's not less than 20 to 30%.
Can I just something picking it up from the DQ? there's a very simple way to assess the risk stratification when we get the HLA matching, which is the difference between the broad antigens and the split antigens, which is already in the panel. It was found that if you consider just with broad antigen compatibility, is very different from considering the split antigens. There's a big difference, and we sort of disregard split antigens, which could be quite important. This is one thing. The other thing, I strongly believe that to categorize a patient from the first is by the panel reactive antibodies. If he's above 80, forget about him. Below 20, he's okay. And in between, we will discuss induction or not. Another thing was what mentioned is the calculated panel reactive antibodies. This is in the cadaveric programs. They do not fit in our living programs. And they have a big data of the HLA, of the antigens of the population, which is different from one country to another. Anyway, we should depend on the wet cross-match, definitely, and the MFI and RIS. This is very easy and doable.
I believe performing a PRA cytotoxicity screening is important for every case, and if any percentage is present, you should go to the donor-specific antibodies, probably with all the details, DP, DQ, the CW4, whatever. But this should be one of the important screening points, not to put the patient at any risk, even if he is transplant naive. I hope you can have all these points, please, written and deliver it to me. I will pass it to Professor Rashad and consider having a revision for the next wave of the guidelines. And I think this was a very beneficial, fruitful, and breakthrough achievement in our Egyptian practice. I would express my sincere gratitude and appreciation to Professor Rashad Barsoum for this great achievement. My appreciation to all the panelists for sharing their ideas and the very valuable contribution. And let us close this first session and move to the next session and switch the chairpersons, please.
عامل ايه؟ كويس منور. انا بقينا اشوفك في المظاهرات اول مره. ايوه عارف. ايوه. بس والله ما اعرف بس يعني انا بشوف ماشي كلمته ما ردش وهنتكلم مع بعض ما تقلقش يعني مش نقطه بيج ديل يعني مش مهم قوي
صباح الخير.
متحف الحضاره ايوه no I've been there اول ما فتحوه انا معيش عارف I've been there بس اصلا كنت خايف I'd love to, بس لا لا انت ما كنت نمت خلوني انام ساعه تفرق معاك
انا انت بايت هنا صح؟ انا جاي البيت بتاع البيت.
طيب يلا يا جماعه فين مين تشير بيرسون تاني؟ دكتورة هديل جمال الدين مش موجودة؟ ودكتورة منال الديب، شريف مجاور، وحيد دوش. طيب احنا for the sake of time we'll start the session وبعدين الأساتذة ممكن تجوين. دكتورة هديل اتفضلي. ازيك؟ بسم الله الرحمن الرحيم. We'll start the second. قربي عشان المايك وكده وتبقي معانا في وسط خايفة من الكورونا ولا ايه؟ We'll start the session, the second session for today, to be transplantation in COVID era. I will have the honor to moderate this session with Dr. Hadil. Dr. Hadil, hepatologist, professor of hepatology. احنا هنمودريت السيشن ومعانا Professor Mahmoud Amara, Professor of Internal Medicine and Nephrology, Menofia University, as a chairperson. As we all know, Yani, we are in the COVID era, and we've seen how it affects the practice generally, and especially in transplantation. And I had the pleasure to be the chairman of the committee of nephrology in the higher committee for COVID in the Egyptian Ministry of Health. We put the Egyptian guidelines as early as April 2020, when the pandemic was declared by the WHO. And ever since, the protocol has been revised over and over, and we changed a lot of the protocol ever since. I mean, the protocol for transplant population who got COVID or during the COVID era. We all know that in the first few months, first 3 months maybe, we all, I think, worldwide stopped or hold the protocol, the transplant programs. We did not have enough data about the spread of the disease, the amplitude of the disease, how to deal with the immunosuppression. But we built up data over and over. Even the results of our patients who were infected with COVID in the first era was very bad. Some reports in the US reported that 30% of transplanted kidney transplant recipients who were COVID positive was dead because of the disease. The mortality reached up to 30% in the US in the first few months. But I think now all of us gained enough experience to protect our patients. The mortality now is much less than what we used to have in the beginning. And the data is building up, and we are improving our practice over and over. So we'll start the session now. Dr. Mahmoud will start the session. Introduce.
I would like to express gratitude, thankful for all the organizing committee for this good and first together an African transportation committees, and we'll start actually this session with Dr. Prof. Ahmed Hassan, COVID vaccination, kidney transplant population. Go ahead.
Thank you for my invitation today to present this lecture. I am Professor Dr. Ahmed Hassan, Head of Nephrology Department in National Institute of Urology and Nephrology, and أنا عضو مجلس العلمي لزمالة الكلى المصرية وعضو مجلس إدارة الجمعية المصرية لأمراض الكلى والجمعية الإفريقية لأمراض الكلى. So I will start today.
أحمد قرب المايك شوية لو سمحت
update of COVID-19 vaccination renal transplantation. So our agenda today identify the physical organism and its major structure protein, enumerate its mode of transmission, clarify clinical manifestation, precautions, diagnosis, and management, and define COVID-19 vaccine type characteristic, and explain proper vaccine for renal transplant recipient timing, doses, and efficacy. So this schematic structure of COVID-19 and its major structure protein. Here is protein which is important for the entry of the virus to the cell, and as regarding the M protein, membrane protein, envelope protein, which is responsible for the virulence of the virus, and the nucleocapsid RNA, which is important for transcription and replication of the viruses, and protective lipid bilayer for protection of this virus. So what about the origin of coronavirus? It is usually origin from a bat with intermediate host. We have 3 outbreaks initially in 2002 with severe other respiratory stress syndrome, which is occurred in the Far East 10 years after. Middle East respiratory stress, which is occurring in Saudi Arabia, and the intermediate host is the camel. And after 7 years, third outbreaks in COVID-19 in Wuhan in China. Another breaks may be happened later on. So the mode of transmission from human to human, usually droplet infection, small droplet or large droplet, direct contact with contaminated surfaces. Another accidental laboratory exposure, blood transfusion, organ transplantation, and transplacental, all of this mode of transmission of COVID-19. So after exposure of the person to COVID-19, the incubation period mean from 5 to 6 days may be extended from 2 to 14 days. And viremia occur in the first week after exposure, and to coming down on the next second week after initiation of symptoms. As regarding the antibodies started from the middle of the first week and to increase steadily to increase to reach maximum after 2 weeks to 3 weeks after the initiation of symptoms. The severity of the COVID-19 may be mild to moderate illness or severe or critical illness. For mild illness from symptoms, starting with symptom or onset of the symptoms, take 10 days to clear the patient from the disease. Sometimes some person complicated and need hospitalization, especially in the second week, early in the second week, and may be complicated with shortening of breath, other respiratory distress syndrome, and even for need ICU admission and ventilation. This figure showing how the virus enters the cell. This can be happened by S protein when attached to the angiotensin converting enzyme to receptors and facilitate the adhesion of the virion to the cells through transmembrane proteins, and then phagocytosis in the cell and entering the cell, and then takes the sequence for replication and transcription. So the most important manifestation of COVID is pulmonary, of course, but extra pulmonary manifestation can be having neurological, ocular, and dermatological, cardiovascular, liver, renal, and gastrointestinal can be occurred also. So regarding the risk factor for the prognostic for severe disease or admission on ICU or mortality, many factors affected under that condition is the form of old age, hypertension, diabetes, cardiovascular system disease, chronic obstructive pulmonary disease, malignancy, obesity, and maybe according to the presentation and laboratory markers, high fever more than or equal to 39 degrees degree, and dyspnea on admission, markers like leukopenia and raised LDH, C-reactive protein, ferritin, interleukin 6, and D-dimer and angiotensinogen enzyme 2. So how to diagnose? This is clinical suspicion for suspected cases or probable case or confirmed case. CT is very important for diagnosis of COVID infection, 19 infection. To the CORAD 4, this is high suspicion, CORAD 5, very high suspicion, and CORAD 6 is confirmed. And as regarding PCR, COVID-19 PCR, it is sensitivity around 70%. So repeated tests is needed at least 48 hours to 72 hours repetition for sure diagnosis, if it is positive. Immunoassay for antibodies started after 2 weeks from the onset of the disease to 3 weeks from the onset of the disease to get a positive result. So this is diagnostic diagram for the detection of acute COVID-19 infection in individual with clinical suspicion for COVID or asymptomatic one. Preventive measure for COVID is very important with as regarding wearing mask or stay 6 feet apart, at least 1 meter, but better 2 meters the distance, and avoid crowdedness together with respiratory etiquette, hand and environmental hygiene are a vital element for prevention. The most important for prevention or decrease the severity of the disease is vaccine, COVID-19 vaccine. What about the vaccine? Vaccine is an inactive form of a disease causing germ that is intentionally introduced to the body and help a person build up immunity to an infectious disease. It stimulates the immune system, production of antibodies that help to protect the person from future infection if he ever comes across the real germ. So the ideal COVID-19 vaccine or ideal vaccine should be safe, long-lasting, protect against disease, administer a single dose, produce in large quantities, and easily stored, transported, and administered. For any vaccine should be passed through preclinical stage and many phases, phase 1 and 2 and phase 3 till approval. So when we see here in comparison COVID vaccine to classical vaccine, there is a period of shortage of period regarding the phases up to 6 months in comparison to the classical vaccine. This is because it is pandemic and dangerous. So it is taking approval from many societies all over the world. So the summary of strategy types of COVID-19 vaccine may be a vector, a viral vector, and inactivated virus, subunit viral protein virus, like particle and messenger RNA and DNA vaccines. So what about the immune response to vaccine? When a patient is exposed to the virus, it is engulfed by antigen-presenting cell and to be presented to T helper cells. And T helper cells will activate cytotoxic cells that will give active or cytotoxic cells which kill the infected cells, and also give memory cells to be reactivated when re-exposure to the same virus. And also T helper cell will activate B cells which will maturation to plasma cells with secreting antibodies and giving memory B cells, and memory B cells, this will be reactivated when exposed to the same variant. The most important vaccine known in Egypt will concentrate on it. Pfizer vaccine, Moderna, and Johnson & Johnson. This is vaccine time messenger for Pfizer and Moderna messenger RNA, and replication incompetent adenovirus type 26 vector for Johnson & Johnson's vaccine. It is given age for Pfizer more than and equal to 12 years is accepted now, and for Moderna and Johnson more than 18 years. It is given in 2 doses for Pfizer and Moderna, and 3 weeks for Pfizer interval and 1 month for Moderna interval. It is well tolerated for all patients. Side effect is very minimal. Only injection site pain, redness, swelling, tiredness, headache, muscle pain, joint pain, sometimes fever. This is most common side effect for all vaccines. So another AstraZeneca vaccine, Oxford University, AstraZeneca, Sinovac, Sinopharm vaccine, Sputnik vaccine from Russia. This is for AstraZeneca, 2 doses, 4 to 12 weeks apart, and 2 doses for Sinovac, Sinopharm vaccine 3 weeks apart, and for Sputnik vaccine 2 doses, and all accepted for more than 18 years or equal to 18 years. And regarding Oxford University AstraZeneca vaccine, types seismic with weakened version of cold virus for home chimpanzee, and this is incorporated to it a small part of viral messenger viral RNA, which encode the S protein after its multiplication, and then injection to the body to induce immunity. For Sinovac and Sinopharm, it is inactivated the coronavirus that cannot replicate in human cells. And for Sputnik vaccine, adenovirus vector-based platform of technology delivered for genetic instruction for COVID-19 antigen to patient cell triggering immune response. So the summary for the result for COVID vaccine trial efficacy, most important for efficacy preventing clinical COVID or efficacy for preventing the severe COVID. Preventive severe COVID, most of these vaccines giving 100% efficacy for preventing severe disease, and for efficacy for preventing clinical COVID, the most important is BioNTech Pfizer, 95%, Moderna, 94%, Sputnik vaccine from Russia, 92%, and even Sinopharm, 79%. So American Society of Nephrology recommendation for post-transplant donation vaccination, COVID-19 vaccination should be given for all transplant patients more than or equal to 12 years. Messenger RNA vaccination is a preferable, and protective measures should be taken even after vaccination or infection. Vaccination of COVID-19 in patients who have recovered from 19 should be given, and for checking antibody response to the vaccine, this is not recommended. This figure showing antibody response and serial response to a vaccine in transplantation versus control, normal persons. There is significant lower response for in transplantation regarding antibody response and serial response in comparison to control. As regarding the dialysis and transplant patient comparison for antibody response and T-cell response, on dialysis, it is much better or significant higher in dialysis than transplant patients. So better to giving vaccine in before the transplantation than after transplantation. This figure shows the prevalence of COVID-19 antibodies and the antibody titer before and after vaccination. Here, we check here that the antibody is highly significant higher after 1 month from the third to before first, second, third dose. Even titer after 1 month after third dose is much significant higher before first, second, third dose. So it is recommended to give third dose for all patients. American Society of Nephrology recommendation post-transplant organ donation, pre-transplant patient vaccination completion at least 2 weeks prior to transplantation, post-transplant given from 1 to 3 months after transplantation, third dose is recommended for messenger RNA vaccine. Routine adjustment of immunosuppression medication prior to vaccination outside the clinical trial are not recommended. This suggested vaccination approach for protection against COVID-19 in renal transplant patient. This for prognostic and mortality. Procalcitonin more than 0.3 milligram per liter, or troponin more than 20 nanogram per liter, or the D-dimer 100-500 unit per liter, serum creatinine more than 150 micromole per liter, or CRP more than 50. This is prognostic and can give an idea about the severity of the disease. The therapeutic, it's usually concept is from entry to the cell or viral application or host immune response. For a summary, a monoclonal antibody in the form of scarzirivimab and imudivimab and sotrovimab, antiviral in the form of favipiravir or remdesivir in severe cases can be given. Steroid, according to the CAPI study, can be given in severe patient and hospitalized in ICU or ventilated person. Convalescent plasma can be used. Tocilizumab and sarilumab this can be used in severe cases. Also not recommended for chloroquine, hydroxychloroquine, and colchicine, ivermectin. For management of immunosuppression can be happened if there is no recent rejection episodes and severe COVID. We can decrease the dose of calcineurin inhibitors. mTOR can be distilled, continue and give corticosteroid therapy. This suggested algorithm for management of the COVID-19. 2 minutes. Suggested algorithm for the management of the COVID-19 positive kidney transplant. This, if patient have COVID-19 infection, who can isolate according to the symptoms. If it is asymptomatic, we consider decreasing the dose of antimetabolites, and mildly symptomatic antimetabolites to be stopped and maintain CIC and mTORs on a lower level. Start low dose if the patient not on steroid and give him monoclonal antibodies. In moderate symptomatic, stop antimetabolites, keep CNI mTORs on lower level. High dose steroid and monoclonal antibodies can be given. Severe symptomatic, stop immunosuppression. High dose of steroid and remdesivir can be given. Full clearance of the patient who had should be for mild to moderate disease, 10 days is enough, and for severe disease, 20 days for clearance patient from the hospital after getting infection. If transplant recipient with reports of COVID-19 risk for infection is rare, this is due to immune response to the primary infection of mutant virus. For COVID-19 and organ donation, living donor who has been high risk or exposed to someone diagnosed or evaluated for weird infection, postpone donation from 14 to 28 days after returning. Our message, SARS-CoV vaccination in all organ transplant recipients should be given more than 12 years. A messenger RNA vaccination is preferred for a transplant patient. Pre-transplant patient vaccination completion at least 2 weeks prior to transplantation and can be given post-transplant 1 to 3 months after transplantation. COVID-19 should be continued practice transplant recipient after natural COVID-19 infection or vaccination. Third dose of messenger RNA vaccine is important. To postpone donation for 14 to 28 days for living donor who have been a high risk area or exposed to someone diagnosed or being evaluated for COVID-19 infection. And thank you for your attention.
Thank you very much, Dr. Ahmed. Any question on the floor?
Thank you, Dr. Ahmed, for such elegant presentation. Can I have a Dr. Ahmed? أنا هسألك سؤال بعد. You mentioned that the immune response in the transplant patients is much lower than normal subject or even those on dialysis. So apart from the third or the booster dose, is there any further measure that we may use or any factor to be added to improve the response, or is there any timing preferred to give the vaccine post-transplant if you did not give him pre-transplant?
This studies done for 2 doses as regarding comparison between the normal population or even dialysis. This is on 2 doses. So because the antibodies, so what increase the response, we can give a 3rd dose, because 3rd dose for renal transplantation, after giving 3rd dose, as we mentioned before, after 1 month, there is marked significant increase in antibody titer after the 3rd dose. So this is a recommendation for CDC to give a 3rd dose for vaccination after 6 months from 2 doses given, after 6 months from the last dose of the 2 doses given before, and this will improve the antibody response for these patients.
There's anything you do with immunosuppression to improve the response?
Recommendation before. So this is research, not recommendation.
Yes.
CDC inform not يعني guidelines not recommend to adjust medication أو immunosuppression. ولكن في in some researches they mentioned as individual patient you can adjust, especially the anti-metabolites to decrease the dose to improve and even you can give 3 months after transplantation the vaccination. Because after 3 months you can adjust the immunosuppression coming down to the lowest one and so on.
There's a question online. Can you put it on the screen, please? Oh, Ahmed. Yeah. When we can give the booster dose, the booster dose.
This is what we mentioned before. We can give after 6 months from the second dose, after 6 months after completion of second dose of vaccination, primary vaccination.
After COVID infection.
After COVID.
After recovery. Patient has
This is the this is you told booster dose after recovery. If the patient have infection after recovery, you can give after 3 months. 3 months, from 1 to 3 months. Yani this is recommendation. But if you give a vaccine, you can give 6 months after the last dose of vaccine, primary vaccine.
أنا بس I want to
تفضل.
comment على the question here was when you can give the booster dose, I mean the third dose, after concurrent infection.
Concurrent infection after 3 months. We can give
concurrent infection. Since you have 2 doses and you have an infection, this is considered the booster dose.
Usually, if you have a current infection, you don't need the booster dose except after 3 to 6 months. The answer here is when you can give the booster dose, you start vaccination. You can start vaccination. The last literature, maybe 3 days ago, you can vaccinate 2 weeks after ending the infection. Now, 2 weeks. Start the vaccination.
At least 1 month, not 2 weeks. I will give me my presentation.
استنى بس يا أحمد. أنا لسه قايلها امبارح.
طيب عموما بما ان دي حاجه لسه ريسنت احنا هنبقى we can revise.
لا I can give this is the plan. This is written in the plan.
عشان for the sake of time دكتور احمد
لا هجيبها لك
احنا will stick to the guidelines اللي هي 1 month. اذا نزل new guidelines we can modify it later.
1 dose of messenger RNA vaccine at least 2 months after COVID virus infection. 2 months. This is what is written as the suggested vaccination approach for protection against COVID in kidney transplantation. So if you give 2 doses, at least 3 months after transplantation, this is 2 doses per dose after 6 months. But if the patient have an infection, you can give him another dose after 2 months at least.
Okay. Thank you دكتور احمد. Thank you. هو احنا الدكتور حسين فيشاوي معانا اونلاين ولا ايه؟
انا معاك اونلاين يا محمد. ايوه انا معاكم اونلاين.
اوكي ازيك دكتور حسين؟
ازيك دكتور محمد؟ انا بس ممكن بس
هل في تشير بيرسونز؟
بقول ان انا اعمل شير سكرين.
بليز. في تشير بيرسونز الدكتوره منال الديب او حد من التشير بيرسونز الاخرين؟ لا بكلم نفرولوجي مفيش حد منهم يعني احنا هنقدم. طيب اتس ماي بليجر. دكتور وحيد دوش موجود. اهلا وسهلا دكتور وحيد. دكتور شريف
اهلا بيك ازيك؟
انا تكونوا معانا
زي الحال.
اهلا بيك. احنا we'll start to move to the next speaker. Pleasure to introduce my dear colleague Professor Hussein Fishawi. Professor Hussein is Professor of Internal Medicine and Nephrology, Cairo University, and Professor Hussein was among the committee that put the Egyptian guidelines with Professor Hisham Al-Sayed from Ain Shams and myself. And Professor Hussein is well known for his very scientific and meticulous revision. He will speak to us about optimization of immunosuppression in kidney transplant recipients with COVID infection according to the Egyptian guidelines. هو طبعا احسن حد ممكن يكلمنا عنها لانه هو اللي حطها يعني. اتفضل دكتور حسين.
Thank you, my dear Professor Dr. Muhammad, for your kind invitation for me today, and for my dear Professor Dr. Gamal Saadi for his kind invitation for me to be with you today to speak about the hot topic of this era, which is kidney transplant recipients and optimization of the immunosuppression for this type of population. As my dear Professor Dr. Muhammad, I was really honored to be one of the committee for guidelines for management of COVID-19 infection with Professor Dr. Muhammad Salah and Dr. Hisham Said.
Dr. Hussein, can you make it full screen, please? The presentation, can you make it full screen?
Please, 1 minute. Okay. I was honored to be with my dear colleague and dear Professor Dr. Muhammad Salah and Dr. Hisham Said to be of the committee that have introduced the guidelines for management of COVID-19 infection in kidney population in AKI hemodialysis and transplant patients. And this is about the entity of course, kidney transplantation, but I'll not speak about the whole guidelines of kidney transplantation because of the time factor. Why we have applied guidelines for COVID-19 in kidney transplantation?
Hussein,
Because
you're still not on full screen mode. Can you?
This is full screen?
No, not yet. طب دوس F5 بيقول لك.
Full screen. This is now full screen.
جرب F5 F5.
Is this full screen now?
No.
شغل طيب البرزنتيشن وبعدين اعمل ماكسمايز، خليه يعمل ماكسمايز. اعمل ماكسمايز من فوق. يعني شغل البرزنتيشن.
شغل واعمل ماكسمايز من فوق كده.
كده فول سكرين ولا نوت فول سكرين؟
No.
This full screen يا دكتور محمد؟
لا لا خلاص لو مش نافع خلاص كمل بقى كده. خلاص عشان الوقت كمل يا دكتور حسين. خلاص هنشوف كده لو عرفت تعمل.
This full screen؟
No but عشان الوقت كمل بليز يا دكتور حسين كمل خلاص.
I will rescreen the
كده انت خرجت خرجت خالص. Share again, please.
Okay.
ايوه كده تمام تمام.
Full screen?
Yes. Yes.
Okay.
اتفضل.
COVID-19 mortality hits almost 30% in kidney transplant patients, so that we are dealing with a great problem. And in the era of COVID-19 infection, kidney transplant have made a great burden. As we can see in this study, COVID-19 infection in kidney transplant patients can cause severe illness requiring ICU admission with high rate of AKI, and prompt reduction in immunosuppression is required in severe cases. Older and diabetic patients may be at a higher risk. COVID-19 may pose great risk to transplant recipients and their contacts, and this have raises that very serious concern about the safety of transplant patients in this outbreak. As we can see in one study of medical center, 28% of cases have mortality rate, and in another center in New York, they have found that nearly 1/3 of these patients died from their infection with COVID-19, and 39 of the patients proceed to be put on mechanical ventilators, and nearly 2/3 of these patients, of ventilated patients, have passed away. This is a very important article in the New England Journal of Medicine, have shown then the impact of COVID-19 on kidney transplantation, as they have mentioned that mortality rate reaching 28%, mechanical ventilation intubation 39%, death after intubation 64%, the requirement for renal replacement therapy about 21%, remained hospitalized 43%, and discharged from hospital 36%. So that what a great mortality rate and great morbidity and great burden for these transplanted recipients. What about the guidelines of kidney transplantation during the COVID-19 pandemic? As we know that, by analogy with other infectious diseases, it is considered that kidney transplant patients under immunosuppression are at a higher risk of poor outcomes. It is important to note that information about this disease and our understanding of this virus and its impact on transplantation is evolving rapidly, so the guidance may change over time. As we know that lymphocyte count was low, and these patients may require ICU care. It is not possible to tell if lymphopenia was a manifestation of a more severe form of disease or if it is predisposed to severe disease, as many transplant recipients have medication-induced lymphopenia. Particularly, those attention should be paid to transplant patients with suspected or confirmed COVID-19 infection who are lymphopenic, because they have higher risk for mortality and morbidity. What about the recommendations? As we know that when we have introduced the guidelines, the aim of these recommendations was protection of the kidney transplant recipients, protection of the kidney transplant program, protection of the kidney transplant donors, protection of the kidney transplant healthcare providers, protection of the kidney transplant center, reduced burden of the healthcare, protection of the community, adequate care of kidney transplant recipients, modulation of immunosuppressive therapy in COVID-19 kidney transplant recipients, protection of contacts of kidney transplant recipients, and modification of drug doses according to drug-to-drug interaction. This was the whole guideline, so that it's impossible to speak about that for the time factor. Here, I will stress about the modulation of immunosuppressive therapy in COVID-19 kidney transplant recipients. As we know that for transplant centers, outpatient clinic visits that are not critical should be either deferred or substituted with telemedicine. Visitors should be restricted as much as possible to transplant floors. Specify team members who may be impacted with suspicious transplant recipients. So it's very important to develop guidance for candidates and recipients, medication, including limiting exposure to large crowds, hand hygiene, and avoidance of sick exposures. Staff and facility should be prepared to receive suspicious patients. They should develop guidance for which suspicious transplant recipients need evaluation, testing, and management by the transplant center versus which can remain at home with close remote follow-up. For transplant recipients, should avoid, of course, travel and, of course, overcrowded areas. Transplant recipients with higher incidence of infection, those within contact with COVID-19 infected people or within 14 days prior to the onset of the disease, history of travel within 14 days, in contact with patients who have fever or respiratory symptoms. They should avoid elective clinic visits. Suspicious transplant recipients should be instructed to call the transplant center and avoid presenting to the clinic without notifying it in advance to avoid inadvertent exposures. They should be examined clinically, laboratory, and radiologically according to our national policies and international policies to exclude or confirm COVID-19 virus infection. As we know that these patients are receiving immunosuppressive therapy, such as the steroids, which is dexamethasone, prednisone, which is responsible for inhibition of lymphocyte gene expression. Its immunological outcome is suppressing cytokine form, prohibition of pro-inflammatory cytokine production, preserving the permeability and integrity of the endothelium. They are receiving antimetabolites such as MPA and azathioprine through blocking DNA replication, which diminished immune response in vitro, and calcineurin inhibitors such as cyclosporin and tacrolimus with inhibition of lymphocyte signaling. So the outcome is selective inhibition of cytokine production and function. mTOR inhibitors, sirolimus, everolimus, which is the mammalian target of rapamycin or rapamycin, inducing and cycle cell arrest in lymphocytes. Biologics such as interleukin-2, daclizumab, and interleukin-6 inhibitors, tocilizumab, act as anti-cytokine antibodies, inhibiting the production of cytokines and thus alleviation of cytokine storm. Let us see the impact of these drugs in the era of COVID-19. For the corticosteroids, we are really impressed by two issues: the viral load and viral replication, and the clinical outcome. As we can see that for corticosteroids, cohort studies regarding viral load have different results. 5 cohort studies found that steroid use have no effect on SARS-CoV-2 clearance time. 3 cohort studies report that steroid use associated with longer SARS-CoV-2 clearance time. All studies have high risk of confounding by indication. So that one randomized control study found that dexamethasone use was associated with lower 28-day mortality rate, shorter length of hospital stay, and lower prevalence of mechanical ventilation. Limitations, open label observation studies have different results. 6 cohort studies have found that steroid have a beneficial effect, while, which is most of the studies, 2 cohort studies conclude that steroids have a detrimental effect, and 1 cohort studies report that steroids have no effect on mortality. What about calcineurin inhibitors? For viral load and viral replication, no evidence available, but in the case of SARS-CoV and MERS-CoV, the cyclosporin A inhibits the replication of SARS-CoV and MERS-CoV in vitro. TAC, which is tacrolimus, inhibits the replication of SARS-CoV in vitro. In spite of being inhibiting the viral replication and the viral load, which may be beneficial, but really there's no evidence available data for the clinical outcome. But according to the measurement, to the experience, the previous experience in infections, it is not recommended, of course, to give these drugs or to reduce them, as we can see later, because they will, of course, they are inhibiting the replication of the virus, but they are inhibiting the immune system of this population, which is the transplant population. The mycophenolic acid, the MPA inhibits SARS-CoV-2 replication in vitro. The MPA does not inhibit the proteolytic activity of SARS-CoV proteolytic enzymes. SARS-CoV replication in vitro. MPA inhibits the proteolytic activity of MERS-CoV. And so, as we can see, they have beneficial effect in inhibition of the viral load, inhibition of these proteolytic enzymes of these viruses and their invasive techniques. But on the clinical outcome, there is no evidence available data for this process. 1 cohort study found that MMF use was associated with lower mortality rate, but there is significant risk of confounding because they are inhibiting the viral replication, but they are, of course, making severe inhibition of the immune system, which is more deleterious than the benefit of inhibiting viral replication. What about thiopurine analogs? No evidence available data, but the azathioprine and 6-TG inhibit the periodic activity of MERS-CoV, but the same, there is no evidence available data, but of course, about measurement regarding previous experience in infections, it is not recommended, of course, to increase the doses because, of course, they will make suppression of the immune system. What about the mTOR inhibitors? There is no evidence data that about viral, of course, replication. Apart in MERS-CoV, sirolimus and everolimus reduce, of course, replication of the virus, but on the clinical outcome and the clinical ground, it is not advocated, of course, for these drugs because they are making marked immunosuppression for our patients. For the anti-TNF alpha agents, as we can see, about viral replication, there is no evidence about that, but in animal study, administration of this drug monoclonal antibody have no effect on mortality rate, but the onset of symptoms was somewhat delayed. What about the anakinra? Anakinra, in human study, there is no evidence about viral load and viral replication, but in 1 cohort study in patients with COVID-19, they may be used in case of ARDS and hyperinflammation because the use was associated with a lower 3-week mortality rate, but a longer duration of mechanical ventilation. Of course, there is a debate about this drug because it may help in the cytokine storm, but it may have the effect on the patient life regarding the aggressive immunosuppressive effect. What about tocilizumab and other interleukin-6 inhibitors? There is no available data about viral load and viral replication, but 1 retrospective cohort study found that treatment with tocilizumab may be beneficial in case of cytokine storm if we have high, of course, ferritin, high interleukin-6 more than 3-folds, and they may help in improving of the survival rate and reduction of mortality and ventilation and mortality rate. According to the radiological finding in transplant patients, as we can see, about 30% of the patients may have, of course, ground glass appearance, and of course, in this situation, paving and consolidation, while 48% may have, of course, paving and 4% only consolidation and 9% ground glass opacities and gracy paving and 9% only ground glass opacities. As we can see, this was the behavior in transplant centers all over the world. Most of the centers have making reduction and withdrawal of MMF. Also, most of the centers have making reduction and reducing dose of mTOR inhibitors. Some of the centers have reduced the dose of tacrolimus, and with improvement of the condition of the patient, they have reduced the doses later on. But when you are speaking about the guidelines, we should stress about not all the patients the same management, because we have high-risk patients, such as those above 70 years old, comorbidities or risk factors such as diabetes, cardiac or pulmonary disease, heavy smoking, obese patients, reduced kidney function with reduced GFR below 30 milliliter per minute, lymphocyte depletion therapy with PVA 3 to 6 months. What about the guidelines? This is the latest version of our Egyptian guidelines. And as we can see here, this is about our recommendations. When we have confirmed COVID, totally asymptomatic, just swab positive.
دكتور حسين لا يعني هو ايه قطع ولا ايه؟ اديني افتح لي بس دقيقة.
تمام كده الصوت كده واضح؟
بص يا حسين احنا كده الوقت
انا خلاص انا فاضل دقيقتين يا دكتور محمد وخلص خالص. ده الدياجرام الاخير.
كده خلاص الوقت خلص. دقيقتين بالظبط. ها؟
دقيقتين بالظبط. For cases who have confirmed COVID, if we have asymptomatic patients without any symptoms or any signs, just swab positive, no change of immunosuppressive therapy. For mild disease with no evidence of pulmonary infiltrates, here one of two options. Some recommended no change in immunosuppressive therapy, while others have recommended for triple therapy patients to reduce or stop MPA as mTOR and maintain on dual therapy. For dual therapy, to continue dual therapy. For dual therapy, steroid-free. For CNI plus MPA or mTOR, we should change MPA or mTOR for low-dose steroids. And for double therapy, MPA and mTOR, we should change one of them to low-dose steroids. If there is no clear improvement over 3 to 5 days, CNI reduced reduction. But if we have mild disease, but with pulmonary infiltrates, here we should try, of course, to reduce or stop MPA or azathioprine or mTOR, and to make our patients on dual therapy and to continue dual therapy, CNI and steroids. If there is no clear improvement over 3 to 5 days, CNI dose reduction with target of our tacrolimus level 46 nanogram per milliliter. While if we have moderate disease with lung infiltrates, but still we have a good oxygenation, but with tachypnea, we should ask, are these patients high risk or no? If there is not high risk, only to stop MPA or mTOR, dual therapy CNI and steroids, and making the target of CNI levels, cyclosporin at 50 to 100 nanogram per milliliter and TAC 4 to 6 nanogram per milliliter. But if we are really high risk, of course, stopping the MPA as a mTOR and stop CNI and increase the steroids in this situation. For severe disease hospitalized patients who are hypoxic, tachypnic, and of course may be in need for ICU, discontinue all immunosuppressive drugs, increase start steroids at a higher dose. For higher risk of rejection, you may increase the dose of steroids, but consider to continue with low dose CNI. Here steroids, you may give dexamethasone 6 milligram per day or methylprednisolone 1 to 2 milligram per kg per day divided on 2 doses. When to resume immunosuppressive therapy, usually we consider that 5 days after clinical resolution, and we can resume the full dose of calcineurin after 14 days of onset of symptoms and 3 days of a fever, and consider later on for reinitiation of MMFs, azathioprine, and mTOR inhibitors. Take home message for our asymptomatic or mild moderate symptoms patients. Of course, they should be quarantine these patients. We should, of course, consider reduction or halving the dose of antipruritives. We should start ivermectin or the monoclonal antiviral antibody, which is pamlavinab per day. For hospitalized patients, dexamethasone or methylprednisone may be advocated. Remdesivir here is advised. Stop antipruritive with reduction of the target tacrolimus limit tacrolimus dose for 46 nanogram per milliliter. And for persistent duration, we can give them convalescent plasma, tocilizumab of cytokine storm syndrome, and consider ivermectin in this situation. But here you should avoid the monoclonal antibodies because here will be of no value. And thank you.
Thank you, Professor Hussain, for such elegant presentation. But for the sake of time, we'll move to the next speaker. It's my pleasure to introduce my dear colleague and brother, Professor Ahmed Al-Sisi. Professor Ahmed is Professor of Nephrology at the National Institute of Urology and Nephrology, and one of the eminent transplant physicians in Egypt. He will speak to us today about COVID-19, about peri-transplantation precautions in the COVID era, because as you all know that we started to have many other precautions rather than the usual when we are facing this new pandemic.
Thank you for the organizing committee and the panelists for inviting me to speak about this rather an important topic. And thank you very, very much for the moderators and chairpersons for the kind introduction. This is actually an unorthodox medical presentation. The presentation will be covering few medical points, however, many administrative points. To introduce myself, more than this, I'm a holder of the fellowship of the Egyptian Fellowship of Healthcare Management and Masters of Business Administration, beside my medical qualifications, of course. So peri-transplant precautions in the COVID era was a hassle at the beginning when the COVID-19 perspectives initiated in China in late December 2019, and the WHO declared the COVID-19 as a pandemic. All transplant centers in the world was confused a little bit what we shall do in this situation. And there was no solid guidelines and no data from the virulence of the organism and the effect of immunosuppression regarding this important issue. And many of the transplant services all over the world was halted or modified for maybe a period of 3 to 6 months. However, in our facility, we started as early as Jan 2020 to think about what shall we do in this important issue. And we made a plan. Of course, there was no data, no guidelines. And so we used the management skills and the management science to sort out this. So at the beginning, the idea was to resume the transplant program safely and adequately, as safe as possible. And the targets was to create a safe environment. And we started by brainstorming to create a task force team. Task force teams in management skills is to create the most important persons aligned on the service, on the line, to get the best of the best without a prior knowledge. Then we set a time for assessment and reassessment for 3 months to initiate the service again. And that's what we done. And we initiated the transplant service in April 2020. So we created the task force team with the team head. And of course, the team head was a transplant nephrologist and 5 of the stakeholders. The stakeholders here are the people aligned on the service. Those people concerned with each discipline needed to sort out this problem. Here, the quality manager as a team member, the infection control manager as a team member, the nursing director, the OR manager, and the inpatient manager. So 6 persons with equal votes, except if we have an equal vote, that the team head will have 2 votes to align because of this an even number. We started as every managerial task by brainstorming. So the task force team started by brainstorming, and brainstorming is a skill to involve something called a multiple head syndrome. Multiple head syndrome is involving all the ideas from all the team members to be listed and to be put in a clever way to sort out the problems. And the multiple head syndromes led to sort out 4 main points. So we had a problem in people, we have a problem in patients, we have a problem in places, and we have problem in problem planning. And we used something called the marketing mix. Those people using marketing for projects, there is 4 P's to sort out this marketing. And we extrapolated the 4 P's here from people, patients, places, and problem planning from the marketing mix actually. So the brainstorming will start with the task force team to put all the points involved in the 4 points: places, people, patients, and planning. And of course, after brainstorming, the task force team will analyze these brainstorming in a fishbone analysis. And fishbone analysis, and those you can that will not oriented with this, is to put all the causes and the effects in a fishbone, an actual fishbone. I will show you in the next slides, to put all the causes and the analysis of the causes to lead to an expected effect. So fishbone analysis of each individual variable was put to analyze the problem. And after analyzing the problem, another brainstorming sessions to see what's the crucial 20% of causes that will solve 80% of the problem. This is called Pareto charts or Pareto prioritization technique. After doing Pareto, we can do another Pareto and re-Pareto with thinking until we get the best of the results. After getting the Pareto, we will put a stepwise plan and planning to each individual variable. I told you before about the people, the place, the patients, and planning and replanning. And then after that, we will go for the execution. It's not working. Yes, it was not. Okay. And of course, after putting the stepwise plan and planning to each variable, we'll go evaluate and re-evaluate. And this was done in a period of about 2 weeks to 1 month until we put the final plan. So this is the fishbone diagram I told you about. It's a fishbone diagram. It's a structured brainstorming tool using categories to explore root causes for undesirable effect. So you can put on the blue columns the undesirable effect or the categories, and you sort out the problem by listing all the possible effects that happens with this problem. After putting the fishbone, you will look for the Pareto charts, and the Pareto principle shows you that you can use 2 out of 10 causes that will solve 80% of the problem. And when you're doing Pareto and re-Pareto again, you can reach a very minor error effect at the beginning. Of course, for these are done for problems that was not sorted about before. 20% of input will give you 80% of results. And after doing this, I will not go through the details. However, we created 6 bubbles to sort out this problem. Those 6 bubbles included number 1, a pre-bubble or a home bubble. We instructed patients and donors, related donors, to be in a home bubble for 1 week before coming to our facility for admission. During this bubble, phone calls was done every 2 days from the transplant coordinator to check if the patient or the donor is suffering any symptoms or signs of an ongoing infection. 3 days before coming to the hospital, we instructed the patients to do a routine CBC, C-reactive protein, and ferritin, and we didn't do any COVID screening by ribosomal or non-ribosomal screening for the antigen or the polymerase chain reaction, because it was not available by this time in Egypt very frequently. However, we went after this to step 1 bubble, and step 1 bubble was in the hospital. In the hospital, we designated the physical existence of the place for transplantation, where we isolated the donor and recipient. And each transplant, we have 2 couples, so 2 donors and 2 recipients. And as they are related, we put each donor and recipient in a separate room, and we isolated the nursing, and each nurse was isolated in a ratio 2:1. So each couple, we have 2:1 nursing in 2 couples, and we put them preoperatively 3 days assessment in the bubble. On admission, we had a routine lab, and 24 hours prior to the OR or transferring to the second bubble, we had a PCR. Then we transferred the patient to the second bubble. The second bubble, after 3 days in the isolation with nurses and the doctors, and sorry, no doctors was isolated. I was, excuse me, donor and recipient and the nursing. We transferred to a second bubble for another 3 days, and we had another set of acute phase response parameters and another PCR. So total of 6 days, 2 acute phase responses for the whole team, including donors, recipients, and the nursing isolated with the patients. And here it was to mention that we created a protocol that nursing team would work for 14 days in the hospital. They will be isolated 14 days in the hospital, and then we'll have 14 days vacation, cyclical vacations. And during vacations, they will be screened by the acute phase response only. After having a second PCR and 6 days, and all of us know that we had knowledge then that when you contract COVID-19 infection, you will have some sort of an acute phase response available in your serology. In the CBC, you will have some lymphocytopenia, some CRP elevation or ferritin elevation, and after 5 days, most probably you will have a positive PCR. So we have no positive PCRs in the second bubble. And day +4, day 7, I mean, after isolation in the hospital, we go in the for the transplant. And the transplant, we had here an OR bubble. So the OR bubble, this day we do the 2 transplants. The OR will be designated only for the transplants. And there was 2 parallel teams, 1 parallel team on duty and 1 parallel team not on duty. With weekly screen for all the members of the team members of the transplant surgeons, nurses, and those people attending the operation. Of course, the OR teams are minimized to few people that will be attending the surgery, and the patients will be going to the OR completely isolated. And complete PPEs will be applied for the surgical teams then. And of course, for the nursing, for those who don't know, we were isolating nurses, 2 couples, and each nurse will be attending for the 2 patients, even in the fresh situations, because we are isolating nurses for 4 hours, ready-made PPEs for complete 4 hours. And then after the 4 hours, she can take off, and one of her friends will go inside, and she'll go to the bathroom and eat. So if you have 2 couples, with 4 nurses, we can circulate every 4 hours, so they can rest. After the OR bubble, we return to the step 2 bubble. Step 2 bubble, we're in the ICU or the transplant ICU, and each 3 days we will do assessments. No PCRs, of course. If the acute phase response and the symptoms are okay, it's okay. Medical senior assessment was done through a virtual cameras. And only 1 mid-senior round per day. Mid-senior means not a consultant, not a resident, assistant lecturer, or a specialist that will attend the round once daily to examine the donors and the recipients, of course, wearing a complete PPA. We created also an isolation bubble. This isolation bubble was not used in maybe 109 cases over 2 years. For those that may contract a COVID infection. So those who may contract COVID infection has a separate bubble outside of the place in another ICU to treat the patients. And of course, after discharge, we created another home bubble for the patients to be there. Transplant patients that had an infection later on, we created a protocol. It's mentioned before, so I not going to go through it again. Stopping anti-proliferative, minimizing CNIs, and of course, I want to cover only 5 points from the clinical guidelines created in December 2021 for a special population of transplantation in the CDC in the United States. So the guideline bullets included screening and testing. The donor and recipient diagnostic molecular testing must be done routinely before the transplant, and it didn't mention, this is created 1 month ago, maybe less than 30 days ago. Molecular screening, including antigen and PCR testing for the virus, for donor and recipient using the diagnostic molecular techniques. And if you have a positive infection, you must defer the operation. And here the level of evidence was 3B. I'll check. اللي حصل هنا على فكرة this computer is not ما علينا. So the level of evidence was 3B or B3 that testing must be done for the donors and the recipients, and we did this actually before these guidelines by 2 years. The second one, if you suspect or detect an infection, even a suspicion, a high index of suspicion, defer the operation for 2 weeks. The second point is if you have a post-exposure, you can use now monoclonal antibodies for moderate cases. It's highly recommended. If you have an infected patient, you follow up the guidelines for non-transplant. I finished. You must consult, or the team treating the COVID patient, who must consult a transplant physician for modifying the immunosuppression, and a clinical pharmacist and a transplant physician must monitor the drug-drug interactions and the possible cytochrome P450 induction or inhibition from the antiviral medications. And the level of evidence here was A3. Thank you very much for listening. I hope it was fruitful. Thank you very much.
Thank you, Dr. Ahmed, for this elegant presentation.
Unusual presentation.
Anyone have any question? Okay, for the sake of time, we'll move to the second part of our session, which will be moderated by Dr. Hadeel Gamaluddin, which is the liver transplant part. تفضلي دكتور هديل.
Firstly, I would like to thank the organizing committee for their kind invitation. And now we are moving to another category of transplanted patients. So we are now speaking about the liver transplant patients. Starting with our patient. So Mr. Ali is 35 years old male who was presented with decompensated liver cirrhosis secondary to Hep C with refractory ascites, and his middle score was 18. While he is on the waiting list for living donor liver transplant, he developed fever, sore throat, and bony aches, and was diagnosed as having COVID-19 virus by positive nasopharyngeal swab. Now he is consulting about his management. In order to answer this, Professor Yusri Aqlo was supposed to answer this question. However, because of a strict obligation during the pandemic with his patients, so he apologized, and we have to skip to the next speaker. Moving on, our patient was lucky enough. He recovered without hospital admission with only symptomatic treatment, and he is now asking about the COVID-19 vaccines while he is on the waiting list. And in order to answer this, Professor Sharif Mugawer is going to kindly to invite our second speaker, who is Professor Sharif is with us.
Yes, Dr. Adil, thank you so much for this kind invitation. Thank you, Professor Gamal, Professor Mustafa, for inviting me. We are lucky enough to have Assistant Professor Sharif Musa, who is an Assistant Professor of Endemic Hepatology and Gastroenterology. His main interest is in infectious diseases. He's going to answer this million times asked question, which is the COVID vaccination in liver transplant patients. Kindly, Professor Sharif, start your presentation.
Thank you very much, Professor Dr. Sharif and Professor Dr. Wahid Dos and Professor Dr. Hadil for this invitation. Actually, there are so many similarities between liver transplantation and kidney transplantation in this issue, and Professor Ahmed Hassan has made my job more easy. So I'll run rapidly through the few questions we will face with such a patient. Mainly insisting on the American Association guidelines and European Association position papers for the use of COVID vaccines. Are liver transplant recipients at higher risk for complications of COVID-19? Of course, like other solid organ transplant recipients, it's supposed to be associated with increased severity. However, mortality rates seem to be lower compared with kidney transplant recipients. As shown in this study, for the outcomes after liver transplant recipients, we'll see that the ICU admission and invasive ventilation were more frequent in liver transplant cohort compared to controls. So can we prevent COVID-19 in liver transplant recipients through vaccination? As for other infections, particularly in immunocompromised patients, vaccination against SARS-CoV-2 seems until now the most significant measure to decrease the risk of clinical disease. And so all the guidelines and guidances recommend COVID-19 vaccination for all solid organ transplant recipients, of course, including liver transplant recipients. The most important question is, are SARS-CoV-2 vaccines immunogenic among liver transplant recipients? Actually, we know that there is an excellent immune response in the general population to vaccines, but the vaccine immunogenicity might be not as robust for the immunosuppressed patients. As shown in this study, which showed low immunogenicity to SARS-CoV-2 vaccination among liver transplant recipients, we'll notice that the positive antibody response in liver transplant recipients was down to 47% compared to 100% in controls. And even the antibody titers were so much significantly different between the control and the study population of liver transplant recipients. They predicted that some factors are the predictors of this vaccination failure, like the age, medications, mycophenolate mofetil, and higher doses of prednisone, and triple therapy immunosuppression. This is a summary of the studies which address this issue. There are variable positive serological response rates from the 47, which we have seen in the last study, reaching up to 79% and 81% in some other studies. This variability may be related to the time since transplantation and the different protocols of immunosuppressive drugs used. What about the T-cell responses? If the antibody responses are suboptimal, can T-cell responses be similarly? Actually, this study, recent study, coordinated the cellular response through measuring the interferon gamma and interleukin-2 from the T helper 1 cells, and it also found that in liver transplant recipients compared to the health controls, there is suboptimal cellular response even after vaccination in liver transplant recipients. So we have decreased immunogenicity, humoral and cellular. What about the vaccine efficacy among liver transplant recipients in the real world? Actually, vaccine efficacy in preventing symptomatic COVID in healthy individuals ranges between 70 and 95% depending on the type of vaccine. And the suboptimal immunogenicity, which we have shown in the previous slides, may lead to a significant reduction in this protection theoretically. However, when we did real-world studies for liver transplant patients who received COVID vaccine, we will notice in this study that the hospitalization and ICU and death were much lower in liver transplant recipients receiving different types of vaccines. And all of these ICU admissions and deaths occurred in patients who received only 1 dose. But after receiving 2 doses, the ICU admission and death were 0 in this study for liver transplant recipients. And the more recent and larger study, which measured the coronavirus vaccination in relation to the reduced infection and death, we will find here that there's significant difference between the vaccinated and non-vaccinated COVID-19 infection and symptomatic infections and related death between those vaccinated and not vaccinated in liver transplant recipients. So they are efficacious, the efficacy is established, but are they safe in liver transplant recipients? Actually, none of the vaccines approved till now are liver replicating vectors, and therefore all of them are acceptable for our transplant recipients. There is only one report of acute cellular rejection of the liver after mRNA vaccination, but even the authors said that a causal relationship between this vaccine and the liver allograft rejection remains uncertain. So which vaccine shall we use in liver transplant patients? Actually, transplant patients should receive whichever vaccine is available based on the local distribution policy. But most of the studies we have shown and are being published are usually done on mRNA vaccines. The issue of the timing, which was mentioned by Professor Muhammad, when should liver transplant candidates and recipients be vaccinated? In this study, analyzing the antibody responses after COVID-19 vaccination in liver transplant recipients, we will see that after liver transplantation, there is the lowest response compared to people with cirrhosis before transplantation or even without cirrhosis. So the ideal time for the liver transplant candidate, they should receive the COVID vaccine before transplantation whenever possible to help ensure an adequate immune response. Preferably, they should receive the second dose at least 2 weeks before transplantation. But by no means should liver transplantation be delayed because of vaccination schedule. And it's recommended that patients on liver transplant waiting list with a recovered COVID-19 receive a vaccine after the complete disappearance of manifestations or after the end of the isolation period, especially if the patient has been treated with monoclonal antibodies or plasma from convalescent patients, this should be a little bit delayed. So if the patient couldn't complete his vaccination program before transplantation, the best time for giving the doses after transplantation usually ranges from 1 month to 6 months after transplantation, and this depends on the agents used for induction to get the best results. Should immunosuppressive regimens be modified before or after vaccination? Actually, we will see in this study that the immunogenicity of the mRNA vaccines have been affected by the type of immunotherapy, usually the type and the number of immunosuppressive drugs used. However, despite this information, the American Association of the Study of Liver Disease does not recommend alteration in immunosuppression to elicit an immune response to vaccine because of the potential risk of rejection. And it advises us to continue the maintenance of immunosuppressive regimens, including even antiproliferative agents in patients receiving SARS-CoV-2 vaccine. Should different vaccine schedules be applied specifically for liver transplant recipients? Actually, this slide was shown by Professor Ahmed Hassan, and it showed that there is much more increase in the immunogenicity after adding a third dose in solid organ transplant recipients. And this, a series of 3 mRNA doses is now considered a primary series of vaccination in many centers, with a 4th dose even as a booster 6 months after the 3rd shot, but still it's not in the final recommendations. But many centers are now starting to use this primary 3 doses. An additional dose of vaccine may help to increase immune responses, but more data are needed assessing the clinical benefit of this approach. To conclude, liver transplant recipients are at a priority for immunization against SARS-CoV-2. Although antibody responses are decreased in this population, however, vaccines still confer a benefit and reduce risk for severe COVID-19. The other measures like alternative immunization schemes, including a booster dose, higher doses, and modulation of immunosuppression during vaccination still needs further study and assessment. And thank you very much.
Thank you, Professor Sharif, for your elegant talk. And now returning back to our patient, Mr. Ali. Unfortunately, Mr. Ali didn't manage to have vaccination prior to his transplantation. And he passed through the liver transplant procedure with stable and had stable graft function and satisfactory tacrolimus level. 6 months post the liver transplant, he caught COVID-19 again. He was worried, asking what to do. He was worried about his graft and what to do with immunosuppression, his medications after transplant. And to answer this, Professor Wahid Douz will kindly introduce our third speaker. Please, Dr. Wahid. Professor
It
Wahid.
gives me great pleasure. Is the sound okay like this? Can you hear me?
حضرتك احنا سامعين حضرتك. دكتور وحيد حضرتك unmute please.
Yeah. Can you hear me like this?
Yes, we hear you.
It gives me great pleasure to introduce our dear colleague, Dr. Manar Mohammed Salah Ad-Din, lecturer of endemic medicine at Ain Shams University, who will talk about this very important topic of the complicated case of a patient who had performed the liver transplant and unfortunately has developed a COVID-19 infection. Dr. Manar, please begin your lecture.
Thank you so much, Professor Wahid. Thank you, Professor Hadil, for kind invitation. We will talk now about management of COVID-19 post-liver transplantation. ايه هي التشالنجز اللي بتواجهنا في حالة الكوفيد-19 post-liver living donor liver transplantation؟ انه الكوفيد-19 is still new, still mysterious, and in such a special group of population. So avoiding catching the infection is highly recommended. What about the immune suppression post-transplant and the hepatotoxicity of some drug used in treatment of COVID-19? And we will answer, does COVID-19 post-liver transplant have a worse or an equivalent outcome to general group of population? The current coronavirus disease or COVID-19 pandemic has witnessed a disruption in the community of transplant activity worldwide. The anticipated fear of potential serious outcome in solid organ liver transplantation, particularly in early post-operative period when there is a maximal immune suppression doses, the added risk of nosocomial infection during hospital stay, follow-up visit, put the transplantation program on back foot. It has been so long than restarting the usual activity and restoring the transplantation process become a must to avoid losing patient on the waiting list. Yet data about the course of COVID-19 infection post-living donor liver transplantation was scarce, and guideline of management recently been addressed. Giving the extraordinary amount of rapidly emerging data, COVID-19 management in such a special group of population is dynamic and continuously changing. First data, we should be grateful for the Italian group. This was the first case series published in April 2019 about post-living donor liver transplantation. وهم الحقيقة أول ناس قالوا إن الإميون suppression ملوش أي تأثير بالمقارنة بالهايبر ميتابوليك ستاتس زي الهايبرتنشن أو الدايابيتس والأوبستي as a risk factor for severe COVID-19. كان في consensus للتشاينيز جروب تقريبا في نفس التوقيت، ودي كانت أول داتا عن الليفينج دونر ليفر ترانسبلانتيشن. بعديها بدأت الأمريكان سوسايتي اوف ليفر اوف ترانسبلانتيشن نزلت أول جايد لاينز اللي هي أبديتد أخيرا في أغسطس 9 2021، والأمريكان أسوشيشن نزلت آخر جايد لاين للمانجمنت اوف أو البراكتس اوف ليفر ترانسبلانتيشن during الكوفيد ايرا. وحاجه حقيقه تدعو للفخر وجود الايجيبشن بروتوكول فور ليفينج دونر ليفر ترانسبلانتيشن اللي عملوا اساتذتنا واللي كان مواكب للحدث بشكل كبير. في الاخر الكوفيد 19 مانجمنت بوست ترانسبلانت is difficult, so preventing of catching the infection is more important. الحقيقه في الوقت ده ظهرت اهميه التيلي ميديسن. المانجمنت اوف ستيبل ريسيبينت through telemedicine was important. ان احنا نكابتشر الانفكشن ايرلي ونقدر ان احنا نمانج الحالات بدري، نانكارج الفاكسينيشن زي ما دكتور شريف تفضل في فتره الويتنج ليست او حتى بوست ترانسبلانت. بنعمل تيستنج للدونر والريسيبيانت بيفور الادميشن. احنا بنابلاي الحقيقه الدبل تشيك ده من اول ما رجعنا الليفر ترانسبلانتيشن بروسيس. بريفنتيف ميجر ان احنا بنفهم البيشنت ان هو while admission there is no visit وبن encourage السيفتي بريكوشن. بنencourage our patient ان هم high risk group فيلتزموا بالسيفتي بريكوشن الماسك ويرنج والفيزيكال ديستانس as much as possible. بالنسبه للاميون سبريشن الامباكت اوف اميون سبريشن على الكوفيد 19 كان الحقيقه مش معروف. في الاول الناس كانت متخوفه جدا من الاميون سبريشن او الاميون سبريست بوبيوليشن علشان السوبر انفكشن، وناس جوز فور ان الاميون سبريشن لا بروتكتيف علشان السيتوكاين ستورم والانفلاماتوري افكت بتاع السارس كوفي. لكن في ان جنرال الريكومنديشن بتقول انه احنا البيشنت اللي هم ما عندهمش recent rejection episode احنا minimize الاميون سبريشن بالذات الانتي ميتابولايت، نمونيتور الكيدني فانكشن والدراج ليفل، نادجست الاميون سبريشن based on the severity، ونبقى عارفين انه no plan fit all. This is a case by case. It is difficult and it should be balanced between the severity of COVID infection and the state of liver. Hepatotoxicity of some drugs used in the management of COVID-19 have hepatotoxic effect، بالذات الريميديسيفير ده الانتي فايرال اللي هو كان approved للسيفير cases في حالات الكوفيد 19. Still, the American Association recommend the use of remdesivir 5 days duration to liver transplant recipient hospitalized with COVID-19 and requiring oxygen supplement. لكن ان احنا نعمل baseline testing للliver biochemistry قبل بداية الريمديسيفير ومونيتورنج الليفر enzymes during الانتاك بتاع الريمديسيفير وديسكونتينيويشن لو اكتر من 10-fold upper limit للليفر انزيمز. بالنسبه برضو للادويه اللي هي كورنر ستون في التريتمنت بتاع الكوفيد اللي هم الانترلوكين 6 انهبيتور، الاميون سبريست بيشنت اللي هم بيريسيف الكورتيكوستيرويد مع التوكليزوماب، المشكلة إن هم at increased risk of catching routine or opportunistic infection, so careful monitoring is required. برضو monitoring the liver enzymes and drug-induced liver injury have been observed in some patients receiving tocilizumab. The NIH will ITZA guideline recommend that tocilizumab should be used in patients with severe COVID and have elevated marker of systemic infection, should be only avoided if there is recurrent recent infection. في الآخر الجواب عن السؤال بتاع الكوفيد 19 post living donor liver transplantation have a worse or an equivalent outcome. دي كانت الحقيقة our experience recently published in International Journal of Medicine 2021. الكوفيد 19 we followed up 41 patients. We had 2 patients with recent reinfection. جالهم الانفكشن twice. المين ايج كان 54 years old وكانوا 74 male و 26 female. We had mild course في 30% من الحالات و 47% have moderate course. Only 9% have critical course. 20 patients have had home isolation. 17 was admitted to ward, 4 in intermediate care, and just only 2 patients in the ICU. الأوتكم الحقيقة كان كويس. عندنا 41 patients have recovered. Just 2 cases of death. One was related to COVID and the other one was related to non-COVID. والcorrelation مع السيفيريتي احنا نفس الفايندنج بتاعت معظم الداتا اللي اتنشرت انه الهايبرتنشن والايدج والسكس والبي ام اي هم اللي كانوا significantly correlated مع السيفيريتي. التايب of immune suppression and the type of immune suppression stoppage was not correlated with disease severity. So to conclude, in the setting of living donor liver transplantation, being chronically immune suppressed increase the possibility of getting the infection. The outcome of living donor, of post living donor in terms of morbidity, the need of hospital admission, intensive care unit admission, or mortality is matched to general population. In outcome في COVID-19 post living donor liver transplantation is comparable to high risk population when outcome analysis is corrected with comorbidities such as diabetes, hypertension, and BMI. Thank you.
Thank you, Professor Manar, for your elegant talk. And now returning to our lucky patient, Mr. Ali has recovered with just symptomatic treatment. He didn't need to be hospitalized, and he didn't need any change of his current immune suppression, and he was maintained on tacrolimus with satisfactory graft function. Through the past two lectures, we were mainly speaking about the international experience. But what about our local protocol for management of COVID-19 during the pandemic? And in order to answer this, Professor Sharif Mugawer will kindly introduce our last speaker. Professor Sharif,
yes,
are you with
now,
us?
yes, it's time for
Please unmute.
introducing Professor Nahid Makhlouf. Can you hear me? Professor Nahid Makhlouf.
Professor Sharif, we can't hear you.
I'm muted now. Professor Nahid Makhlouf is a professor of tropical medicine and gastroenterology. She is the head of the medical team of liver transplantation at the Rakhi Liver Hospital in Asyut University. She will address a very important topic, which is spotlights on the Egyptian protocol for liver transplantation during the SARS-CoV-2 pandemic. She's a well-known name in the field. She's done a lot of effort, and we are waiting to hear this important topic. Kindly, Professor Nahid, start your presentation.
Okay. First of all, I would like to thank the organizing committee of the conference for invitation, and I would like to thank the chairperson and the moderator for preparing this session. I would like to thank Professor Sharif Mugawer for the introduction. My presentation under the title of Spotlights on Egyptian Protocol for Living Donor Liver Transplantation during SARS-CoV-2 pandemic. My agenda include contributor and protocol preparation, background and rationale, aim of the protocol and recommendations and conclusions. I present this protocol on behalf of Scientific Committee of Ministry of Health that was done for National Project of Waiting List in Egypt, that was done in April 2020 by the Professor Hani Saeed Abdel Basit, head of the committee from Ain Shams University, Professor Ahmed Sultan from Mansoura University, Professor Imam Muntasir from Ain Shams University, and Professor Hussam Sulaiman from Menoufiya University, Professor Muhammad Al-Ayashi from Cairo University, and I'm honored to be a member of this committee from Asyut University. SARS-CoV-2 pandemic require unusual allocation of healthcare resources, which may negatively impact the care of liver transplant candidate and recipient. Information on transplant recipient with COVID-19 during the first wave of pandemic were few and was based on published case report or case series. Rationale for this protocol: each country with limited resource must have their national guidelines for living donor liver transplantation during SARS-CoV-2 pandemic based on the current situation and according to local resources and available tools. One of the major objectives of this scientific committee is preparation of national protocol for transplant center in Egypt to deal with living donor liver transplantation during SARS-CoV-2 pandemic. Aim of the protocol and the recommendation: this protocol highlights four major points. Basic hospital requirement for living donor liver transplantation during SARS-CoV-2 pandemic, patient selection from the waiting list, management of the patient on the waiting list, and post-transplant management. First, hospital requirement for living donor liver transplantation during SARS-CoV-2 pandemic. Basic hospital staff, facility, and equipment required to restart the program during the pandemic. Presence of sufficient staff for initial evaluation of the case by using rapid survey questionnaire survey. Availability of nasopharyngeal swab for SARS coronavirus 2 PCR laboratory facility. Availability of high resolution CT chest for both recipient and donor in hospital admission. Availability of infection control team facility for screening, error detection of suspected case, including hospital staff, potential donor, and recipient. Provide safe busway for recipient and donor, including operative room, ICU, ward, and necessary equipment. Medical staff precaution and protection. Personal protective equipment must be provided to all medical person and worker who are in contact with the donor and recipient in the operative care. Any medical staff with history of contact with confirmed case of COVID-19 without wearing full PPE must be temporarily excluded from the team for home isolation and nasopharyngeal swab if needed when symptoms arise. Patient selection from the waiting list. We classify the patient into high priority risk group and moderate risk group. High priority risk group means the mortality risk on the waiting list outweighs the risk of SARS coronavirus 2 infection. This high risk group criteria include fulminant liver failure, mild equal to or greater than 20, child BU class C score 10, previous history of hepatorenal or spontaneous bacterial peritonitis, benign portal vein thrombose grade 2, hepatocellular carcinoma within Milan unfit for bridge, which include the child late B and the child C, hepatocellular carcinoma beyond Milan within San Francisco with good response of down staging after 3 months. A decision for high risk group, proceed for transplant with precaution. Moderate risk group includes those with mild from 15 to 19, hepatocellular carcinoma within Milan, fit for bridge therapy. The decision was complete donor preparation and the close follow-up in the waiting list. But the scientific committee does not recommend the transplant in the current situation. Basic precaution needed for recipient and donor. Recipient and the donor must have home isolation and personal distancing for minimal 10-day counting back from the planned date of transplant. Initial evaluation before admission, evaluation based on symptom, background, and exposure history, and by latest updated rapid survey questionnaire provided and updated by Ministry of Health. Nasopharyngeal swab for SARS coronavirus 2 PCR should be done for both recipient and the donor 48 hours before hospital admission and 24 hours before operation. High resolution CT chest for recipient and donor on hospital admission, as negative nasopharyngeal swab does not completely exclude SARS coronavirus 2 infection. So CT chest is mandatory during pandemic. The recipient team must explain the potential recipient and the relative the risk of SARS coronavirus 2 infection aggravation under post-transplant immune suppression. Transplant candidate with a history of confirmed COVID-19 disease. If there is non-urgent transplant should be avoided. If urgent transplant is indicated, nasopharyngeal PCR should be negative twice, at least 48 hours apart, with complete resolution of clinical, laboratory, and radiological finding. Recommendation for donor: only donor with low risk who accepted, who have no direct contact with positive or suspected patient, and there is no suspicious symptom. High risk donor advised to postpone donation for at least 28 days after symptom resolution and have negative PCR testing. Detailed informed SARS coronavirus 2 infection risk content should obtain from the donor. Management of potential recipient in the waiting list for living donor liver transplantation. All potential recipients in the waiting list should have regular follow-up, either by phone contact or transplant clinic visit. Monthly update of a child and mild, and weekly update if higher mild score. Abdominal ultrasound and alpha-fetoprotein every 3 months to screen for HCC, and if suspicion finding ultrasound, we should do CT. Weekly update arrangement of the waiting list by transplant team in each center according to child, mild, and hepatocellular carcinoma characteristic of recipient. We recommend that specialized center for liver transplant should provide easy accessible contact information to facilitate immediate hepatology consultation to the local health care provider if needed. Include nasopharyngeal PCR testing for COVID for patients who develop acute and chronic liver failure while in the waiting list. Detailed informed COVID-19 disease risk consent for recipient before the operation. Regard post-transplant management, immune suppressant protocol maintains the usual protocol for immune suppressant, which based on CNI, MMF, and steroid, and at usually recommended target level. For a recipient with proven post-transplant COVID-19, data from different liver transplant center during the first wave of pandemic were scarce and based on case report. Some reports suggest decreased immune suppression of infected recipient if there is no rejection episode. However, other studies suggest immune suppression may be protective from cytokine storm. The national recommendation include reduction and hold of CNI dose according to the severity and radiological finding in CT chest. It must be done in a case-by-case discussion, a multidisciplinary team with senior chest consultant, transplant hepatology consultant, and ICU consultant in severe cases. MMF and azacitidine hold should be discussed on case-by-case basis, and it is essential to consider reducing the dose of MMF and azacitidine in the setting of lymphopenia, a worsening pneumonia attributed to COVID-19. Patients who develop ARDS use steroid dose as recommended by COVID-19 protocol prepared by Ministry of Health. Drug-drug interaction with immune suppressant medication need to be evaluated and managed. We recommend regular telephone communication between liver transplant team and healthcare physician caring for liver transplant recipient with proven COVID-19 at isolation hospital. Regarding post-transplant clinic and follow-up visit for recipients who are transplanted more than 3 months, the follow-up can be made through telemedicine with the transplant team according to the scheduled visit or as usual or exceptional telemedicine whenever needed. Hospital visit and admission whenever needed according to clinical judgment by the transplant physician. All recipients discharged from hospital with educational booklet, information including alarm symptom and including contact detail for transplant team. Early post-operative period less than 3 months, regular follow-up visit as per center protocol, limits the number of patients who visit the transplant clinic and limits the number of family member and friend who accompany the patient in their visit, usually to 1. Special precaution, hand hygiene, wearing face mask, well-aerated room for waiting, keep distance 2 meters between patient at waiting area, decontamination of the waiting area should be practiced. Transplant recipients should be educated about avoiding crowded public place, social distancing, and staying away from patients who are ill. Vaccination, the usual vaccination of liver transplant recipient against strep pneumonia and influenza is strongly recommended. Travel restriction for transplant recipient, it is essential to postpone all non-essential travel for transplant recipient, and we recommend that transplant patient immediate household contact should not travel to high-risk recipient transplanted from rural area instructed to stay to nearby their transplant center at least for the first 3 months. In conclusion, preparation of national protocol for transplant center in Egypt to deal with living donor liver transplantation during SARS coronavirus 2 pandemic was essential, and regular and frequent updates are essentially needed according to any emerging data. And I think it is a time to update this protocol to include the vaccination against the COVID-19 cases and to include management of post-transplant with monoclonal antibody. Our protocol was published in Egyptian Liver Journal 2021, and this is our reference, and thank you for your attention.
Thank you, Professor Nahat, for your elegant talk. And I think we have a couple of minutes for any question either or comment either from the chairperson or
Dr. Hadid, sorry, we're out.
we are running
out of time.
Okay.
Yes.
So we end this session.
Yes, thank you. We'll move immediately to the next session, the plenary method session. It's a session about also the anti-COVID-19 vaccine in solid organ transplant, critical appraisal by Professor Antoine Berberi. Professor Antoine Berberi is the Middle East Society of Organ Transplant past vice president, and he is Istanbul Declaration Steering Committee member and MISOT Secretary General. Professor Antoine is one of the figures in the field of organ and kidney transplantation. And we will start with Professor Berberi. Sir.
I cannot share my screen.
Please open the screen. Is it okay now? Professor Antoine, is
yes,
it okay?
Yes. Now, Okay.
Yes, please.
Well, first I want to thank the organizing committee for inviting me to such an important and impressive meeting. I want to thank in particular Dr. Jamal Saadi, who's the president of the African Society of Transplantation. And I will be discussing today, in fact, the critical appraisal of anti-COVID-19 vaccine in solid organ recipient. The outline of my talk will be first, we'll look at the efficacy of the COVID vaccine. What is the definition? What happened to this efficacy with the emergence of the variant of concern? Can you hear me?
Yes, but we can't see your screen.
You cannot see the screen?
Yes, please share the screen, please.
I'm sharing the screen.
Not yet.
Can you see it?
No, we can see. We can see the camera on yourself only. Maybe if you switch off the camera and no, still not shared. Yes, now it is. Please make it full screen, please.
Can you see it?
Yes, excellent.
Okay. So the outline of my talk will be, in fact, looking at the efficacy of COVID-19 vaccine in terms of definition and what happened to this efficacy with the emergence of the variant of concerns, as we all hearing now what's going on in the world. The second point, I would look at what is the definition of vaccine immunogenicity? Do we know truly, do we have a biomarker for this, accurate biomarker for this immunogenicity? And I will discuss, of course, the humoral and the cellular immunity, as I've been hearing now with the previous speaker. Then we'll look at the immunogenicity in previously infected people with the SARS-CoV-2, an immunocompromised patient as well as an immunocompetent patient. And we'll look at the factor affecting the vaccine immunogenicity. Some of it has been addressed in the previous talks. And we need, of course, since this is an experimental and new, mainly the mRNA vaccines, we need to look to see whether there are some safety concerns. And I will conclude with some take-home message remark. First, the efficacy of COVID-19 vaccine. You know, we have more than 10 vaccines now rolling out in the market, but the one that took the most attention, really, the mRNA vaccine from Pfizer as well as from Moderna, and the vector DNA vaccine from the Oxford AstraZeneca. So I'll be focusing mainly on these vaccines since we have one of the most data that we can share now. The first two studies, based on which published in the New England Journal of Medicine on the two randomized controlled trial, the first one for Moderna and the second one for Pfizer were published in the New England Journal of Medicine within 1 day in December 2020. And this studies really had unleashed the rolling out of the vaccine all over the world because of the vaccine efficacy that was stated in these studies. So, as you know, there were nearly similar efficacy, both for the Pfizer vaccine and the Moderna vaccine, 95.1% for Pfizer and 94.1% for Moderna. Now, what does it mean, this efficacy? Efficacy, in fact, was defined as by measuring the relative risk of reduction. And the relative risk of reduction, to measure it, we need to know what is the risk ratio. And the risk ratio is, in fact, the percentage of people of the participant in the vaccine group that developed infection divided by the percentage of the people or the participant in the placebo group that developed the COVID-19. And this ratio, in fact, if you do with the calculation, is 0.049. And to measure the risk reduction ratio, we deduct from 1 this risk ratio, and it turns out multiplied by 100, and it becomes 95.1%. So this was the relative risk ratio, which is the equivalent of the efficacy for the Pfizer vaccine. Now, is this really the real accurate measurement of efficacy for any vaccine, not only for the Pfizer vaccine? In fact, there is more better accurate efficacy parameter, which is what we call the absolute risk reduction. And for the for the Pfizer vaccine, this absolute risk reduction was 0.7%. And how we measure the acute risk reduction? It is we deduct from the percentage of the people who, the placebo group who developed infection, we deduct the percentage in the vaccine group who developed infection. And this, the acute risk reduction is 0.74 minus 0.036, and it turned out to be 0.7%. Now, if we want to compare the two, we can see that the number by itself for the acute risk reduction is very low. And in fact, it represents the true and absolute risk reduction, while the relative risk reduction, it reflects the vaccine risk reduction in relation to the placebo. Now, scientists, doctors, and many people don't understand and don't know the difference between the two. What matters the most, in fact, is the acute risk reduction. But why we don't use it is because, as you see, the number is very low, is not impressive. It's very important to use because it reflects as I said, the absolute risk reduction of a vaccine. It avoids any interference of co-founders. It avoids any risk of co-founder. And most important, it is very important, we use it to address the issue or to calculate the number of the needed to vaccinate, which what we call the NNV. In this particular case, the Pfizer trial, the NNV, it is, we divided the one by the acute risk reduction multiplied by 100 and is 142. What it means is we need to vaccinate 142 persons in order to avoid one event of infection. So if we compare the two now, the Pfizer and the Moderna vaccine, we see in terms of risk reduction rate, it is the same, around 95%. The acute risk reduction, it's also very low, 0.7% and 1%, with a different number of NNV, 142 for the Pfizer and 88 for the Moderna vaccine. So you see, if we talk about the absolute risk reduction, this does not look that impressive, while if you talk about relative risk reduction, this gives you a much higher number and more impression and psychological impact on people to encourage people for the vaccination. Now, one of the major concerns that I wrote in a paper we published in last March, that the two randomized control trial that I mentioned today, the Moderna and the Pfizer, were not initially designed to assess the following primary outcome, which is hospital admission, ICU admission, which means severe disease, as well as death. Now, if we look at the severity in the two studies, severity of the infection, in the vaccine group, there were 1 out of 8 who developed the disease after vaccination, developed severe infection, while in placebo, it was 9 out of 162, which is 5.1%, suggesting that there were a double rate of severe infection in the vaccine group as compared to the placebo. In the Moderna trial, 1 of 185 patients in the placebo group developed a severe infection requiring ICU, which amount to 1 over nearly 15,000, which is the total participants in the placebo group. So the risk of developing severe infection in the placebo group in the Moderna was 0.006%. Now, what are the key limitation points in these studies? Most important is there were an exclusion from these trials of children, pregnant women, frail, elderly, and most important, immunocompromised patient and patient with autoimmune disease. The very important, another key point, which is the short duration and the safety and efficacy for the follow-up. Because we know today that in transplantation and vaccination, we know today that there are at least several years we need a follow-up to determine, to look at the safety and efficacy of these vaccines. Another important limitation, it is the lack of unidentified correlate of protection. We don't know today how to measure what we call, the immunogenicity, the protective immunogenicity. Nobody knows what it is, and I will be discussing it later on. Very important point also in the one of the key limitation point, and mentioned all this by the investigators themselves, that there were some people, some participants who were previously infected. The number of these participants were very limited, and so therefore we don't know. Assessing the efficacy and the safety in this group population couldn't be assessed, in the Moderna trial as well as in the Pfizer trial. Another important key limitation, which is the waning of efficacy over time. And this also has been addressed because the papers were published after 2 months follow-up, and this was not enough to assess the waning of the efficacy over time, especially with the emergence of the viral, the new mutant, because this waning of efficacy has been demonstrated with other vaccines. Now, what happened to the efficacy of these vaccines with the emergence of the new variants of concerns? You know that the initial virus were the Epsilon virus, as you can see, in January and February. Then gradually we had the emergence of the Alpha and the Gamma in some country, and in the early summer, the Delta variant became the dominant variant all over the world. And today, as you know, all of you, today there is an Omicron is replacing most of the variants, and mainly in the most vaccinated countries in Europe and in USA. Now, there were reported reduced vaccine efficacy against the new variant, mainly in the elderly, frail, and immunocompromised patients. And one of the first reports that came out was from Israel in April, by April 26, by the end of April, there were 400 fully vaccinated patients, who broke through, who developed reinfection with the Delta, which is interesting in these patients that 60% of them were admitted for severe COVID disease, and 40% of those with severe COVID disease, in fact, died. Who were these patients? In fact, nearly 50% of the patients who were reported in the study were on some kind of immunosuppression, such as corticosteroid therapy, chemotherapy, or anti-CD20 treatment, as well as recipients of organ transplant. And this is a study, I guess, was shown in one of the particulars from the New England Journal of Medicine, where they looked at the booster effect, 3-dose effect. You can see there were a 4% increase in the efficacy or in the level of antibodies after vaccination, after the second dose, before the second dose, and 40% before the third dose, and 60% 1 month after the third dose. So you see nearly only 50% of the patient, even with the third dose, had developed some kind of antibodies. But most important, you can see that this wide variation in the antibody level between patients. And this is not only seen and observed in solid organ transplant recipient, even as we will see also in patients with immunocompetent patient and with healthy patient, they have exactly the same thing. And this is one of the reasons we don't know what is the threshold, because it could vary up to 300 folds between patients in terms of response of antibodies. This is a study in adolescent kidney transplant patient who received the mRNA vaccines, and the conclusion from the study, they showed that the vaccine response in adolescent kidney transplant recipient was lower than that in the general population, or was similar to that in the adult solid organ transplant patient, and slightly better than that seen in the adult kidney transplant patient. This is a study conducted in the heart and lung transplant, where they looked at the anti-spike humoral response in transplanted patient and compared to the healthy control. You can see here on the right side that the healthy control were in the black dotted, where the transplant patient in the blue, were significant reduction in the anti-spike humoral response in transplanted patient as compared to control. Similarly, also there were reduction in the anti-spike T-cell response in the transplant patient as compared to control. And if you can see among transplant patients, there were a variability in response. So when they stratify the patient into responder and non-responder, again, there were no significant response in the anti-spike T-cell response. And the conclusion of the study was that these results confirm a recent study showing that solid organ transplant have suboptimal humoral and cellular immunological response following mRNA vaccination. This is a study from England, from the registry data from the UK, where they just released the information regarding the transplant patient vaccinated with either Pfizer or the AstraZeneca vaccine. The number of participants in the study were nearly 40,000, 43,000 divided into the unvaccinated group, which represented the minority, 1 dose, and the 2-dose group, which amounted to almost 40,000. What they have shown in the study, this is conducted between the alpha period in the UK, where most of the transplant patient, renal transplant patient, solid organ transplant patient, were not vaccinated, what you see in the black rectangle. And then in the Delta era, where you have most of the transplant patients were vaccinated, we can see that there is a similar pattern in terms of the number of infection among the vaccinated, the unvaccinated group, when are compared to the normal population, which it is in the dotted number. So there were similar number and rate of infection. And most important, what the study have shown, that vaccination was not associated with reduction in risk of testing positive for SARS-CoV-2. None of the vaccinees showed a protective effect from SARS-CoV-2 infection, and no difference in protection between the unvaccinated and the double vaccinated solid organ transplant recipient. And you can see here for the risk patient survival or the risk of death, there were no difference between over 90% in the patients who were unvaccinated versus 92% of the patients who were double vaccinated. So what about the reported efficacy in immune competent people, not only in immune suppressed people? There are several studies now and report published in the New England and the journal and the Lancet, where this is for the AstraZeneca vaccine, where the vaccine efficacy, in fact, during the Delta, with the Delta variant, this is with the Beta variant, was dropped to 10.4%. Another study from the US, from Israel, where they showed that fully vaccinated that tested positive were disproportionately infected as compared with the unvaccinated individuals, with a ratio of 8:1 for the Beta variant and ratio to 3:1 for the Alpha variant. And this results suggested a reduced vaccine effectiveness against both variants. This is a study from the US with mainly for where the Delta variant was the predominant. They look retrospectively at the effectiveness of the Pfizer by age and by variant, and as you can see, there is significant drop after starting from the first month after vaccination. There's significant drop in the effectiveness, reaching nearly 40%, and this was independent of age and independent of variant. And they concluded in the study that effectiveness against infections declined from 88% during the first months after full vaccination to 47% after 5 months. This is a study from Qatar, where Qatar is one of the most vaccinated today country. 80% of the population is fully vaccinated. The mean age of the population of the participant here was 31. We can see on the breakthrough during the Delta period, where nearly 40% of the double vaccinated broke through and acquired the Delta, and the majority of those who broke through were those patients who received the Pfizer vaccine. And as you can see here, in the first months following the vaccination, there were increase in effectiveness, in Qatar, and this was followed by gradual drop in the effectiveness, reaching 22% at 6 months post-vaccination. This is a study coming from Israel, showing the same thing, a gradual drop in the IgG level in the overall population. And this was independent in all age groups. So and another study from Israel 3 months later, again showing that there's the immunity against the Delta variant of SARS-CoV-2 waned in all age group at few months after the receipt of the second dose of the vaccine, with increase, as you can see here, in the number of confirmed infection that was parallel also by increase in the number of severe cases. And this is what prompted Pfizer to ask the US for authorization for a third dose of its COVID vaccine in order to boost immunity within the 12 months, that could increase the immunity within the 12 months after the third booster. And this has created a problem with the FDA, where two of the prominent scientists from the FDA, Philip Krause and Marion Gruber, that had led to their refusing to be under pressure. It led to their resignation from the FDA because, and they wrote a very important article in the Lancet claiming that boosters could pose risk if they are introduced too early or too frequently. And of course, it's not only the concern about their risk also. This is a just released a few days ago from South Africa showing the breakthrough infection with SARS-CoV-2 Omicron despite mRNA vaccine booster dose. So the booster does not seem to protect from the Omicron. This is data of mortality from the Public Health of England, where published by August, where they looked at the breakthrough cases with the Delta, and they identified 204,000 cases. 40% of them were vaccinated, and 60% were unvaccinated. The rate probability of death was 0.3% in the vaccinated, 3 times higher than the rate of death, 0.1% in the unvaccinated. Most of the deaths, in fact, occurred in those patients who are above 50, with 61% of them were vaccinated versus the 36% unvaccinated, showing that there is no difference, in fact, between the vaccinated and the unvaccinated in terms of mortality, since 60% of the population in the UK was vaccinated. And this is a study, again, recent study published in the Lancet, looking at the infection, risk of infection and breaking through in Scotland and Brazil, where Scotland was the Delta variant and the Gamma variant was in Brazil. And they have shown that there is an increase in those who are fully vaccinated. There is increase for the confirmed symptomatic COVID-19 infection, both in Scotland and Brazil. You can see here the risk ratio increasing gradually after the second to third months. And similarly, also there were risk for severe COVID-19 hospital admission or death was increasing again after the third months, both in Scotland and Brazil. And the conclusion of the study was the vaccine protection for shadows, of the AstraZeneca against COVID-19 hospital admission and death declined in both Scotland and Brazil within 3 months of the second vaccine dose. Now, what about the evolution of the pandemic in Israel, COVID-19, to understand, because Israel is one of the most vaccinated countries. You can see here, there were 5 waves in Israel, the first one in April 2020, the second one in September 28, the third one, mid-December, the vaccination started in Israel, and then we got the third wave in January 17, the peak. Then a third, the Delta started to occur with the third booster preceding the Delta. The peak of the Delta was in September 14, and then a fourth booster was started in Israel for the Omicron, and you can see here the expansion, the full expansion with the highest rate of cases following, with the Omicron in Israel. So if we look at the number of cases per million population, you can see a gradual increase from the first to the fourth dose, and then with the Omicron, there were an explosion of cases in spite of the forced vaccination that took place in Israel. And this expansion, took place independent in all age group. There were no specific age group. All of them had Omicron. And if we compare, the number of cases to the number of mortality in Israel, the peak mortality was about the third wave. And in spite of the continuous increase in the cases in Israel, After the third wave, which followed the first vaccination, there were a gradual drop for the Delta, for the first wave, and even further drop in mortality with the Omicron in spite of the explosion of the cases. So there were increase in cases, but decrease in the mortality. And if we compare what happened in Israel with the whole pandemics with the Spanish flu pandemics in terms of mortality, we see exactly the same pattern. While here, the difference here, there were vaccination. With the flu pandemic, there were, with the Spanish flu, there were no vaccination. So most likely this might not be related to the protective effect of the vaccine, but rather to the herd immunity and the natural progression of any pandemics that would lead usually to the disappearance of the virus. This is a study looking at the correlation between the rate of vaccination and the rate and the frequency of vaccine-resistant mutation. This study showed that the frequency of vaccine-resistant mutation correlates strongly with the vaccination rate, which was observed in Europe and in America. Now, in Israel, a recent report from the Prime Minister, he admitted that the current policy will not prevent a big rise in infection, and in fact, they did not force the people, the high-risk people to take but in fact, they offered for people who are over 60, as well as the medical staff, to take the vaccine if they want. So why herd immunity by COVID vaccine is probably impossible, because it's unclear whether vaccine prevent transmission. We know today that vaccine do not prevent transmission. The new variant changed the herd immunity equation and developed immune escape. This is what I just showed you. The immunity might not last forever. That's what also I have shown you. And most important, the vaccine rollout is uneven. And this is a fact. We know that 60% of the vaccine today is received by the world population, and nearly 10 billion doses were administered globally, and only 10% of these doses are in the low-income countries. And that's why we see mainly what we see in terms of data of mutations and variants are mainly in the most vaccinated country. What about a vaccine immunogenicity, a definition? It is a humoral or cellular. This is a key limitation. Again, we did not know, and until now, we don't know what is a true correlate of protection. And this is a study from Israel where there was a breakthrough in the people who were double vaccinated. They looked at the level of antibody between poor outcome and the patient who had good outcome. You can see significant variability, within each group, and there was no significant difference between the two groups in terms of anti-spike level. And this is what the FDA do not recommend today to assess the immunity by measuring the antibody level. With the phase 1, phase 2 trial, the lymphocyte count, you can see here during the first week after giving, there was significant drop in the total lymphocyte count, which is a rough marker of immunity. So it seems the vaccine, when we give the vaccine, there is significant drop in the lymphocyte count. And this, after the second dose, it is also correlate with the dose of the vaccine, but to a lesser extent. Now, there are several studies to look at natural immunity, showing that natural immunity could last up to 8 months after the infection. They also studies looking at the bone marrow importance of the plasma cell, longer plasma cell, which are the memory cell, and their role in the infection. This study showed that importance of the highly in asymptomatic SARS-CoV infection. In spite of being asymptomatic, they still have a highly functional virus-specific cellular immune response. This study ended from published in the CDC in Germany, where they looked at PCR-confirmed patient, and they stratified this patient in relation to their ratio of IgG, SARS-CoV-2 IgG. They were stratified into 3 groups: the one who had a ratio above 3, which was a positive, the intermediate, and within the intermediate, the identified group who had a ratio below 1.1. So they did not have antibody. And yet, when they looked at their T-cell response, 80% of the PCR positive volunteer with undetectable antibodies, they showed T-cell immunity against SARS-CoV-2, and there were similar frequency of this T-cell immunity in donors with a strong antibody response. And the conclusion of the study was, in convalescent patients with undetectable SARS-CoV-2 IgG, immunity may be mediated through T-cell. Similar findings were also reported in patients who are receiving immunosuppression. What about the immunogenicity in previous SARS-CoV-2 infection? So these are people who had the infection. So we look at the data in immunosuppressed as well as in immunocompetent patient. In immunocompetent patient with previous infection, this study published in Cell showed that neutralizing IgG antibodies are detectable for up to 10 months in the majority of the individuals. This is another study just released from Nature Immunology, again looking at children and adult in patients who were exposed to the virus. The specific spike-specific T-cell response were more than 2 times higher in children than adults. They were detected in many seronegative children, and the spike-specific response were also broadly stable beyond the 12 months. So this study emphasized, in fact, the immunity and natural immunity, and as well as the duration of the natural immunity in children as well as in adults. Is natural immunity protective? Yes, natural immunity is protective, as this study, the Siren study, have shown from England, looking at the infection rate of antibody positive compared with antibody negative healthcare workers in England. They have shown that median protective effect was observed 7 months following primary infection. And the previous infection with SARS-CoV-2 induced effective immunity to future infections in most individuals. This is another study from Qatar, where they looked at reinfection in primary infected people. Again, they saw that with the reinfection, only 4 hospitalized, and none of the 4 led to the ICU and admission or death. And reinfection were in fact rare and mild, and had 90% lower odds of resulting in hospitalization or death than primary infection. The study from Israel, where they show with the Delta emergence that less than 1% of the people screened, the people who recovered from previous infection. So they were the most protected against the variant. This is a study just released from the CDC, where again, they looked at serum, convalescent serum from California as well from New York. And the study, they have shown that infection-derived protection was higher after the Delta variant became predominant at a time when vaccine-induced immunity for many persons declined because of immune evasion and immunological waning, as I've been showing you with all the data, previous data. Is there any benefit to vaccinate naturally immunized individuals? Well, there's no benefit. In fact, this is a study coming from Israel, where suggests that people who got the vaccine, they can have a very strong protection against reinfection. And these results question the need to vaccinate previously infected individuals. This is a study from the US, again showing that vaccination of previously infected individuals does not provide additional protection against the COVID-19 for several months. Is there any risk in vaccinating individuals with past infection? Well, yes, there is a risk in vaccinating, as this study have shown, looking at the vaccine side effect after vaccinations. And they have shown that systemic side effect as well as local effect were common and significantly higher among individuals with previous SARS-CoV-2 infection than among those without known past infection. This is another study showing the same thing, where individuals with history of COVID-19 were 56% more likely to experience a severe side effect that required hospital care. Vaccine immunogenicity in immunocompromised patients with previous infection. Well, this is a very interesting study from the UK, looking at the immunological response to COVID-19 vaccine in kidney transplant recipient with previous infection. We can see here, both for the humoral response as well for the anti-T-cell response, there were no difference in between transplant patient and healthcare workers, irrespective of the vaccine used. There were no difference in the humoral response as a T-cell response in kidney transplant patient with previous infection as compared to healthcare workers. And there were no difference, in fact, in humoral or T-cell response in kidney transplant recipient with previous infection between vaccine types or between patients and healthcare workers. What are the factors that affect vaccine immunogenicity? Well, we heard the previous speakers. Low immunity is a very important factor in determining and influencing the rate of humoral response. So SARS-CoV-2 vaccine, as this been shown in immunosuppressed patient, is impaired in immunosuppressed patient compared to healthy individuals. And this study looked at 3 groups of participant patient, kidney transplant patient, dialysis patient, and control. And the conclusion of the study that the humoral response to SARS-CoV-2 mRNA vaccine is poor in kidney transplant recipient and reduced in patient undergoing hemodialysis compared with healthy control. The vaccine type, as I have shown you, it seems that the vaccine, the Pfizer vaccine seems to be associated with a stronger humoral response and a stronger cellular response. This study from UK, again, showing that independent of the status of infection, the Pfizer vaccine seems to be inducing a higher level of anti-spike antibody, and independent of the type of vaccine we're using, the patient who have previously experienced infection, who were previously exposed to the SARS, have a significantly much higher antibody response as compared to those who were infection naive. The type of vaccine is important. This is a study looking at a kidney transplant patients that were vaccinated within 2 doses of inactivated SARS-CoV-2. We can see that the level of antibody positive, or the frequency of antibody positive in this patient, was only nearly 19%. And this low level response was in fact aggravated by increased age and impaired GFR. What about the type of immunosuppression? Again, you all heard.
Have 2 minutes left, please.
Yes. So anti-spike IgG level was highest among kidney transplant recipients when they did not have MMF, if they did not have corticotherapy, if they had only 2 immunosuppressant drugs, young patient, and those vaccinated with the Moderna vaccine. B-cell depletion, tacrolimus, as well as belatacept, they are all affect and reduce both humoral as well as T-cell response in solid organ transplant recipient. What about safety concern? We need to talk about safety concern. I think it's very important because of the short follow-up of the patient, that we need to be careful with what's going on at the midterm and as well as the long term. We published a paper in this regard for those who are interested. The thrombotic event and the thrombotic thrombocytopenia, there are several reports today in the literature, and this which has led in Europe to cancel mainly with the AstraZeneca vaccine and the Johnson & Johnson vaccine. The European, they canceled their contract with AstraZeneca by the end of June. The FDA now adds the heart inflammation warning to Moderna and Pfizer vaccine, and these really heart inflammation as pericarditis and myocarditis, they occur mainly within the first week after the second dose, mainly in adolescent people, and now there's a very high number of these being reported all over the world. Unknown risk of mortality. Yes, there is an unknown risk of mortality. Well, the FDA recently published in November a report that finds all-cause mortality, which, as you know, is one of the most important outcomes, was higher among the vaccinated people in the Pfizer group. In fact, there were 21 deaths in the vaccinated group in the Pfizer trial at 6 months versus 17, which means that they were increased by 24% the rate of death in the vaccinated group as compared to the unvaccinated group. And we extrapolate this to the total USA population. It will be expected that 346,500 people in the vaccinated group will die versus the 280,000 in the unvaccinated. What about unknown risk of genome alteration? This is very important, mainly in children and adolescents, especially that the children, as you know, adolescents have no risk whatsoever of mortality. The possibility of viral transmission after vaccination is no longer a possibility. It is a real fact today that these vaccines do not stop viral transmission. And this has been admitted by the CDC, where they say that the fully vaccinated people spread the Delta variant and should wear masks the same way as the unvaccinated one. And I conclude, Mr. Chairman, there is a lack of correlate of immunogenicity. The extent and duration of vaccine-induced immunity are unknown. The immunogenicity appears to be suboptimal following vaccination in immunosuppressed patients. Vaccinated immunosuppressed patients with previous infection have similar humoral and cellular immunogenicity as vaccinated immunocompetent individuals. Many PCR positive patients with undetectable antibodies showed TCL immunity against SARS-CoV-2. Natural immunogenicity seems to be stronger in children than adults, independent of the immune status, and is detectable up to 10 months. SARS-CoV-2 natural immunity appears to be protective against the new variant and lasts longer than the one induced by vaccines. And post-vaccine immunogenicity seems to be affected by several factors: immune state, vaccine type, immunosuppressive regimen, previous SARS-CoV-2 infection, and the booster COVID-19 vaccine is not recommended for the time being after the initial 2-dose primary and array-based vaccination in spite of the waning immunity. So there is a limited data on COVID-19 vaccine in solid organ transplantation regarding efficacy, immunogenicity, and mid and long-term safety. Most data and recommendation today are derived from case report, single center experience with limited number of patients, retrospective analysis, and expert opinions. And there is definitely a definite need for future well-designed trials to individualize COVID-19 vaccination in solid organ transplantation. Thank you.
Thank you, Professor Antoine, for such elegant presentation. And for the sake of time, we'll close this session. I would like to thank all the speakers and chairpersons and moderators, and we will start the next session immediately. Thank you.
Bismillah ar-Rahman ar-Rahim. We need to start immediately because we are half an hour beyond our schedule. Actually, I am honored to be co-chairing this session with Dr. Karim Amin, the representative of the Foreign Affairs, and he is very supportive of African achievements and activities. And I would ask Dr. Karim to introduce the first speaker, please.
The first speaker will be Mr. Deviner, Dr. Deviner Nayirara from Kenya. She will be speaking about infection control in the transplant unit, the role of the nurse.
Dr. Deviner is the president of the African Nephrology Nursing Association. She is doing a great effort to collaborate all the achievements and activities of the nephrology nurses in all Africa and to try to develop their activities. She is online. Dr. Deviner online? Yeah, please proceed.
Good morning, colleagues. Thank you so much for this opportunity to share with you. And I also want to thank the speakers that have been before me for very, very educative presentations. And yeah, I just want to share kidney transplantation. The role of the nurse is very, very important. And we have realized that over the years, the infections have been the major hurdle in the success or the outcomes of the transplantation. And being the fact that the nurse takes a central role in taking care of these patients, it is then important for us to understand what that nurse is expected to do. So although the prevention, diagnosis, and management of infection in transplantation have immensely contributed to the improved outcomes of organ transplantation, infections still remain an important source of excess morbidity and mortality in these patients. And the nurse's role in infection control in transplantation cannot be underestimated, as I have already alluded to that. And the studies have also shown that bacterial infections are twice as frequent as viral infections in the outcome of these patients. And healthcare-associated infections in transplantation will include surgical site infections, blood stream infections, pneumonias, and urinary tract infections. And these contribute to the prolonged hospitalization and long-term disabilities, increased resistance in microorganisms and antimicrobials in these patients. Transmission usually occurs from healthcare providers, and therefore it is important for us to just understand what roles the nurses can actually play in ensuring that these patients don't get infections. In many centers, the success or outcomes of kidney transplant patients have been very poor because of the infections that have come up, and therefore it became important that the healthcare providers, including the nurse, can understand what measures they are supposed to put in place to ensure that these patients don't get infections, because we understand the fact that these patients, being in end-stage kidney disease, and also being that they are now transplanted, they have been put on immunosuppressive agents. Their infection, they are more prone to infections than the common patients in the hospitals. So why a transplant patient is at risk? We have the host issues that we can see, and we also have exposures. The exposures is where I want to dwell on most, because the exposures will come either from the donor, from the hospital, from the healthcare providers, and even from the community where the patients are going to after they have been discharged from the hospital. And therefore, the role of the nurse here is that, apart from taking care of the patient when they're in the hospital, we also need to prepare this patient on how they are going to interact or stay in the community after discharge, because they are going to go home with the drugs that immunosuppressive drugs that we have already given them. And therefore, the patients need to understand how they are going to stay in the community. So the patient who has been transplanted, as I've already said, is susceptible to infections because of the immunosuppressive agents. And these patients, when they are transplanted, we also have invasive devices that they are heavily on, right from theater. We also have other hospital agents that these patients can easily get, where the fact that they are in a hospital setup, the role of colonization pressures in the hospital, resistant pathogens that may be in existence in the hospital, that could be, maybe we have multi-drug resistant pathogens where the patient is being taken care of. The risk of overuse of antibiotic, that also compounds the risk for these patients to get infections. We also need to, as nurses, we always aspire to understand the impact of antimicrobial stewardship in the management of these patients. The antimicrobial exposure, we have said the overuse of drugs, there is these patients, they are on multi-drug regimens, and they can also have resistance to these drugs. So there is need to have controlled prescribing as a goal to decrease the risk for these patients to get infections. And we also need to, globally now we understand that we have regimens that have stop limits. We have scheduled changes in antimicrobial therapy and also antibiotics cycling. All these are geared towards ensuring that these patients don't get resistance. So despite the absence of transplant-specific data, the use of antibiotics, it also needs to be considered in these patients. So the impact of antimicrobial, as we have already just said, it is how do we make use of the drugs that we give these patients to ensure that these patients are not at risk of getting resistant. and such that those drugs can be of essence or of important use to these patients. And therefore, it is important that even as doctors or caregivers of these patients, we also need to make the nurse understand that these patients need this kind of care. So we also have, these patients are also at risk of other nosocomial threats, like the fact that they have so many invasive devices that they are using. They are already prone to many pathogens that can cause infections on them. You could be having bacteria or fungal infections and all sorts of infections that come because we have bypassed the normal defense mechanism for this patient. Also, there is potential person to person, and this can happen from the healthcare providers. So as nurses who are taking care of these patients, we need to ensure that we can control the visiting or the visitors who come in. We can control on what the people who come in to give services to these patients, how much they can be able to defend this patient from infections. Like in our setups, we look at even the people who have or common flu, we don't allow them in to take care of these patients when they are not well. Also, it's also important for us as nurses also to understand that the role of environment where this patient is being taken care of, we may have things like fomites that can contribute to infections of these patients. So how we handle the patients in the setup where we are nursing the patient is quite important. How we handle the environment, how we handle the hair that is coming in, and the use of PPEs on these patients, and the reverse barrier nursing we apply on this patient is quite important in the outcome of this patient. Because previous years we've lost, like in our setup, we lost a number of patients because of we did not care too much on how we were handling these patients, and also the fact that these patients are immunosuppressed. So we also need to understand as nurses the role of cross transmission or cross infection. That we know now that 30 to 40% of nosocomial infections are attributed to cross transmission, and this is what the studies have told us. And you can also get infections from inanimate environment, which we need to take care of. The hands of the healthcare providers carries a lot, and this contributes to a lot of cross-infection. And we can also have patient to patient. That is why these patients in acute stages after kidney transplantation, we do reverse barrier nursing and we nurse them in a single room, such that they do not have, they are not exposed to patient-patient transmission. And also we control a lot of visitors coming in. And like in our center, we have a screen where the visitors can just see the patient from outside and not necessarily coming in. So the risk of hand and glove contamination after contact with the patient environment, also as care providers, we need to understand this. And basically, as nurses, we easily point out when our other care providers are forgetting that. So cascading of contamination, the patient and patient environment, as I've already said, the healthcare providers' hands, microbe survival in health care providers' hands, and that is why sanitizers are quite important nowadays. And incorrect hand hygiene has also been said to contribute to cross-infection and the cross-transmission from other patients. And so in our setup, the patients, when the nurses are taking care of the new patients from theater, you allow those patients, the nurses who are in the transplant room, not to move to other patients, so that we avoid that cross-infection. And even if they were to move, then they need to change their PPEs.
We have one more minute, Diviner, please.
Okay. So the cross-contamination, I've already said. There are other devices that can make this patient be prone to infection, and those are the ones I have shown there. Environment, source of infection, I've already said. And across the pathogens that are actually common in causing infections on these patients, I have also shown them there. So the optimal approach requires multiple interventions. We need to take care of the environment, and the environments, of course, we need to use the right detergents in that. And also to appreciate that inanimate objects can actually be a source of infection, including the patient's bed. And the items that we use as care providers, the stethoscopes, the machines that we use to actually, when observing patients, can also be another source. So we need to ask ourselves, how do we prevent? What are the preventive measures that we need to put in place to ensure that these patients are safe? Hand hygiene is top in the list, that we take care of our hands so that we don't contaminate the patient. And also the question is, do we isolate these patients? And it goes without saying that we need reverse barrier nursing, and also to appreciate that this patient is prone to prone to infection because of many things that the patient harbors. We have multi-drug resistance, we have emerging pathogens, we have the environment where the patient is staying. And so going forward, the focus on prevention of infection through reduction of alterable risk factors that we as healthcare providers can do to save the patient. Thank you so much.
Thank you very much, Diviner, for your excellent presentation. Actually, we are missing your physical attendance and hope to meet in next June. I believe you will be attending the ExCon. And when we first meet in Dar es Salaam in Tanzania, I will deliver to you your shield of the Azoth. And now let me excuse.
Thank you so much.
You're welcome. Let me excuse Esther Obeng from Ghana and Onesmo Kisanga to make a switch for flight commitments.
Okay, and now we will move to our next speaker. He's from Tanzania, Dr. Onesmo Kisanga, who will be speaking about transplantation practice in Tanzania. He is a consultant physician. He's a nephrologist, of course, working in Muhimbili National Hospital, which is one of the oldest and biggest hospitals in Tanzania and in East Africa. He's the president of Nephrology Society of Tanzania, and he's member, of course, of African Society for Organ Transplantation. We welcome him here in Egypt, and we are listening to you, Doctor.
Thank you very much, Mr. Chairman. I convey my thanks to Professor Gamal Saidi, President of ASOT, for enabling me to be here today. I thank him and the Egyptian colleagues for giving me the second home. Truly the second home, because today it is the second time I'm in Egypt, in Cairo. I wish to congratulate you people from Egypt for presenting what you are doing. You have your Egyptian work, which emulates what have invested. It never comes so simply. It must be through a lot of sweat, and I thank and congratulate you. Tanzania is as you can see, right. Pointer, okay. This is our Africa where ASOT is being made. Tanzania is just here. It's a small country in the eastern part. I just give it the country. It's about 345 meter squared, and we are harboring a very good part despite our situation. This is the capital city, Dar es Salaam, which is here, and this is where I work at the National Hospital. This is Mount Kilimanjaro, the tallest mountain in Africa, and we have a good scenario of animals which are very, very, very nice. And I welcome you people from Africa to come and visit Tanzania. We have as well nice beaches. Yeah, as I said, Tanzania is a low middle income country in East Africa with a population of more than 55 million. The chronic kidney disease prevalence is 7% following a community survey setting, and prevalence of diabetes is 14.8%, and hypertension is 19.9%. Unfortunately, young people from the age of 18 to 38 are more affected by CKD. Likewise, you'll find people on dialysis are mostly at this age, and people on transplant are more also on this age. We have 31 nephrologists, among them 16 males and female, 15 females. So you can find that ladies are more aggressive in our country. We have 32 hemodialysis centers across the country, and we have 2 renal transplants, Muhimbili National Hospital where I work, and Benjamin Mkapa Hospital. All these are government owned. We have as well started peritoneal dialysis. Of note, we have had 18 living-related kidney transplant alone, including 2 children. And this was started at the National Hospital from November 2017. We are transplanting both hepatitis B and hepatitis patient, and we are soon going to start the secondary transplantation, that is after graft failure, as well as in HIV patients. Bone marrow transplant in Tanzania was started late in December last year with 6 patients. Of note is that the National Hospital where I worked, we didn't transplant patients from March last year because of Corona, but our colleague in the Benjamin Mkapa went on transplanting. This followed political issues that the previous president who died of COVID never believed that there is Corona until he also succumbed with the same. We as well expect to start liver transplant this year. And as well, we are planning to have organ transplant center, and we will host all the organs transplantation, including kidney, liver, bone marrow, in vitro fertilization, and cochlear implantation. This transplant center has been budgeted for, and we are looking for funds. Assistant Professor Gamal will highly be appreciated. What do we need from here? We need assistance in the following areas: supply of consumables for transplant services, which is expensive for us, everybody knows here, established, as I said above, of organ transplant center, immunosuppressive drugs availability, which are expensive, as have been presented here, and the staff training on hospital exposure. Thank you for listening.
Thank you very much. Thank you very much, Onesmo, for your very comprehensive presentation. And
Thank
I
you very
believe
much.
we will be coming to Tanzania for the African Nursing Association in March, I think.
You're welcome.
Yeah. Okay.
Okay. You're welcome.
Thank you very much. And please accept the shield of the Azot for your excellent presentation.
Thank you.
Is Esther online or not? Esther online? No. Dina Al-Bashir, is she available? Is Dr. Abdulatif Ashur online? Dr. Abdulatif Ashur online?
Yes.
And now we will be hosting online Professor Dr. Abdulatif Ashur, presenting Tunisian nephrologist. He will speak also about transplantation practice in Tunisia. Dr.
Hello?
Abdulatif, the floor is yours.
Excuse me, I want to. What is it? My presentation. Excuse me. Thank you, Mr. Gamal, to invite me to this presentation. I want to present you the condition of transplantation on Tunisia. Hello, you see me, please? Hello?
Yes, we can see your slides.
You can, all right, thank you very much. Donc, I present you the transplantation in Tunisia. If you see, we have in the first transplantation of cornea is 48. The kidney, the first one in the hospital Charnikol, 86. The heart, it's beginning in 33 at the military hospital. And the liver, the first one at the hospital Sahloul at Sousse, and the bone marrow, we began it on 98. If you see here, the center of organization transplantation, prelevement and organization in 93, who had the law to is a public institution and an administrative nature. He started his activity in 98. It's created in 95. His mission is to fight against graft shortage, organize the collective activity, management waiting list and refusal register, contribute to the examination of the law of antibiotic, ensuring the health security, continue the evaluation of transplantation. If you see here, almost the center and hospital at Tunisia to make a prelevement and a graft. Here in Tunisia, we have 6 centers of kidney transplantation, 3 at Tunis, 1 in the south, Sfax, 2 on the center, Monastir, and our hospital here, Sahloul. And the heart, we have 3 centers. The first center is the OP Hospital Military at Tunis. The second center is in the OP at Tunis, and the third center at Sahloul. The liver graft is beginning at Sahloul on 98. After that, 99 and at Tunis at El Marsa, and the beginning for the pediatric liver at Monastir on 17. Here, if you see the activity of kidney graft in Tunisia, like 2020, donc we have a good activity like 2010, and after that it's reduced. You see here the evolution of liver transplantation. We have the liver, the living liver transplantation, and the brain death. It's beginning at 98. The cornea, if you've seen, we have 5 centers to graft cornea, and if you see here, after and the pandemic here, we have little activity and small activity for this kidney, the cornea prelevement. You see the evolution of femoral and grafting, femoral transplantation, and the pandemic here, we have a slow, very little activity. One, identification and management of brain death donor is the really problem in Tunisia. One, we do not have a very big activity. If you see in here, we have lower than 16 by 100 year. We have 600 brain in the state. Donc we have a problem of the anesthetist and the activity to brain prelevement and the center and Tunis center and in the south Sfax. We have two problems. The under declaration of brain death state and the power declaration performance. The deficiency of our in Tunisia is the under declaration of and the breath encephalopathy deficiency. The problem, the real problem is to delay diagnosis, confirmation, and management. The disengagement for brain death state is very far in Tunisia. And 74% of the family refusal that donor of that activity. If what justifying to refusal this facility is the physical integrity, religion, breath death, and not the problem for definition, breath death and the death of the person. And the very really problem, lack of truth and confidence, lack of transparency, initial defect support, doubled about the organ trafficking for our situation. We must to have to sensibilization our population or population, general population to donation this activity, environment patient association, transparency and the rigor of to have confidence for our citizen population and the consensus religion authority. the professional training, which we have a good diagnostic of brain disease, and we must have to conform it of university, learning society and college, postgraduate study, and our center, the CMPTO center training session. We have to relationship with family and approach to constant to donation. And thank you very much for your listening.
Thank you very much, Professor Ashur, and hope next time you will be attending with us in Cairo and welcome you face to face. And now we'll move to the next talk.
Thank you.
Our next distinguished speaker will be from Sudan. She's the Secretary General of Sudanese Nephrology Society, Dr. Dina Al-Bashir, and she will also present the transplantation practice in Sudan.
Assalamu alaikum. I'd like to thank Professor Jamal and his organizing committee for inviting me to give this talk about Sudan. We have a lot of data, but unfortunately, without a renal registry, a lot needs to be done. Okay, so this talk will cover very quickly overview of renal care in Sudan, causes of acute kidney disease and end-stage renal disease, renal replacement therapy, renal transplant during the COVID era, and addressing the issues. So renal care in Sudan, 3 important facts that a lot of people don't know. That dialysis started in 1968, and the first transplant was 1974, and the treatment is free of charge. All of renal care is free of charge. So in spite of this promising start in full government funding, why are we lagging behind? Because we have 2 main factors hindering the progression of renal care in Sudan: patient-related factors, skilled manpower, extreme poverty, and the lack of awareness, late sporadic appearance. Would they come with end stage? And when they do come, they are lost to follow up because they live in remote areas, and we have a loss of manpower to more affluent countries. So in 1994, the Majlis al-Wuzara, which is they did a body which is responsible for this budget or this body. It's a coordinating and supervising body funded by the resolution of the Council of Ministers. It basically coordinates the money taken out by the government and supervises all of the renal care in Sudan. So what are the causes of acute kidney injury? A study done in tertiary centers in Sudan found that 82% were community acquired, 18% were hospital acquired. So the ACKDS did a protocol of prevention and early detection. A budget was done, implemented, approved in 2020, but it was interrupted by COVID. Now, the causes of end-stage renal disease in Sudan, 2 papers were done, and they were found basically that hypertension and GNs were the 2 most common causes of end-stage renal disease, but we're not sure whether it's due because patients are presenting late and therefore they're hypertensive, or is it hypertension? It's usually hypertension, GN, diabetes, or GN, hypertension and diabetes, the main causes. Okay, so the milestones in Sudan: the first renal transplant was in 1974, the second in the Arab world after Jordan, and the second in Africa after South Africa. The important things to know that the government actually started funding renal transplantation in 2000. So anything before that was sporadic. Even though we had a human and organ transplantation law passed in 1978 and which was updated in 2019, the real transplantation did not start actually after 2000 when it was funded by the government, because the cost is so high. And one of the first centers that started was Ahmed Qasim in Jazeera, and Ahmed Qasim now is currently the largest center in Sudan. So we will take a lot of examples from them because they have a lot of data and the number is large. So renal transplantation in 2010, the first pediatric center was formed in Soba, and before that the renal transplantation were done in adult centers. Now this table will show you very clearly to just clarify what I've been saying, that hemodialysis started 1968, peritoneal dialysis 2005, because also the funding started from the government then, and transplantation 1974. Currently, we have over 8,500 patients, 90 patients on peritoneal dialysis, and transplantation 4,500 from inside and outside Sudan. The number of centers of hemodialysis 98, 4 peritoneal dialysis centers, and 6 transplantation government hospitals. The frequency, because the government is funding and it's very expensive, is 2 times a week, and everything is funded by the government. Now, this is a map of Sudan. It shows you basically that all the rural areas now have renal hemodialysis. Now, this table will also show you, out of the large amount of money being paid, that hemodialysis and its consumables take 64% of the budget. That's why the government now is moving towards training and going towards renal transplantation, because it's draining the budget without a good outcome. Hemodialysis, I mean. This is also shows you in 2018, when they compared that the first year it cost the government over $6,000, almost $7,000 to put a person on hemodialysis, and another patient almost $6,000 to transplant him. By the 5th year, it cost the government $10,000 on the same patient who started 5 years ago, because by then he would have developed complications. But the same patient who started at $5,000 went down to 3. For every 3 patients transplanted, you're putting 1 on hemodialysis. That's why now we're moving towards renal transplantation. Now, this will show you the renal transplant inside, outside Sudan. You can notice that it was 600 in the beginning, and it was 1,000 outside Sudan. After the funding started, now we have 2,500, 700, and the patients going abroad are less, because it's cheaper to stay in Sudan if the government is keeping doing it. Now, this is all the government hospitals from 2000 to 2019, 2,577 patients transplanted. The largest center being Ahmed Qasim. This is from 2019, 2021. We had transplanted 776 patients in those 3 years. The drop was almost 50% because of the COVID, and they had a break from March until July. So that's 4 months of not working. That's why the numbers went down. Now, we found that the percentage, the males were transplanted more than the females. And this shows this even in 2013, it also shows that males are transplanted now. I took this slide from Dr. Sara from Ahmed Qasim Hospital. It gives you that in Ahmed Qasim Hospital, the number 1,200 patients, we found the living donors, the siblings, the males were more predominant. The brothers gave their sisters, but they didn't give their wives. عشان توروا الرجال حقارين كيف they give their sisters but they don't give their wives, but the wives give their sisters and they give their mothers. Now, this is also in 2013. The same number is, I'm just going to go really quickly because it just proves what we said in the other table in Ahmed Qasim, which mirrors all the centers, different centers, that the males are more predominant in receiving, and the males give more to their sisters than their wives. The mothers give to the daughters. Now, the overall patient survival in Ahmed Qasim from the year 2000 to 2015, the outcome, if you can see that the patient survival at 10 years is 94, 1 year at 86, but you can see the graft is much less. Here at 1 year, the survivor were 86, and at 10 years, 94, it went down to 54. These are the outcomes according to the low and moderate and high risk patients and what happened, primary non-function, rejection, and so forth. And you can see that the numbers are not very promising, but as we progressed, it became better. This I got from Dr. Nazig in Ahmed Qasim in 2020, 2021. They transplanted 73 and 147. Again, males more than females. You can see that the trend is mirroring. The low risk, 17 were transplanted because during COVID, as worldwide, everybody was transplanting low and moderate risk more than high risk patients. At 1 year, graft survival in Ahmed Qasim Hospital was 97, and at 1 year, patient was 100. If you remember, it was 54, the graft. Now it's 97 at 1 year, or 86. Now it's 97. The first year was 86. Okay, so this was restarted in some centers in July 2020, but officially we started again at August 2020. We stopped at March. Now, I didn't have time to write the numbers, but out of the 4,500 we talked about, only 303 got COVID. That's 16% of the total population. And the mortality was 22% and CAN was 6%. Okay, what are the challenges facing acute kidney injury? The majority of cases community acquired. We need to, the general public has to be aware that screening programs. The hemodialysis is very expensive. We want to do renal transplant. CAPD is very successful in Sudan, but needs trained personnel, and the dialysate is very expensive. That's why we didn't increase the pool. And the donor pool can be encouraged by encouraging live unrelated donation. And we started paired exchange and getting over religious and cultural taboos and starting a deceased donor program. The Fiqh Islamic Academy recently approved brain donors in January 2000, but the deceased donor program is still under registration because there's still issues in the government, and COVID, of course, stopped everything. What should we do for the donors? We started a donor program in March 2019, and then NCKDS set a separate budget to the development for taking care of the donors because it was felt that donors were neglected post-transplant. Medical personnel, we want to intensify their training, increase their pay, but we had finishing up and a fellowship program, and they're fully trained and still leaving. We need a renal registry, we don't have. So to summarize, renal care in Sudan is free, fully funded by the government. The main factors hindering progression in renal care are poverty, loss of trained personnel. Acute kidney injury, mostly community acquired, needs to be tackled by early prevention treatment programs. To also summarize, PD first is a good option in Sudan, but it costs less than hemodialysis, but the dialysate is very expensive. Hemodialysis is expensive. Now we're draining the budget. We're encouraging renal transplant and improving the outcome. A renal registry is paramount. We have a lot of data in the centers and in the Markaz Al-Ghomi, but we need trained personnel to be applied. We can increase the donor pool by encouraging live unrelated donation and starting a disease program. And a free donor clinic was started in March 2020. Renal transplantation has its challenges in any developing country. In the long run, it's the best and most effective option of treatment, especially in government-funded renal replacement programs. And finally, I would like to thank all of those who contributed to the work done in this talk and who are continuously and tirelessly striving to improve renal care in Sudan against all the odds. With that, I come to the end of my talk, and thank you for your presentation.
Dr. Dina, wait, please. Thank you very much for your great presentation, and always welcome to Egypt. We used to have the Sudanese delegates more than 20 or 30 in each of our meetings, but I think in the COVID era, we have limited exchange of delegates, but looking forward to welcome all of you again and come to Sudan and visit you more frequently. Please accept the shield of the Congress.
Thank you very much. Egypt is our second home. Thank you. Thank you.
Now we will move to the last talk of this session. It will be presented by the president of the International Federation of Kidney Foundations, the World Kidney Alliance, Professor Dr. Seo Fei Lui from Hong Kong. He is the current president of the International Federation of Kidney Foundation, and he is the chairman of the Hong Kong Society of Nephrology. The IFKF is leading the World Kidney Day activities, increasing the awareness of kidney diseases worldwide. And we are very interested in the IFKF for the regional programs and increasing the awareness, particularly in less privileged countries. Dr. Seyow, your presentation, please.
Thank you. Can I share this screen, please?
Yes, please.
Yes, I can do it now. Thank you very much, Gamal, for invitation. Thank you, everyone in Africa. I wish I was actually able to be with you personally. I'm looking forward to visiting Africa sooner in the future. So very brief that I would like to very briefly share with you the work of IFKF, International Federation of Kidney Foundations, which we have expanded to World Kidney Alliance. That means that it's not just foundation, it's everyone, patients group, society, etc. But our focus, as request, to focus on the World Kidney Day, the theme for this year. As you know, kidney is a major problem. 1 in 10 people around the world, doesn't matter where you are, have some degree of chronic kidney disease, with different degree of severity. I understood now is similar situation around the world. Some is slightly better, mainly worse, and increasing number of patients that we're faced with. The consequence is extreme in terms of morbidity and even mortality, not to speak on the burdens of the disease to the person, the patients, the families, and the whole healthcare system. So there's a need to increase the awareness, the prevention, and the detection of kidney disease, to start early treatment and provide better care for patients, and more so for better health rehabilitation as well. So I believe that we are all together. We all have something to learn. We also have to share it. We can share with others, and we need to support each other, especially around this part of the world, Africa, Asia region. IFKF World Kidney Alliance, our vision is very simple. We wish to have better kidney health for everyone with no kidney disease, and to optimize the care for people affected with kidney disease. So our mission is to promote both. We can promote kidney health and promote health in kidney patients, quality of life, and longevity of the patient as well. So these are our current members, as I highlighted in red. I hope I'm not missing out anyone. There's quite a few of you from Africa. We would like to invite all of you to join us because it's so important that we work together. I hope after this, you'll be interested in joining our federation. So our strategy is maybe classified as follows. We want to establish an international community and a network that we can all work together for better kidney health. We are a global advocate, especially for the lesser developed countries as well. We need to partner with a lot of stakeholders of interest people. As I said, we all have some experience and expertise, and we should share among us. And this is true World Kidney Health in the future with the NAFLO. We also wish and advocate promote effective, efficient, high-quality healthcare system for the patients. As you all now know that we try to be more patient-centered, patient engagement, empowerment. World Kidney Day is our main activities every year, and I will elaborate on this. And we'll continue to provide education program. I look forward to maybe have joint seminar with the African Society as well. We also promote research recently as well. So we have meetings, World Kidney Days. We're interested in renal diet. You'll hear a lot more from us in the future. We'll be holding kidney consensus. We have done one on living well with kidney disease. We have a NAFLO journal to publish articles. We would like to share information among all our members as a resource, tutors. We have all of us, I've heard the presentation just now, we all have good ideas, and we kind of a dialogue between the experts as well. And it's a matter of communication with each other, which now is through the website and webinar as well. Now, World Kidney Day, move on to World Kidney Day. I have been with World Kidney Day for the last 14, 15 years now, since 2006. Are your kidneys okay to the recent one? And we have not focused all that much on transplant, but there was in 2012, we did focus on donate kidney for life. We have been mainly focused on kidney health for everyone, moving upstream to prevent kidney disease. And this year, we focus on a very interesting topic. As you can see here, for the last few years, we focused on children's, ladies, women's, Better Kidney Health for All, Better Kidney Health for All. I just mentioned in 2020, it was actually important year, but it was actually sort of vanished in the mid of COVID as well. We actually published the guiding things about the 8 most important points to prevent kidney disease. You can read it here. So keeping fit, eating well, check blood pressure, control blood pressure, take appropriate food. So if you want to know about this, by all means, go to our website and you see you can download all this for your country as well. Last year, we focused on the living well with kidney disease. It's a step forward. It's not just maintain the patient alive, but actually allow them to live well with kidney disease. We actually define the symptoms, the life impact, and strategy to do that. Now, move on to this year very quickly. This is important. I've been the co-chair of the Joint Committee for World Kidney Day Program. It was good that everyone agreed that we should focus. There is a big gap. There's a big gap on many sides, how to bridge a gap for better kidney care. We need to talk about this in the kidney community. There are obstacles to better kidney health because we don't understand the complex nature, we don't have share information. The healthcare workers is another barrier. How we can actually communicate in a better way with our patients. How can we connect with our patients? And there also are public health policy makers. Our healthcare policy makers are also aware of the management of kidney disease. So this year, as you see, there's a healthcare professional, there's administrator, and the patient themselves. So there's 3 separate groups that we want to connect with, and because all of us have a role to play in bridging the gap. But I would like to highlight for you and show you a preview of the editorial that we're going to appear in Kidney International in March issue. We wrote out our editorial, Gamal is here as well, Kidney Health for All, Bridging the Gap in Kidney Health. So I'm just going to show you the abstract. Now, I'm going to show you the green part in a minute because this is actually quite important because I think this is the first time we are saying something slightly different to everyone. I don't know about how you understand health literacy because all of us do have this concept that is a major issue about health literacy of the patients because it affects outcome. But I think recently this has been rephrased as health literacy is the degree to which a person or a patient and the organization have equitably enable individual to ability to find, to understand, and to use. And we're no longer saying that this is health literacy is the problem with patients, that they're deficit, they have not enough knowledge or other things. The role should be more of us, as kidney organization, healthcare providers, work towards shifting the patient deficit health literacy narrative. This is not necessarily to that one that we are responsible for sharing and letting them to know what they need to know. Okay, I think this is quite important. If anything that I couldn't commit with you today, this is a message that we are here, not only just talking about how clinical service, but how to communicate with patients as well. So in this article called Towards Health Literacy for Healthy People in 2030, they say there's no longer just talking about patients, the person or patients, but on organization health literacy as well, the role of an organization. Cam Kalanta and myself actually put together a rather bold statement. What we're saying now is that there is a role of healthcare providers, that's you and I and everyone together, the renal unit, and organizations such as Kidney Foundation and other promotion, health promotion organization. We need to provide healthcare information to the public and the patients and carer, move forward to the public. I use the 5 rights of drug-given medications. We need to provide the patient with the right information, what they need in the content at the right time, because those patients who have not have chronic disease, they need different information compared to those who are on dialysis to transplant. So they need different information at different time. And it has to be the right source, reputable source, factual source that they can rely on. And in the right format, that they can understand. And the right channel. And nowadays things are changing. Maybe in the future, webinar, online webinar is a fantastic way of actually reaching a lot of people around the world. So this is an important statement, the right information at the right time, at the right source, or the right format to the right patients. So this is the main message I would like to share with everyone. Think about the role of the healthcare organization, healthcare provider in bridging this health literacy gap for the patient, as not only the patient's problem, we also have a role. Just to share some of the work that's going on. we as a IFKF actually had launched a pilot survey, a polling survey, so to speak, and it's not very scientific. But we thought it would be nice to know, do the patient feel that they got enough knowledge? What sort of knowledge do they want to know about the kidneys? What sort of knowledge do they want to know about treatment of kidney disease? What sort of knowledge do they need to know about living well with kidney disease? And we asked them, where do you get your knowledge? Do you get enough? And where will you prefer to get it? So I'm very pleased that we put together this international survey. And I'm so pleased that at this moment, there's 10 countries who are now conducting this survey with the patient. It's so important to connect with the patients, understand what they need, understand what they actually want. And we'll be publishing this result in the international webinar by ISN and IFKF to be held on World Kidney Day on the 10th of March. So do welcome to stay tuned in as well. In the editorial, we'll also highlight one thing. There are three parties: the people with kidney disease, the community, the kidney consumer advocacy, the people like us, and healthcare worker. We all need to work together for the kidney health of patients. But we are suggesting that in the future, the role of social media provide education awareness. But it's important that we must provide accurate data, because there's so many data on information around in the social media which is not reliable. So this is something that we propose to do. So this is our main theme of work for World Kidney Day by IFKF. Maybe just 2 more minutes just to give you an overview of global World Kidney Day vision. Mainly is to increase the awareness of the importance of our kidneys to our health, and to reduce the impact of kidney disease and the social problem. That is the aim of the World Kidney Day across the world. So our mission is a global movement. We want everyone to be together, bringing everyone together. We lobby together for promotion. We plan this World Kidney Day every year. The first day of March is the World Kidney Day. We want a central repository and clearinghouse for best practice and stimulate international advocacy work on World Kidney Days as well. So we target government, we target the public, general public, we target healthcare professionals like you are, because you have a very clear role. Healthcare funders, international organizations, and media as well is very important. So we have a lot of champions, and we welcome champions from Africa as well. Do it in your own country. Promote organ donation, promote kidney health and everything else. Of course, you can promote organ donation as well, which is important. So you'll find a lot of useful material on our website, visuals, materials, and it's all been translated into different languages. There's about 13 languages as well. So this is there for everyone to use it. So social media is the way in the future, especially with COVID. We actually provide a lot of social media kits. Do you visit our website, you'll find them very useful. And how to get involved? Spread the word. Do you promote World Kidney Day, 10th of March? Organize an event in your country or in the area or in your hospital. Involve the local people and the press as well, and get the World Kidney Day message loud and clear to everyone. We want better kidney health for everyone, and start with early prevention. So I would end there. Our mission is very clear: better kidney health for all and better care of patients with kidney disease. As I said at the beginning, I truly believe we all have something to share. We all have something to learn, and we're here to support each other. And I welcome your organization and your patient group to join IFKF. Thank you much.
Thank you very much, SF, for your very excellent presentation. And I believe it is one of the important issues of the IFKF is to perform more regional activities, particularly in less privileged areas or regions worldwide. And I think Africa is one of the most important regions to concentrate the activities of increasing the awareness of kidney diseases and regulate the screening programs, which is an important issue for the early detection and early prevention and treatment. Thank you very much, and we will close this session.
Yeah.
And
I look forward to meeting you in person one day. I'd love to travel.
Yeah.
Okay, thank you.
Thank you very much. And now we'll close this session. I think we will have a very short coffee break, 10 minutes, and then we start the session. تزنى لحضرتك 10 دقايق. 10 minutes coffee break سريعة ونبتدي السيشن اللي بعدها. Thank you very much. اتفضل.
عايز اعمل لك السيشن بتاعك كوفيد السيشن واحده كفايه يا فندم كام ساعه 3 اوكي هي جاهزه يعني هي جاهزه
Bismillah ar-Rahman ar-Rahim. Now it's my privilege and great honor to chair this very special session with very most distinguished and eminent professors in the field. This session will shed the light on the burden of end-stage patients requiring organ transplantation and the utmost need to increase the donor pool and implement the law for cadaveric donation, which is the only option for cases like the heart and the chest. So it's my honor to introduce the first speaker, Professor Mohammed Awad Tajuddin, President Advisor for Health and Prevention, Professor and Consultant of Thoracic Diseases, Ain Shams Faculty of Medicine, former Minister of Health and Population, former President of Ain Shams University, and President of the Egyptian Society of Chest Diseases and Tuberculosis. Fadalatul Mohammed.
Bismillah ar-Rahman ar-Rahim. Good morning. I appreciate very much the kind invitation of Dr. Gamal, Dr. Amay, and our colleagues, the organizing committee, inviting me to join you during the first meeting for organ transplantation. Also, I am delighted to be co-chairman of this session with my professors and my colleagues, Professor Rashad Barsoum, Professor Adel Adawi, Professor May, and other colleagues. The dream of lung transplantation is our dream for a very long time. Because as we heard, I will try as much as I can to concentrate my presentation during the next 20 minutes. Animal experiments for lung transplantation goes back to 1940s and 1950s. The procedure was technically visible. Hard performed the first human lung transplantation in 1963. A donation was essentially after cardiac death, and the recipient of the left lung transplant survived only for 18 days. And then from 1963 to 1978, multiple attempts and trials of lung transplantation failed because of rejection and the problems with anastomosis. In 1980s, introduction of cyclosporin from Sandoz, which is a powerful, used up till now, immunosuppressive drugs, renewed. I think at that time, it was the first drug to be registered in the United States before the approval of FDA. And this drug was very successful in preventing the rejection of the organs. The first successful single lung transplant was reported at the University of Toronto in 1986. And in 1988, another technique for double lung transplantation was successful. But unfortunately, the lifespan of the patient was very short. And then the first attempt to heart-lung transplantation was performed at 1968. Transplant in a 2-year-old girl with arterioventricular canal defect and pulmonary hypertension. The patient died after 14 hours from the operation. And then in 1970, there is, after the use of cyclosporin, there is achievement of clinically acceptable results in primates. In 1981, the first successful heart-lung transplant was performed in 45-year-old woman who went on to do well for more than 5 years after transplant. What about the indications of lung transplantation? The first indications is respiratory failure, chronic respiratory failure in patients with advanced pulmonary diseases, and the most common diseases who need transplantation are patients with chronic obstructive lung disease, COPD, which is a combination of chronic bronchitis, emphysema, and the asthmatic component. Other indications, according to the requirements, is restrictive lung diseases, including, or the most important, idiopathic pulmonary fibrosis, cystic fibrosis, alpha-1 antitrypsin deficiency, or primary pulmonary hypertension. And then we have other indications for that, but we should consider lung transplantation when they meet the following criteria: life expectancy after transplantation, class 3 or 4 New York Heart Association with the stable nutrition status, motivated for rehabilitation, and also have intact psychological support system. Now, after the problem or the era of COVID-19 pandemic, we have an end result of the what we called post-COVID-19 syndrome or long COVID syndrome. One of the characteristic features in some patients, now the number is not so small, we have advanced lung fibrosis, advanced lung fibrosis. In some patients, the lung is completely white, and the part of the lung which is working is about 10 to 15%, and the patient maintained on high flow oxygen with high flow cannula or CPAP or BiPAP. Most of those patients will need actually lung transplantation. And unfortunately, as you hear for some known figures, the main cause of this is respiratory failure, and some of them developed nematocysts in the lung, which is air spaces which ruptured, which leads to acute severe pneumothorax. What are the indications? As I mentioned, chronic obstructive lung disease. Other chronic indication with lung transplant is performed in, there is some index for transplantation. There is some data needs body mass index, degree of airflow obstruction by pulmonary functions, degree of dyspnea, as measured by Modified Medical Research Council, dyspnea scale, and also the exercise capacity of the patient, which is measured by what we call 6-minute walk test. This is one of the emphysema, one of the picture of chronic obstructive airway disease. As you show here, there is marked hyperinflation of the lung, and also this circle identify multiple very large nematocysts, or what we call emphysematous bulli. At any time, the rupture of this emphysematous bulli in those patients usually it's fatal. So that this advanced stage with emphysema require definitely lung transplantation. The criteria to refer the patient for transplantation of COPD as follows: progressive disease despite treatment, including all of the medications required, pulmonary rehabilitation, and oxygen therapy. And now we use a very high flow oxygen therapy for the patient with chronic obstructive lung disease with domiciliary oxygen supply. Patient is not a candidate for endoscopic lung volume reduction surgery. I attended in United States the first lung volume reduction surgery. The results are not so good, so that those patients after that they need lung transplantation. Simultaneous referral of the patient with COPD for both lung transplant and the lung volume reduction surgery evaluation is appropriate. The index of more than 5 is one of the indication. Partial pressure of carbon dioxide, PaCO2, more than 50 millimeter of mercury, or partial pressure of oxygen, PaO2, less than 60 millimeter of mercury. And the FEV1 is more than 25% of the predicted, which sometimes is not recorded in the patient with chronic obstructive lung disease because they are not able to inflate or to expire in the machine. The other important indication for interstitial lung disease, if we recorded the common causes of required interstitial disease, is interstitial lung disease. Unfortunately, we have now a lot of patients with interstitial lung disease. Some is related, some idiopathic, definitely. Some also is due to drug medications. And you have one more, about 125 drugs can induce interstitial lung disease. 125 drugs. For example, for you, Cordarone, which is amlodipine, which is used for cardiac arrhythmia. It is one of the drugs which can induce interstitial lung disease and also can induce thyroid fibrosis or dysfunction, and the many other drugs which can be used, up to acetylsalicylic acid. In some patients, which is very rare, but it can occur, aspirin can induce interstitial lung disease. Atmospheric pollution is one indication, and other medications can induce interstitial lung disease. And as I told you, now we have recorded cases after viral infections, which is well known for us as pulmonary medicine physicians, but because the number of cases developed interstitial lung disease after, for example, seasonal influenza virus is very rare or a small number of cases, so that the community is not aware about that the other viral infection can induce interstitial lung disease. What are the indications? Evidence of usual interstitial pneumonitis or fibrosing non-specific interstitial pneumonitis regardless of the lung function. Because the lung function here are very low. Forced vital capacity low, and also carbon monoxide diffusion test, DLCO, is more than 40% of the predicted, less than 40% of the predicted. Any dyspnea or shortness of breath or functional limitation attributable to lung disease. Any oxygen requirements, even if they only during exercise. All of these are indication for lung transplantation. As you see, there is advanced case of interstitial lung disease. End stage interstitial lung disease, as you see, most of the lung already is replaced by fibrotic pneumonic lesions. And as you see in this CT scan, many circumscribed translucent area, which is nematoceles. And most of the patients die after this advanced stage. They die from rupture of these nematoceles with irreversible respiratory failure. And then we have the pulmonary hypertension. As a chest physicians or pulmonary physicians, we know the problem of pulmonary arterial hypertension. Since the era of schistosomiasis. Schistosomiasis was affecting the lungs with endarteritis obliterans and with marked increase in pulmonary artery pressure. And when we were residents or students, the pulmonary artery in the chest X-ray was about like balloon in the lungs, which can lead to respiratory failure in the patients. So that pulmonary hypertension, either idiopathic or due to any other lung disease, the lifespan of the patient with advanced pulmonary hypertension is between 2.5 or 3 years. So that it's one of the indications for transplantation. So that we have indications for transplantation in the patient of pulmonary hypertension, which needs as like 6 minutes walk, development of significant hemoptysis, pericardial effusion, or signs of progressive right heart failure. And then if the cardiac index is less than 2 liters per minute per square meter for body index, and the right arterial blood pressure is more than 15 millimeter of mercury. There is absolute contraindication for transplantation. According to International Society for Heart and Lung Transplantation, there is absolute contraindication, including malignancy, untreatable advanced dysfunction of another major organs like renal failure, or except if there is combined transplantation, which is happened in some centers, so that we can perform that. Another contraindication is atherosclerotic disease with suspected or confirmed end-organ ischemia or dysfunction or coronary artery disease, not amenable to revascularization. Acute medical instability, such as acute sepsis, myocardial infarction, and liver failure. Uncorrectable bleeding diastasis or problem, chronic infection with highly virulent and or resistant microbes that are poorly controlled pre-transplant. Active, with many other contraindication, including, for example, active Mycobacterium tuberculosis or other mycobacteria, resistant mycobacteria, significant chest wall or spinal deformity, class 2 or 3 obesity, history of repeated or prolonged episodes of non-adherence to medical therapy that are perceived to increase the risk of non-adherence after transplantation, psychiatric problems, and absence of adequate reliable social support, severely limited functional status with poor rehabilitation potential, abuse or dependence, etc. Extrapulmonary organ dysfunction is very important. And then we have some relative contraindication, including old age. And now the age is not limited. Most probably the limitation of transplant is up to 65 years, but we have cases recorded 75 or even 80 years without other major comorbidity. Progressive or severe malnutrition, severe symptoms of osteoporosis, prior chest surgery with lung resection, infection with highly resistant organisms. As I told you, the adults older than 75 years are unlikely to be candidate for lung transplantation in most cases, although age by itself should not be considered as absolute contraindication. Now, what about the selection of living donor lobar lung transplant? This is very common now. We have in lung transplantation, not other transplantation, like not other transplantation, you have 2 donors and 1 recipient. So that in living donor transplantation, you take the right lower lobe from donor 1, left lower lobe from donor 2 to be transplanted to recipient. So that you need 3 surgical operations, 3 theaters and 2 donors. It is reported that bilateral lobe transplantation provides, living donor transplantation provides equal or better survival than conventional cadaveric transplantation. Although for retransplantation, survival rate after lobe transplantation is better than conventional cadaveric transplantation, as a perioperative mortality of retransplant was only 7.7% after lobe transplantation versus 42.3% after cadaveric transplantation. يا دكتورة حضرتك طول ما انت قاعدة تتكلمي في التليفون اتفضلي اتكلمي بره. انت بتعملي انتربشن للسبيكرز والسبيكر. Single isolated lobe transplantation, when indicated, has an acceptable results. However, when 2 donors were available, bilateral transplantation is better outcome. Living donor lung transplantation, bilateral living donor lobar lung transplantation, right and left lower lobe, as I told you, from 2 healthy donors are implanted in recipient in place of whole right and left lungs. Size matching is very important. We started the first 2 lung transplantation in Egypt was done maybe about 15 years ago, and it was living transplantation, and unfortunately, both of the donor and the recipient were died. But we refer some patients from Egypt for transplantation, some of them living for 15 or 20 years. And up till now, we have a very good relation with many centers. And now we started our program at Ain Shams University. This is our team, multidisciplinary team from Ain Shams University, and they were in Kyoto, Japan in 2019. And now we have many groups goes to Japan, one of the best centers in the world in Kyoto in Japan. This is our team in Japan. And before thank you, I will tell you that we have a very strong cooperation with Japan. They have a very good experiences. They have 11 lung transplantation centers in Japan. Most of in Japan, the transplanted lungs, even from brainstem disc cases, from living donors, and also from cadaveric lung. We started also now our trial in our Faculty of Medicine on animals. We started a certain trials for transplantation in animals, so that we have team and we have experiments and we have experiences. And now we have an invitation in one of the pioneers in the field of lung transplantation from Japan. I think he will visit Egypt next October. And I invite you all to attend these sessions on lung transplantation. Dear colleagues, thank you very much for your kind attendance.
Thank you very much, sir, for this comprehensive presentation. And just if anybody needs to ask any question, please.
ثواني حضرتك ثواني حضرتك. طب اتفضل. Any questions from the floor? Would you allow me, Professor Awad, to thank you for your very elegant presentation, and would you let me ask you about the compensation of the residual lung in donor. How long would it take, and would it require any period of rehabilitation, and so on?
Thank you very much. هي بتاخد لها تقريبا about 6 to 9 months. And because you know the right lung is 3 lobes, so that there is reinflation and reworking of to replace the resected lobe in the right lung, and the other patient the left lung. And you know, we have many well-known figures living with one lung or removed lobes from the other lungs, especially after during the era of resection of certain parts of the lung from tuberculosis. So that most of the donors, they have no long-term complications, but the lung is inflated from 6 to 9 months.
Thank you, Your Excellency, for this excellent presentation about the future of lung transplantation. I think that the whole world should prepare, we should prepare ourselves for this new era after the COVID-19 has affected millions of patients. Some millions were died, and other millions will continue to suffer from severe lung compromise after the interstitial lung fibrosis. And I think a lot of centers all over the world are going to prepare themselves now to prepare the team who is going to do this type of surgery. And other countries like our country here, we should prepare ourselves for the regulations and how we can proceed in this difficult task. I think the era is coming very soon. How can you see, Your Excellency, how we can prepare ourselves, our centers, our teams, our regulations regarding the lung transplantation specifically?
I think we are in a new era for definite revolution in the field of transplantation. When I was here with Professor Rashad Barsoum, I told him when I was house officer, we started the regimen of renal dialysis. And my resident at that time is Professor Sabri Gour. So we started that in early 1968 or 1969. And now we started also the renal transplantation. And you know, we have very efficient teams all over the country performing renal transplantation. The same for liver transplantation. And I think within maximum 2 years, a lung transplantation will be implemented in Egypt.
نقدم لحضرتك الأورد دكتور محمد، اتفضل.
Now we will move to the next talk, which will be presented by my dear colleague and friend, Professor Hussam Kamel. Professor Hussam is the Professor of Hematology and Department of Oncology National Cancer Institute, Cairo University since March 1997. He was the Vice Dean for the Community Service and Environmental Development since October 2002. Vice President of Cairo University for Postgraduate Studies and Research since 11/9/2006. And he was the President of Cairo University since 2008 till 2013. And one more thing, I think, is originally a nephrologist.
was.
Yeah, he was a nephrologist, and this is the best thing I would like to introduce him by. And the floor is yours. Dr. Hussam will present the topic of stem cell transplantation crossing the HLA barriers, the success of haploidentical transplants. Dr. Hussam, please.
Thank you very much, Professor Gamal Saadi, distinguished chairpersons. Good morning, ladies and gentlemen. I would like to thank Professor Gamal Saadi for inviting me. It's always an honor to be here. The title of my talk is Allo Stem Cell Transplantation Crossing HLA Barriers. Bone marrow transplantation through a variety of cellular, humoral, and cytokine pathways is a potentially curative therapy for different hematologic disorders. But the probability of finding an HLA-matched sibling donor is not very high. It's about 30%, and is always decreasing due to the modern trend towards lower family sizes. And the search for a matched unrelated donor is time-consuming and might interfere with the optimum timely management of our patients. And the utilization of cord blood as a source of stem cells suffers from several limitations, the most important of which is that the number of stem cells in a cord blood graft might not be enough to transplant an adult patient. So it has been the dream of bone marrow transplanters to perform haploidentical transplants. Now, haploidentical transplants carry some very obvious advantages because nearly all patients will have a potential match, either biological parents or biological children or full or half siblings. There is fast access and re-access to the donor. There is a better engraftment because the stem cells are enough, not like cord blood. And there is a better graft versus leukemia effect because the graft contains a higher number of natural killer cells and the cost is lower. But it also carries some disadvantages. For example, a higher graft failure rate due to the host T cells and higher rates of graft versus host disease due to the alloreactive donor T cells. Now, the strategies to decrease graft rejection and graft versus host disease in haploidentical transplants are the following. You may perform either a T cell depletion of the graft, and the T cell depletion of the graft is either by positive selection of the stem cells, collecting the CD34 positive cells, or a negative selection of the T cells by removing the CD3, CD19 cells. Such a graft is a T cell depleted graft, carries the risk of fatal infections and higher transplant-related mortality due to the delayed immunosuppression. The other strategy is to perform unmanipulated haploidentical transplants, non-T cell depleted, but you try to remove or decrease the alloreactive T cells post-transplant by either giving post-transplant cyclophosphamide or intensive in vivo immunosuppression using methotrexate, ATG, and anti-CD25. Now, this is a T cell replete transplantation, but it carries the risk of a higher incidence of graft versus host disease due to the larger number of alloreactive T cells. Now, what is the rationale behind using post-transplant cyclophosphamide to prevent graft versus host disease? Now, following transplantation, the alloreactive T cells, which are responsible for graft versus host disease,
start to proliferate in the first 5 days post-transplantation. So if you try to kill them during this window of 5 days by giving, for example, cyclophosphamide, you will decrease the incidence of graft versus host disease. While the non-alloreactive T cells responsible for immunity, for example, against CMV, Epstein-Barr, herpes zoster, and aspergillus are non-proliferating, so they are not affected by giving cyclophosphamide. And you can keep the immunity against these organisms because you are not killing these cells. The hematopoietic stem cells themselves are resistant to post-transplant cyclophosphamide, being rich in aldehyde dehydrogenase, which is common graft versus host disease prophylaxis nowadays in haploidentical transplants is giving post-transplant cyclophosphamide. And if you look at data published by the European Bone Marrow Transplantation Registry and also by the US CIBMTR, you will find that the trend for haploidentical transplants is rising and the trend for cord blood transplants is decreasing. Now, in haploidentical transplants, there are two very important questions. Which conditioning regimen should we use? And which is the best stem cell source for a haploidentical transplant? There are two possibilities of giving a conditioning regimen, either a myeloablative conditioning regimen, which we call MAC, and this leads to a lower relapse rate, or a reduced intensity conditioning regimen, which we call RIC, which causes lower graft versus host disease incidence and lower transplant-related mortality rates. Now, concerning the stem cell source, there are two possibilities. You can give either bone marrow stem cells mobilized by GCSF, growth factor, or you may give peripheral blood, but the peripheral blood carries a higher T cell content. So it is combined with a higher incidence of chronic graft versus host disease, but also a lower incidence of relapse. This is a study published in the Biology of Blood and Marrow Transplantation a few years ago, comparing haplo bone marrow transplants versus haplo peripheral blood stem cell transplants. And at 2 years, there is no difference in the times to neutrophil and platelet recovery in the incidence of acute and chronic GVHD. But haplo peripheral stem cell transplants lead to a lower incidence of relapse, a lower incidence of non-relapse mortality, and a better overall survival. Now, if you again look at data published by the International Bone Marrow Transplantation Registry, you will find that the most preferable conditioning regimen nowadays is the reduced intensity conditioning. And if you look at data published by the EBMT in Europe, you will find that peripheral blood has become the most important source of stem cells in haploidentical transplants. And the same is true for the United States, as published by the CIBMTR data. Nowadays, peripheral blood is preferred than bone marrow grafts. It is also easier, of course, to collect. Now, if we look at post-transplant haploidentical techniques, we will find that there are basically 4 techniques. You may use either bone marrow with a reduced intensity conditioning, or bone marrow with a myeloablative conditioning, or peripheral blood and the reduced intensity conditioning, or peripheral blood and the myeloablative conditioning. You may use them all, but peripheral blood and the myeloablative conditioning is not recommended because it carries the highest risk of graft versus host disease. Now, what about comparing haplotransplants to other donors? If you compare it with the matched unrelated donor, 10 out of 10, you will find that haplotransplant donors have a similar 5-year leukemia-free survival and overall survival. If you compare it to cord blood transplants, you will find that cord blood transplants have higher graft failure rates, but also a lower incidence of chronic graft versus host disease. And if you compare it with a matched sibling donors, you will find that haploidentical transplants lead to a slower neutrophil and platelet recovery, and also to a higher incidence of acute and severe chronic graft versus host disease. Now, how do we select the optimal haploidentical or the optimal stem cell transplant donor? Of course, if you have a matched sibling donor, this is the best donor. And you would select a matched sibling donor with 10 out of 10 match. This is, of course, the best situation. But this is only available in 30 to 50% of the transplants. Now, if there is no matched sibling donor, the selection of the donor depends on the urgency of transplant. If the transplant is not very urgent and you have maybe 6 months time, then you can go for a matched unrelated stem cell transplant and look for a matched unrelated donor in the registries, which takes usually a long time, about 6 months. But if the transplant is urgent, you may use either a haploidentical transplant or a cord transplant. And the preferred donor is the donor where there are no donor-specific antibodies in the recipient. And we prefer a younger donor over an older donor. We prefer a male donor to a male recipient than a female donor to a male recipient. We prefer a sibling or offspring rather than a parent, and a father is better than a mother. Now, what about haploidentical stem cell transplantation in Egypt? And let me summarize our experience. In Egypt, there is a lack of matched unrelated donor transplants, and only 40% of our patients who have siblings can be expected to have an HLA identical donor. And less than 3% of the donors listed in international registries are of Oriental origin, which makes it difficult to find a match for our patients, and the cost is very high. This problem has been solved to a great extent by the initiation of our haploidentical stem cell transplantation program about 6 years ago. Now, this program started in June 2015. We have performed more than 100 transplants, but I'm reporting here on the first 43, where the follow-up is a little bit longer. We have performed these transplants in many indications, malignant and non-malignant indications, and benign indications, as you can see. And the conditioning regimen was myeloablative conditioning or reduced intensity conditioning. The stem cell source was basically peripheral blood. Only in very few exceptions, it was bone marrow. And the graft versus host disease prophylaxis in all patients was giving post-transplant cyclophosphamide on day 3 and 4 with a calcineurin and MMF starting day +5. Now, at a mean post-transplant follow-up of 18 months, chimerism, complete chimerism was seen in 39 patients. The graft failure rate is 4.5%. The relapse rate is 9%. GVHD acute 7%, extensive chronic GVHD 2%, and the median overall survival 66%, and the transplant-related mortality of 34%, and the disease-free survival of 56%. Now, to conclude, haploidentical stem cell transplantation is emerging as a fast type of transplant, offering a therapeutic alternative for a wide variety of hematological disorders, particularly for patients without HLA-compatible donors, especially in the case of an urgent need for transplant. And nowadays, every patient can find a donor in the appropriate time. The outcome has improved over the past several years. It's now comparable to other stem cell sources, and there is a potential for a cost benefit. And over the next few years, haplografts will probably be the preferred alternate graft source and might even replace matched unrelated donor grafts. The level of immunosuppression that is required to induce engraftment across MHC is feasible, whether through conditioning regimens, graft engineering, or both. Post-transplant cyclophosphamide has changed the daily practice in stem cell transplantation, and reduced intensity conditioning regimens with post-transplant cyclophosphamide allow almost every patient to receive a haplotransplant. But post-transplant complications, mainly graft versus host disease, delayed engraftment, and infectious complications, especially cytomegalovirus, remain serious considerations. Thank you very much for your attention.
Thank you very much, Professor Hassan, for this elegant presentation. And we can have time for a couple of questions, if any, from the floor. Sure. If not, let me ask you, Dr. Hassan, in the situation of bone marrow transplantation or stem cell transplantation, and you encounter graft versus host disease.
Yes.
In that situation, one of the important lines of treatment is further stem cell therapy. And in this stem cell therapy, you are giving a third-party type of cells. Would this further initiate another further graft versus host disease in the future?
Possible, but probably not, because it is rejected after some time.
The stem cells?
But yes, but we don't use this very frequently because there are very effective drugs now. If the patient is resistant to steroids, and then newer drugs like, for example, ruxolitinib, Jakafi, which is a JAK2 inhibitor, is very, very effective in preventing and treating graft versus host disease. So we don't usually use this technique anymore.
It's not considered.
It's not common anymore.
Because you can't use the original donor because it is the source of the
No,
graft
I
versus
know.
host disease.
Yes,
Okay.
yes.
Any more questions? If no, please accept the shield of appreciation of the Azot and the pin of the Azot membership.
It is my great pleasure to be the person to introduce his friend, Mohammed Onim, the father of kidney transplantation in this country. There is a lot to say about Mohammed Onim, but it would be surplus because everyone knows what he has done, what he is doing, and who he is. Mohammed is going to talk about islet stem cell transplantation, which is, it has been a concern in Mansoura University for many years now with many animal experimental models. Actually, he has preceded many of the attempts that are being published today. So I am very eager to hear from him about this important topic. Mohammed.
Shukran, Rashad Bey, for this introduction. In the first half of this presentation, I'll just briefly summarize our basic experimental work. In the second half, I will try to present our current research efforts. I must say that all the experimental work in its entirety was carried out at the Urology and Nephrology Center at Mansoura. And the title is Using Mesenchymal Stem Cells to Produce Insulin. And we have opted to use mesenchymal stem cells because they are available and proliferative. And the most important thing, it could be applied in an autologous fashion. And also it's possible allogenic application. The only disadvantage is some difficulties in their differentiation to form insulin-producing cells. Anyway, now differentiation is carried in a multi-step procedure, but essentially the cells are cultured in a high glucose, rich glucose medium with the addition of some growth factors. And like non-essential amino acids, fibroblast growth factor, etc. And these are the mesenchymal stem cells at the end of expansion. They look spindle-shaped, like fibroblast-like. And with time, during differentiation, which takes about 22 days, the cells tend to coalesce to each other, forming these whorl-like structures, which are collected at the end. And these are the insulin-producing cells forming sort of whorl-like structures. And initially, there was skepticism about the ability of mesenchymal stem cells to be differentiated into insulin-producing cells. But there are 7 criteria that must be fulfilled to make sure that really the product from mesenchymal stem cells is an insulin-producing cell. First, by immunofluorescence, there must be a positive staining for insulin and positive staining for C-peptide, and co-expression of insulin and C-peptide in the same cells. While glucagon is expressed by cells not related to insulin or C-peptide formation. This is a confocal study showing one cell at the end of differentiation, and the insulin granules are the periphery of the cells ready for exocytosis. Another study which is important is to make sure that there is intrinsic synthesis of C-peptide, not insulin, C-peptide, pro-insulin, within the differentiated mesenchymal stem cells. And on the left-hand side, there is a positive staining. How do we know that C-peptide is really inside the cells? We give golden nanoparticles charged with anti-C-peptide antibody. The cells are cultured with this system, and then to see the gold, the thing is counter-stained with silver. So gold and silver will make black spots, which you see here at the strategic point near the endoplasmic reticulum. These are undifferentiated silver negative, and pancreas, adult human pancreas is positive. The cells must be glucose sensitive and insulin producing in a gradual fashion. So if the cells are exposed to increasing concentrations of glucose, then the insulin secretion or release increases. And the cells must express at the end of differentiation all the relevant pancreatic endocrine genes. The next, أنا عملت حاجة غلط. ممكن تساعدني كان نفتح تاني. أيوه. So that these cells can cure chemically induced diabetes in nude mice. Nude mice have no immune system, so they can accept cells of human origin. Induction of diabetes, usually by streptozotocin, transplantation under the renal capsule of these animals, monitoring, and at the end, the animals are sacrificed and the kidneys are examined. We use nude mice, intraperitoneal, okay, I have said this one, to make sure there are used 4 groups of animals. Definitive group, diabetic animals treated with culture media only. Diabetic animals treated with undifferentiated cells. And the definitive group is diabetic animals treated with insulin-producing cells. And at the back, to provide the background, are normal non-diabetic animals. I will skip this one. This will take time. Anyway, if we look at the at this slide, if we look, this is the blood glucose levels as measured by a glucometer among the 4 groups of animals. If we just focus on the green ones, and after induction of diabetes, after induction of diabetes, the blood glucose levels increase substantially. And after transplantation, within 1 week to 10 days, the blood glucose levels became normalized. But another crucial evidence is that when we remove the cell-bearing kidneys, the glucose jumped up again. So anyway, and this is the histology of the removed kidney, the cells under the renal capsule, and then they are stained for insulin, positive, C-peptide positive, co-expression of insulin and C-peptide within the same cells, glucagon outside the insulin-producing cells, and somatostatin outside the the insulin-producing cell. In this fashion, beta cells were expressed, alpha cells were expressed, and delta cells were expressed as well. And to ensure that the euglycemia was the function of transplanted cells, we examined the pancreas of the animals, and it did not show except few atrophic islets. We are not, we are very modest group. We are not the only people working on this one. Important groups are working in the United States. Okay. In the United States, if you make one step in the lab, you make a company next day. Yeah, you make a company. So there are 3 important groups working to produce insulin-producing cells, but not from mesenchymal stem cells. From either في حاجة ممكن نرجع خطوة يا ابني. لا. Okay. From embryonic stem cells, or more recently from the so-called induced pluripotent stem cells. Kiefer from Canada, Melton from Harvard, and Schulze and Associates from California. I just want you to focus on this one. This is the period required for euglycemia after transplantation in nude mice in the 3 American groups. 50 days, 75 days, 50 days. In our cells, well, I think they are better cells, the cure is within 10 days. Okay. One of the groups, the group from California, in 7 years ago, they had the permit to start a pilot experiment by using embryonic stem cells, which have been differentiated to form insulin-producing cells. But since they are embryonic, they were allogenic, so they put them in a capsule. And this was followed by sort of high noise, much noise, big noise. But the results, this one, they have to stop the trial. In 4 patients, they tried 4 patients, they have to stop the trial. Nobody was cured at all, and the capsules were removed. Similar, recently, in December last year, 2 papers appeared in very prestigious journals. Again, the same groups. They said our capsules did not function well because their pores were very narrow, and the nutrition and the oxygen and vascularization of the cells inside the pouch or the capsule was not possible. So they made the same capsules with wider pores, but wider pores will allow immune cells to go into the capsule. So they transplanted their cells within capsules with wide pores, but with immunosuppression. With immunosuppression. 2 groups using the same technique, using the same cells. Not a single patient. Sorry, not a single patient was cured, and all the capsules were removed within 12 months. المشكلة بقى إن to emulate islet transplantation, they have to transplant 500 million cells in 8 to 10 capsules for each patient, and these were removed. But there was a noise, and the conclusion was there was a proof of concept that the thing can work, may work, and then we have to improve our techniques, etc. So, when transplanting cells to cure particularly type 1 diabetes, there are 2 problems. Allogenic immune responses and autologous immune responses because of the present antibodies that cause type 1 diabetes. So to overcome the allogenic responses, encapsulation is one, use of immunosuppression, use of mesenchymal stem cells, and I'll say why, or gene editing. This is bad and the new thing, gene editing to produce cells which are sort of blind to the immune system of the recipient. Encapsulation has problems, the most important of which is this one. We have tried encapsulation, but within 2 or 3 months, they are surrounded by fibrous tissue, preventing any exchange of glucose in or insulin out. Immunosuppression have side effects. Some of the components of immunosuppression are diabetogenic, like FK, for example. Mesenchymal stem cells are known to be immunomodulatory. They exercise an immunomodulatory function by cell surface elements or by soluble factors. But to exert the immunomodulatory function, these mesenchymal stem cells have to be stimulated in an inflammatory environment, either natural or artificial. Anyway, so our cells, we have examined this concept. Are the mesenchymal stem cells really can provide an immunomodulatory function? Several workers have examined this concept in vitro, but we tried to examine it in vivo using the so-called humanized mice. Humanized mice are mice with a deficient immune system, and in which these mice are engrafted with human immune cells. So we bought them, they called NOG-XL mice from Taconic Bioscience, but these mice are very bloody expensive. Each mice is $1,500, each one, and they are sensitive. very sensitive, very difficult to manipulate. And animals were divided into 3 groups: transplanted, diabetic, humanized mice. Transplanted normal animals. Why? So as we control for diabetes, because diabetes can influence the immune status of them. And then for background, normal controls. Observation period of 8 weeks. Why 8 weeks? Because the lifespan of these animals is short. Now, the weight of the animals throughout the experimental period was similar. And now, for the blue group, the diabetic humanized mice, after induction of diabetes, again, the blood glucose shoots up. And then after transplantation, within 2 weeks, the blood sugar levels became normalized and similar to the normal transplanted and the normal controls. Let us finish this. I think this is the important slide. We have examined the immune cell subpopulations from the transplanted humanized mice. And from the blood, from the bone marrow, and from the spleen. These are the results from the bone marrow. CD45, similar. CD19, which is representative or reflects the granulocytes or marginal differences. But if we come here to the CD3, CD4, CD8, CD16, natural killer cells, CD69, indicative of activated lymphocytes, all of them are without significance. And the HLA A and HLA class 2 are similar, no significance. Then we command the same thing came from the spleen. All of them, all the examined antibodies or immune cell subsets were in significant difference between the 3 groups. Then may reflect that mesenchymal stem cells have some immunomodulatory function. We have them. So we examined the kidneys, the transplanted kidneys from humanized mice, diabetic, non-diabetic, normal, and a control from the spleen by staining them for immunocytochemistry by CD45. Very few cells of CD45. We said the conclusion, and this is the lymph node. This is the positive control. There is a muted immune response. But we can enhance, we can increase, we can improve on the immune modulatory function of the common cell cells by pre-treatment in vitro, using artificially something there, interferon gamma as a pro-inflammatory cytokine. We were surprised to note that pre-treatment with interferon gamma increases the insulin expression and the C-peptide expression. And it also increases the expression of PD-L1. Was one of the elements for immune modulation by mesenchymal stem cells, expressed by the cells as well as released in the culture medium. 3 weeks ago, and on the Facebook came this image, a company called Vertex, and from America, from Boston, and that they have impressive early results. This is a company thing for potential curative stem cell diabetic therapy, for diabetic therapy. They used differentiated cells from induced pluripotent stem cells but they were smarter than the other groups. And instead of putting them in a capsule, they injected them. They used the old technology for islet transplantation, transportal transplantation into the portal vein. But they have to give immunosuppression. But so far, we have no scientific paper in order to look at, not to look at. But Dr. Melton, who is behind this work, gave a webinar talk 10 days ago in Sweden, Stockholm. And he said, take care of the American, that the insulin requirements of this patient was reduced by 50%. It's very good to have, but this could not be considered as cure. One thing, an insulin requirement could be reduced by strict dieting as well. Anyway, this is the future. Maybe it's gene manipulation. Gene manipulation. But gene manipulation or gene editing, there may be some unforeseeable problems. We don't know that as yet. But utopia, the best thing is to have cell transplantation for insulin-dependent diabetic patients with no immunosuppression, no encapsulation, and no gene manipulation. I think mesenchymal stem cells can give, may be the element, and thank you very much.
Thank you very much, Professor Ghanem, for this highly scientific, academic presentation. You actually stimulated our appetite to see diabetics not receiving any insulin at a certain point. My short question is that in your early experiments in animals, you tried. لا يا راجل. تعال جنبي. In your early experiments in animals, you tried several sites for implantation of the stem cells, the testicle, the renal capsule, subcutaneous fat, and so on. Do you think that changing the site of implantation of the stem cells can have an impact on the outcome? طيب انتوا في البدايه حطيتوا الستيم سيلز في الراتس او المايس وفي الكدني، لكن حطيتوها كمان في التستيكل وحطيتوها كمان في السبكتينيوس فات اوف ذا ابدومينال وول. فالفروق دي.
This is an experimental model.
Yes, did you find? Of course, but did you find a difference in between the site? Because of course, changing the site can change the immune response to that site.
Yes.
يعني okay. Okay, thank you.
The experimental models serve as models. And the projection into clinical practice maybe not as successful as in the experimental model, but I think we have to try. This gives us sort of the elements that are required if a clinical trial is contemplated. In a clinical trial, we are not going to transplant in the kidney capsule. There are two good sites, either in the portal vein, oxygenation is ready, vascularization is ready, and the insulin is drained into the portal system. The other thing, but this requires a transhepatic approach. The other possible site is into the omentum. And again, the insulin will be drained into the portal system, but this required laparoscopic intervention. What we are doing now is we do a second trial after pre-conditioning of mesenchymal stem cells. This is unbelievable. You can improve the immunomodulatory functions of mesenchymal stem cells, and make sure that really the allogenic immune responses are not there or very muted. And we use, or we recommend the use of adipose tissue derived mesenchymal stem cells. They are all over the place from cosmetic aspirations, all over the place. And one gram of aspirate have a yield of 5,000 cells, mesenchymal cells. This is the plan. It will take us 2 or 3 years. We are not in a hurry. We are not looking for a prize or something. What we are looking for is satisfy scientific curiosity, one, and publish, if we can, results which are true without manipulations.
Thank you very much.
دكتور محمد، أنا هتكلم بالعربي معلش. أنا دايما بشوف حضرتك بكون في منتهى السعادة. يعني حضرتك دكتور رشاد برسوم، كل الإيجيبشن فيجرز، أنتوا أيقونات طب في مصر. وحضرتك كونك في هذا الوقت بعد اللي عملته، وأيضا تدخل في هذا البيس اوف ريسيرش which is very difficult and sophisticated، لك كل الشكر والتقدير بجد والله. يمكن الواحد لما بيشتغل في عمل تنفيذي او بيشوف البانوراما كلها بتاعت مصر، بيعرف قد ايه الناس اللي زي حضرتك، زي الدكتور رشاد، زي الدكتور عادل عدوي، زي المرحوم عبد المنعم حسب الله، زي ناس كتير قوي اضافت لمصر. وهو ده في ازمات الطب في مصر او ازمات القوميه بصفه عامه بيبان قيمه مصر، قيمه الاندر ستراكشر اللي موجوده، مهما كانت ضعيفه، مهما كانت ما كانش فيه الفاسيلتيز، ما كانش فيها ريسورسز كويسه، ما كانش فيها كابابيلتيز كويسه، لكن قدرت تشيل البلد دي في ظروف مختلفه. حضرتك وناس كتير في مصر يعني قدروا يبنوا مؤسسات بحثيه تشخيصيه علاجيه from the scratch, from at one moment from no resources or minimum resources. فيعني انا سعيد النهارده، انا والله كل ما بشوفك بكون سعيد جدا. ودكتور رشاد ودكتور عادل، كل هذه الشخصيات المصريه الطبيه، لكم كل الحب والتقدير. وحضرتك بعد اللي انت عملته تبدا هذا البيس اوف ريسيرش as I told you very difficult, very sophisticated, expensive and long term research. فانت تستحق يعني مش هقول لك نوبل لانك انت اكتر من نوبل، فلك الحب والتقدير.
هو احنا الريسيرش ده ايدياز يعني قدمناها من حوالي 12 سنه و 10 سنين للاس دي اف، طبعا رفضوها 3 مرات يعني. فده مصر مش ممكن تتقدم باي كونفنشنال ميثودز في اي حاجه، في الصناعه، في الزراعه، في الطب. الامل الوحيد ان احنا يبقى لنا دور في اللحاق والمشاركه في التطور الانسانيه. وما ينفعناش نعمل مصنع انسولين، لكن ممكن نفكر لقدام شويه. دلوقتي الريسيرش كله بايو تكنولوجي ونانو تكنولوجي، يعني ده اللي قدام. وبعمل بدل ما اعمل او افكر اعمل معمل مصنع حديد وصلب، لا، افكر اعمل مصنع للكربون نانو فايبرز اللي هو اصلب واخف، يعني افكر لقدام شويه دايما. وانا متشكر قوي على حضرتك، وانا يعني ممتن.
انا اعتقد يا فندم ان احنا ان شاء الله يعني في هذه الايرا وبقول لحضرتك بجد احنا ناس في يعني مجموعه علميه بتتكلم، لكن بقول لحضرتك عن يقين. احنا بدانا نحس ان احنا لازم نعمل اللي حضرتك بتقول عليه ده، لان السنتين اللي فاتوا دول في الايرا بتاعت البانديميك بتاعت كوفيد 19 كل واحد قال يا نفسي يا روحي يا روح ما بعدك روح. حتى الدول الكبرى، حتى الاتحاد الاوروبي بدا كل دوله تفكر في نفسها. وعشان كده بامانه شديده جدا الفكر الحالي في القياده السياسيه الحاليه سياده الرئيس عايزين دخلنا في هذا المجال. على الاقل هكلمك في مجال الطب بدانا نتكلم واي نوت نقدر نعمل اي بي ايز اللي هي اكتيف فارماسيوتيكال انجريدينتس. طبعا مش هنعمل كل حاجه، ما حدش بيعمل كل حاجه. وبدانا نعمل سيميوليشن سنترز للتريننج اوف ميديسين، واحده منهم هتتعمل في العاصمه الاداريه، واحده في المنصوره الجديده، واحده في سوهاج الجديده. بدانا نتكلم على الريسيرش في البايوتكنولوجي والبايوسيميلرز والمانيفاكتشر اوف سم انتي كانسر ميديكيشنز، الحاجات اللي هي فيري سوفيستيكيتد. بدأنا نتكلم ازاي نعمل ميديكال اكويبمنتس. لما جينا اتزنقنا العالم كله اتزنق في الميكانيكال فنتليتورز وفي المونيتورز وفي الاكويبمنتس الثانيه، بدأنا نتكلم وبدأنا نصنع فعلا. ففي كابابيلتي لهذا. لكن حضرتك كل تخصص او كل برانش زي ما حضرتك قلت لازم في ناس فيهم يقودوا القاطره عشان يقدروا في ناس مش عايزك خلاص في ستاجنيشن في بعض الحتت، لكن سيادتك انت بتقود القاطره في هذا الاتجاه منذ سنوات طويله. والبريزيستنس والبرسيفيرنس والكابابيلتيز بتاع حضرتك ساعدت في هذا. فان شاء الله هي مصر فعلا زي ما حضرتك قلت لن تتقدم الا بهذا.
خليك اسمح لنا
بس لا انا بقترح حضرتك ان انت تغير اسم افريكان سوسايتي فور اورجان تسميه اورجان تيشو اند سيل ترانسبلانتيشن
ان شاء الله. اتفضل عشان نشوف بس.
حسب حضرتك بس عشان ال دي صعبة دي برضه. Now I have the honor to introduce my colleague, one of the most eminent orthopedic surgeons, Professor Walid Abeid, Professor of Orthopedic Surgery, Cairo University, is going to talk to us about the experience of Cairo University in bone banking. We all know that the bone bank in Cairo University was initiated in the late 80s by His Excellency Professor Hilmi Hadidi. And I think Professor Walid Abeid was one of the earliest trainees in this big project. The need in orthopedic surgery for bone grafts is great. A lot of cases, whether difficult fractures or malunited or ununited fractures, and also in management of a lot of orthopedic cancers or orthopedic tumors. And Professor Walid Abeid was one of the eminent orthopedic surgeons who initiated to be one of the pioneers of orthopedic oncology. Please, Dr. Walid, the floor is yours.
Thank you very much, Professor Dr. Adel Adawi. I'd like to thank Dr. Gamal Saadi for inviting me to give this lecture. And it's really a great honor to be among this group of distinguished professors that I really look up to And I wish my presentation would be as simple and straightforward among this community of nephrologists. Okay. There are lots of questions that come to mind when we mention bone transplantation. And I wish in this lecture to answer most of these questions. First of all, is bone transplantation something new? Is bone transplantation similar to kidney transplantation and liver transplantation? Do they undergo the same protocols? Who are the sources for bone transplants? Are they living donors or cadavers? What is a bone bank and what happens there? What does a bone bank do actually? What are the bone allografts used for? And does the bone allograft really work? What are the possible related complications? And do we need bone transplantation in Egypt? Are there other alternatives? These are the questions that I'm going to cover during this lecture. So actually, bone transplantation is not something new. It started maybe a century ago with McEwen in 1881, Lexer in 1925, and then sporadic cases. And there were a lot of literature in the 60s and 70s about bone transplantation, but it hasn't been organized until the development of the American Association of Tissue Banks and the European Association of Tissue Banks and the Asian Pacific Association of Tissue Banks that standardized the procedure of bone transplantation and became something that has standard protocols. And just to give a brief insight, previously allografts were called homografts, which are grafts from the same species, to differentiate it from heterografts from other species. Now it's allografts means grafts from the same, from persons from the same species to differentiate it from xenografts from other species. So how do bone allografts incorporate? They actually, the bone allograft is a dead tissue. Tissues are completely different than organs. These are avascular things like bones, skin, corneas. They act as scaffolds. So actually, from the host glues to the scaffolds. It's not something that is viable. And from our retrieval studies, you can see here at the top is the living bone. And the part down there is actually the allograft. And you can see that the allograft is completely avascular. So it's not like the vascular grafts in which the growth or the healing occurs from both sides. No, it occurs from the host to anneal to the allograft, which is dead tissue. If you do a bone scan for allografts, you'll find that it's a cold spot. It doesn't have any vascularity. So it just acts as a scaffold, and the repair of this dead tissue occurs very slowly. So do allografts create an immune response? Are they like kidneys and livers? They create an immune response and they could be rejected? Actually, no. They create an immune response because they are foreign, but the immune response is not complete. It's not vascular, so you don't find cells going and reaching the allograft. It doesn't get rejected, similar to the skins and similar to the cornea. And the reports about the allografts that it creates a rejection are very, very minimal. So what is a bone bank and what does the bone bank do? The bone bank is a place that is responsible for retrieving the bones, the allografts, processing them, storing them, and then distribute them. But the aim of a bone bank is to provide safe and reliable tissue. By safety, we mean that the tissues that are delivered from the bone bank does not carry any transmissible disease, because the bones that are retrieved from the donors, they contain blood, and blood could carry transmissible disease. So an allograft can transmit disease if it's not handled properly. So, and there were early reports before the standard protocols being implemented that allografts actually transferred HCV and allografts transferred AIDS. HIV. So we have to be very strict among the donors for allografts to make sure that they don't carry any transmissible disease. And this is the role of a bone bank. The other aim is to provide reliable tissue. You can't give a femur as an allograft with cracks inside it or with cysts or that does not withstand stress. So the bone bank aims at delivering safe tissue free of disease and reliable tissues that the surgeons could use for different procedures. So what happens in the bone bank? Tissues are retrieved. Lab investigations are done to make sure that the tissues are free of disease. And then we sort the tissues. We store them in either by freezing or freeze drying. We process them to make different shapes to be used in different surgeries, sterilize them when need them, and then release them and follow them up to make sure that they're doing well. The donors are either living donors from amputation stumps or from arthroplasty surgeries in which femoral heads are taken off, or from cadavers. Before taking any tissues, whether from living donors or from cadavers, there is a donor exclusion criteria. And most of these criteria, they are criteria for patients that could transmit disease. Any patient with an infectious disease, with a previous malignancy, with collagen and metabolic disorders, clotting disorders, chronic steroid use, history of hepatitis, with large wounds in the amputees, or patients which have been put on respirators could not be a donor for bone grafts. We select the age, the bones to be strong enough without any epiphyseal scars. So we take tissues from patients who are between 16 and 60 years. A thorough history and physical examination is done. Written consent from the patient if he's a living donor, or from the family if it's a cadaver. And the tissues are taken under complete sterile conditions. So suppose there is an amputation with, after excluding all the criteria and selecting the donor properly, the amputation stump, once it's done, the tissues are taken in the operating theater under sterile conditions. If a patient is doing arthroplasty, for example, a total hip arthroplasty, and the femoral head is going to be taken out, the femoral head is taken in the operating theater under sterile conditions. In living donors, it's taken immediately. If it's an amputation and it's going to be kept before the tissues are retrieved, it should be taken within the 6 hours before the bacterial bioburden increases on the tissues. So these are the steps of retrieval. You should take a blood sample from the donor to test for all transmissible disease. The tissues are taken under sterile conditions. The bones are taken after periosteal dissection with the capsules attached to the tissues, and swabs are taken from the tissues to make sure they don't have any aerobic or anaerobic organisms. The tissues are sprayed with antibiotic sprays. The cartilage is covered with a cryoprotectant, whether glycerol or dimethyl sulfoxide, and the tissues are put in sterile bags and transferred to the bone bank. Once the tissues are in the bone bank, they are put in a quarantine freezer, minus 80 degrees. And the lab tests are done, the lab tests that were taken from the donor, to check for all possible transmissible disease. So hepatitis B surface antigen, hepatitis B core antibody, HCV, HIV, RPR, and CMV are the tests that are done for every donor. If these are negative, a PCR is done for HCV and HIV to make sure that the tissues are free from any viruses. And the swabs are cultured. Once the results are out, then the fate of the tissues is decided. So why do we do PCR in addition to the serology? Because if a patient contracted the virus within the few days before taking the tissues, the antibodies would not be prevalent in the blood. But if you do a PCR, which detects the antigen, you can detect the infection within 24 hours. So what's the reason we do the serology first, then the PCR? It's for financial reasons, because the PCR is expensive. So we do the serology. If the serology turned out to be negative, then we do the PCR. So what is the fate of the tissues? If the serology is positive, the tissues are discarded. If the microbiology is positive, then we check the organism. If it's Staph epi, we ignore it. If it's Clostridia or Cryptococcus, the tissues are discarded. Other than this, if it's Staph or Strep, then the tissues could be irradiated with 2 megarats. So then, how are the tissues stored? There are 2 techniques for storing these tissues until they are used. Either we put them in ultra low deep freezers, -80 degrees, or freeze dried. For freezing, why is it -80? Why can't we put it just in a freezer? Because -80 degrees or in liquid nitrogen, the minimum is -80 degrees to stop any activity for all degrading enzymes. If it's less than this, if it's more than this, then it doesn't work. If we put it in -80, we can store the tissues for up to 5 years. And these are the -80 degrees freezers. They're connected with an alarm system. They're backup freezers with a UPS just in case electricity fails. The other technique for storage is by doing freeze drying. What is meant by freeze drying? Freeze drying is you freeze the tissues and then you apply heat but under vacuum. And what is the reason for that? If you just heat the tissues shrinks and all its structure is destroyed. But if you transform the tissue into a block of ice and then heat it under vacuum, it's transformed from the solid state to the vapor phase without passing through liquid phase. So the tissues maintains its structure and it doesn't lose its structure. So this is the other technique for storing tissues, freeze drying. And these are the shape of the freeze dryers. We have to just mention that freezing and freeze drying are only methods for storage. They are not methods for sterilization. So if the tissues is contaminated, it's not corrected by freezing or freeze drying. Freezing and freeze drying are only for storage. The next step following this storage is to process these tissues. If you have a femur and you want to use it as a graft, you can mill the femur, you can use dowels, you can use struts. But if you're going to manipulate these tissues, they have to be under sterile conditions in a laminar airflow room. The large segment allografts are photographed or X-rayed to detect the sizes, to make sure they have no cracks or cysts. And once you have these measurements, the tissues are then ready to be used. If tissues are contaminated, they're sterilized by gamma irradiation or ethylene oxide, and then the tissues are released. And every tissue which is released has to be followed up to make sure that no problems appears from it. And this is the packaging. The segment is put with how to use, and another swabs are taken before it's used. This is the freeze-dried component. So what are these allografts used for? They're used to reconstruct large defects following tumor resection. They're used to fill bone cavities, to restore bone stock following revisions of total knees and hips, for spinal fusion, and for ligamentous reconstruction. I'll give a brief summary of what we do in our domain of orthopedic oncology following resection of bone tumors. This is an example of an osteosarcoma of a distal femur. Following resection of the specimen, you can see the gap. And this is the allograft distal femur, which is transplanted. The capsule is sutured to the capsule of the host, and the allograft is fixed with a plate to the host bone. And you can see the X-ray, and then 6 months later with fusion, of the allograft to the host bone, and complete fusion. Another example of osteosarcoma of the proximal tibia, reconstructed also with an proximal tibial allograft. You can do even hemi-joint reconstruction of an osteosarcoma of the tibia. You can remove, after removal of the half of the proximal tibia, and reconstruction with an allograft. Another example of a chondrosarcoma of the distal femur, and then using an allograft to reconstruct it. You can use allografts to reconstruct areas in the middle of the bone, not including the joint, like in this case, the allograft fixed with plates. And you can use even combination of an allograft and a vascularized fibula that is inserted in the allograft, all these techniques to reconstruct the bone defects following tumor resection. You can even use allografts in combination with prostheses, like using after resecting of the femur and reconstructed with an allograft prosthesis composites, like in this patient. So the average union time for allografts is around 8 months. The average functional score for these patients is 70 to 80%. And the function of the allografts actually improves with time. Once it's united, then it behaves like a normal bone. There are related complications. 10% of them get infected, 10% could be fractured, 10% do not unite and needs bone grafting. If you're reconstructing a joint, there might be joint instability in around 12%, and you get arthritis in the osteoarticular allograft in some cases. However, large segment allografts are inexpensive compared to sophisticated prostheses. They're an effective method and a durable reconstructive method for overcoming bone defects resulting from tumor resection. So now, is there a need for bone allografts in Egypt? We did a study on the patients who required bone grafts in general in our orthopedic department and found that 14% of patients operated last year required musculoskeletal tissue transplantation. And this need is expected to increase every year because limb salvage became a standard procedure instead of amputations. There is an increased incidence of revision for total hips and total knees, and there is increased incidence of traumatic bone and soft tissue defects, and there is an increased incidence of spinal fusions. So we expect this figure to increase every year. So I hope in this lecture that I covered the question that I started with my lecture, that this bone transplantation actually is not something new. It's different than organ transplantations. These tissues are dead. They act in different ways than the liver and kidney. And we take our sources from living donors or cadavers. The bone bank does procedures that aims at delivering safe and reliable tissues. And the allografts could be used in a variety of things in the spectrum of orthopedic surgery. We really need to promote bone transplantation in Egypt. There are other alternatives, but bone transplantation should remain as one of the armamentarium in reconstructing bone defects. This is where the bone bank is in Asr Al Aini University, and I'd like to thank you all for listening to this lecture.
Thank you, Professor Walid. As usual, highly illustrative lecture about the bone bank and the value of bone grafting in general, and how far we are in need to modify our task in this. I can ask the floor if there is any question to Professor Walid.
May I ask a short question about when would a prosthesis not fulfill the requirement and you are in need of a graft?
Okay. Prosthesis, tumor prosthesis which reconstruct part of the bone, like tumor prosthesis which reconstruct even the whole bone, they do well, okay, but prostheses in general they do not last for life. They have a lifespan and then they have to be revised. And most of the patients with bone tumors are teenagers and young patients. So for example, a patient with an osteosarcoma who is 15 or 16 years, and you resect it and put a prosthesis, the prosthesis would do well in the beginning, but after 7, 8, 10 years, when he's 25 years, he has to revise the prosthesis with another one. And then so on and so on all through his life. So, and prostheses have their problems as well. The opposite is with allografts. Allografts don't do well at the beginning until they unite and then they become part of the bone. But once they unite, they stay for life. So it's different. And there are indications for this and there are indications for this.
Professor Hani, yes.
Yes. Yes.
A nerve supply.
Yes.
But I think the bone, especially the skull, was successful to print it by 3D. So is there any experience in the abroad about doing this instead of getting the?
Yes. We've been doing this also. Not 3D with bone tissue, but 3D with other tissues like titanium, nylon, etc., to shape a bone instead of the defect that we need to fill. The problem is it doesn't unite to the tissue. It's comparable to the prosthesis, but much less expensive and with the same durability. But it's not a biological reconstruction. Eventually it will fail and it will need revision as well. Especially, and it's different from the skull because the skull is not a weight-bearing tissue. It won't wear off quickly, but the femur and tibia, no, they're under a lot of stress and they could fail easily.
Any further question? Yes. Yeah. Thank you, Professor Walid.
Please accept the shield of appreciation, please.
Now, I am delighted to introduce the international figure and the man who is pioneer in the field of cardiac surgery, Sir Magdi Yacoub. And the title of presentation of Sir Magdi Yacoub is the need for heart transplantation.
غالبا ماله عشان عدى الوقت بتاعه عدى الوقت بتاعه لان هو المفروض كان يخلص.
I believe we might ask Professor Magdi to record the talk and we can present it anytime further, either today or tomorrow. You can ask him to record. أو نشوف كده احنا نستنى.
Hi, Faisal.
Hi, how are you, Howard?
Good.
I hope Jamal will let us go now. I don't know how to contact him by telephone, just not to have break and then.
Right, there's a break now, right?
Hi, Faisal. It's Steve.
I'm sorry for this, but
Yeah, it's any other day it wouldn't matter, but we're kind of getting killed here, so I do have to go back to the ICU. Did you get the video?
I got the video.
We are now going to move to the next session, which is a very peculiar.
Okay. You need me to display Dr. Steve presentation? No, he's here.
You've got it?
Developing countries. The session is moderated by the immediate past president of the International Society of Organ Donation and Procurement, Professor Faisal Shaheen from the Saudi Arabia. And we are honored to be co-chairing this session with the team of the ISODP. Professor Faisal, are you online?
Yes, I am. You hear me? Did you hear me?
Dr. Faisal Shaheen.
Yes, I am with you. I am with you.
Yeah, أهلا Dr. Faisal, welcome. يعني we hope you are with us physically, and probably we wish to have you in, and welcome you in Cairo next meeting, inshallah. Please lead the session, please.
Thank you very much.
Honored having our co-chairs, Professor Muhammad Awad Tajuddin, Professor Adel Adawi, and Professor Rashad Barsoum, and Professor Maya Hasaballah, and with the colleagues from the ISODP. Please proceed.
Thank you very much, Prof. Jamal, and I'm very happy to share with you and to work with you in this very important Congress in a very important area in the world, which is lacking behind transplantation. And the idea was mainly from Prof. Jamal that ISODP should share and work together with the African country in order to promote organ donation. And as the past president of the society, and we have today the current president, Steve, and also Howard, which is the dynamo of the ISODP. I hope that in the future we will do something with you together in Africa. Without further delay in the program and in our talk, and we will have today three eminent speakers from ISODP, Howard Nasson, and Stephen, which is the president of the ISODP, and our co-worker before, and the very well-known figure in the Arab world and the Middle, Dr. Bishr Attar as well. Without again, we will start immediately now with Howard, if you are ready. Please, Professor Howard.
I'm trying to share my screen and it says someone else is sharing the screen. I can't do it.
So can we help in share the screen with Howard, please, Prof. Jamal, or technical people from there?
Yeah, allow sharing. Allow to share. It will be allowed.
You can now share it.
Can you share now?
No, it's not letting me.
I think you can share it now, yes.
Why don't you go ahead and let Steve go ahead, Faisal?
Yes, Steve, probably you can. We can have your talk now, if you don't mind, till Howard fix this one.
Or I'll try and do the same thing. I'll try and Can you see my screen?
Yes, we can.
Okay. Well, thank you very much. My apologies because I'm covering the intensive care unit right now, and so I'm going to thank you very much for the invitation. But I may have to leave as soon as I've finished this. So I just need to acknowledge that up front because we're in a bit of a COVID mess right now. However, this is a wonderful opportunity for me to be able to connect with you in my role as the president now of the International Society of Organ Donation Procurement. My other role is as the medical director of the organ donation program here in Halifax, and I'm an intensive care physician who is really at the bedside more than administratively. So I still consider myself a clinician. And I'd like to talk to you about deceased donation in the ICU, even though I certainly know that in Africa, live donation is much more common, but deceased donation is something that I will cover in this brief window of time. So what I hope to go through is neurological death and the physiology associated with it and why that is relevant to what we may or may not be able to transplant, something about donor identification in the ICU, and a very brief overview of the key issues around management of the deceased donor.
Doctor, please.
Yes?
We can see your screen, but not the presentation.
You can't see the presentation?
Steve, we see your
We see
email.
a list of topics.
We
Oh,
see your email. We see your email.
okay. Well, I thought that was, okay. What do you see now?
Still the list, and you are trying to click it.
Okay. I'm looking at my presentation. You're not looking at my presentation? Okay.
Waiting to be activated.
Try that again. Is that, it says to me that I'm sharing the screen.
But we only see the list.
Okay. I'm not quite sure what the technical solution for that is then.
Doctor, if you are connected to two screens, you have to unconnect one of them.
I have to disconnect?
You have to disconnect one of two screens in front of you.
Okay, I will close this. I'm not sure. What are you seeing now?
Still the same.
Still the same thing.
Okay,
The list and your photo. Try to disconnect and connect once more.
Okay, I will do that.
We see you only now.
Okay, and I will try and share the screen again. Why don't I actually open the presentation? Do you see it now?
Still the list. We
Wow.
return to the same list.
Okay, because I'm seeing this presentation. I will stop again. Or I will try and open the presentation on my desktop. Maybe that will make it.
Yeah, I think open it on the laptop, yes.
Yes, okay, we'll give that a shot.
I believe you need to open it in the laptop screen first and then start sharing and select the opened one.
That's what I just did.
Yes. Yes. Full screen.
Now you can see it?
Yeah, full screen now, yes. Make full
Okay.
screen. Yeah, great. Go ahead.
Oh, technology, wonderful when it works. Well, again, thank you for the invitation. I will go through this fairly quickly. The objectives I hope to cover are focused on neurological death and the physiology, donor identification in the ICU, and some key points around management of deceased organ donor, knowing that this is a much more complicated topic. For deceased organ donation, we're talking about typically donation after neurological death or brain death in most cases, or donation after cardiac death, which is DCD, cardiocirculatory death. There's a variety of ways to describe it. And so one of the things that we have to appreciate is that the herniation of the brain, when there is a severe injury from trauma or a bleed or something like that, is really a catastrophic physiologic event. And broadly speaking, there are two issues that relate to end organ problems. One of them is the sympathetic storm that accompanies a rise in the intracranial pressure. As the pressure gets higher and higher, the brain is trying to perfuse itself, and catecholamine levels will surge to dramatic levels in order to increase the blood pressure to perfuse the dying brain. And of course, blood pressures of 250, 350 are what we see during that terminal event, the Cushing's response. And the blood pressure changes there related to the sympathetic storm are going to affect end organs. You know, neurogenic pulmonary edema, a stunned heart from a catecholamine-induced cardiomyopathy are examples of how that would be a problem for an organ that you wanted to donate. And accompanying that enormous increase in sympathetic tone is an inflammatory storm as well, with pro-inflammatory cytokines being released. And the end result of this event is that the organs that we would ultimately like to transplant may very well be affected by those things. So the physiology around this is important, both to understand why the end organs might be an issue, but it also helps the clinician anticipate what clinical problems they may need to deal with in managing the potential donor as well. Historically, the concept of neurological death or brain death is relatively recent phenomena. Certainly when the modern intensive care units were established in the 50s as a result of polio epidemics, the idea that if you were to mechanically ventilate people who were otherwise healthy, you could keep them alive was part of the genesis of the intensive care unit. And so once you had a whole population of people who were supported in an ICU on a ventilator, some clinicians noticed that some of those people would be on a ventilator, but looked like they had absolutely no neurological function. And in late 50s, that was described as le coma dépassé. And of course, we now recognize that that would be compatible with a diagnosis of neurological death. And Henry Beecher at Massachusetts General and Harvard put together his committee that established the Harvard brain death criteria in the late 60s. And that has been a sentinel work that has more or less established the standard for this diagnosis for many, many years. And in the general introduction of this concept to the clinical world, the idea that somebody would in fact be dead when their brain was dead was over time generally accepted. The next large shift, if you will, in terms of organ donation was a review in the mid-90s of what's called the Maastricht criteria around non-heart beating or cardiocirculatory death and donation from that source. And now in much of the Western world, DCD is a substantial contributor to the organ donor pool. In the UK, it's almost 50% of their donors. In many other jurisdictions, 20-30% of the donors might be DCD donors. So things have progressed over time clinically. It's important for us to recognize where the potential organ donors might come from when we're talking about deceased donors. And although it varies somewhat, traumatic brain injury continues to be a major source for organ donors. And in Africa, where traffic accidents are a huge, huge problem, obviously, perhaps your numbers for traumatic brain injury would be much higher. Vascular injury is becoming the more dominant source of donors in certainly in Canada, as people are a little more elderly, they have high blood pressure, they have strokes or aneurysms in their 50s or 60s or whatever. And then there's a population who would have severe anoxic injury from drowning or resuscitation after cardiac arrest or carbon monoxide or something like that. But this is the donor pool. And if people in your ICU have these conditions, you may need to recognize that some of them will go on to qualify as organ donors. It's also important to notice that these are all catastrophic illnesses, which means their family, their circle identified them as healthy just hours before their catastrophic illness. And that makes the management and the conversation around these difficult topics all the more difficult because families are just overwhelmed. It's important to acknowledge that although neurological death is a widely accepted clinical diagnosis, it's not universal. And I've highlighted that Africa as a continent in particular has many countries where there are no recognized protocols around the determination of neurological death or brain death. Much of the world has worked on this, not universal by any stretch. And Africa in particular is a continent where these issues are issues we'll probably be dealing with in the future. This recent publication that summarized that highlights the fact that a substantial number of countries do not have brain death protocols. And the clinical criteria to diagnose brain death differs much more widely than you think it might. For a protocol on something that seems to be so binary, you are either dead or alive. It doesn't seem like there should be a lot of gray in that, and yet seemingly there is. There's quite a large variability in the way brain death is diagnosed. And that's not ideal, obviously. Clearly, medical standards for death should be the same everywhere, but we cannot fail to recognize that the death is, and recognition and acceptance of death is very, very much dependent on science, but also cultural, societal, and religious issues are going to impact that for sure. I mentioned donation after cardiocirculatory death, and as you can see from this graph, it is largely the Western world, but over time, more and more countries are accepting DCD as a conduit to organ donation. There's a variety of categories: controlled, meaning that somebody is in an ICU and there's a decision to go to comfort care and you allow the patient to pass, versus uncontrolled, which is an unsuccessful resuscitation. Some countries do both. In many countries, it's sort of one or the other. And if we talk about developing a deceased donation program, we need to be clear that some of the things I'm highlighting in the ICU are really just a tiny piece of a large puzzle. If you want to talk about a very high-performing system, if you will, it's much, much more than just what's going on in the ICU. Although as an intensivist, I would argue that's clearly crucial. For the interested clinician, there is an abundance of information out there on how to manage the potential organ donor. At least 27 published guidelines for many, many different countries. You might credibly ask why we don't standardize this. And there's a big project called the World Brain Death Project, where maybe we will work toward a more common way to make this diagnosis and maybe a more common way to manage these potential organ donors. The message here being, though, that there is a lot of information out there on what to focus on if you have a potential organ donor, or if you have a consented and declared organ donor and you're supporting them until organ procurement occurs. There are things that we really need to do clinically to optimize the chance for those organs to be successfully transplanted. And in the ICU, I'm going to broadly focus on 4 areas. And this is very superficial, but it gives you basically a snapshot. As a clinician, obviously, we're focused very commonly on heart rate and blood pressure. Those are things that we see on every patient. And generally, the guidelines we would advocate for organ donation management are what we would be doing for just about every other patient population. We would focus on the mean arterial more than the systolic. We'd like a mean of at least 65, but this patient population are definitely at risk for a low blood pressure or a low cardiac output state. The low cardiac output may be because they are hypovolemic, like a trauma patient who is bleeding. We used osmotic diuretics that decrease their intravascular volume. The herniation of the brain leads to that sympathetic storm, and you get a catecholamine-induced cardiomyopathy, so the heart doesn't work particularly well. So a low cardiac output state from hypovolemia or intrinsic ionotropy would be a challenge, and we see that. And even if that's not the only problem, a relative low tone state, as vasopressin, amongst other things, gets depleted, will complicate our management. So these people are often hypotensive and have a low cardiac output. And the support of that involves volume, obviously, but also vasopressin is a first-line drug to support the vascular tone. Norepinephrine would be the first-line drug to support a low cardiac output state. And it's important to recognize that a heart that looks terrible in the beginning may recover over time. And so serial echocardiography is often done to see what's going on with the heart. In terms of ventilator management, this is important because if you look at who donates organs, somewhere around 90 to 100% of organ donors can donate both kidneys. It's very high. But if you look at lung donors, somewhere in the 20 to 30% of donors go on to donate lungs. So it's quite low, obviously. And it turns out that if you manage these organ donors using essentially lung protective strategies, you can dramatically increase lung donor yield. And these are things that intensive care physicians are very familiar with. Paying attention to the tidal volume, the plateau pressures, appropriate PEEP recruitment when needed. Those are standard ICU things, but if we pay attention to the potential lung donor and use those principles, you can double lung donor yield for the sake of simple adjustments to vent settings. Very important to focus on. Fluid and electrolytes, I alluded to some of the reasons why these patients may be hypovolemic. A hypernatremia is also something we'll encounter. And there was a body of literature some years ago that suggested hypernatremia would impair liver graft function, for example. And there was some discussion of whether it would influence cardiac and lung as well. The time has shown that that's really not an issue. So our focus would be relatively normal sodium levels, not too high, not too low, as opposed to a specific target. So 160 would be too high, but if they're 150, we're not particularly concerned. Metabolic issues, that comes up commonly, and recent publications showed significantly better donor kidney graft function when mild hypothermia was seen in the donor. So we are less vigilant regarding normothermia, if you will, in this patient population. Diabetes insipidus with a severe brain injury is quite common, so we're often using DDAVP. And there was clearly a momentum some years ago to use hormone resuscitation therapy. This article almost 20 years ago showed a substantial increase in organ donor yield when hormone resuscitation therapy was used. Time has shown us that perhaps the signal wasn't as strong as we hoped it would be. Perhaps the centers that were forward thinking enough to consider hormone resuscitation therapy were doing other things that were contributing to better organ donor yield, because we've seen over time that thyroxine actually does not substantially improve organ donor yield, not routinely recommended. Vasopressin, clearly for low tone states and for diabetes insipidus. Glucocorticoids, steroids, are used sometimes for another medical condition that would be steroid responsive, and sometimes for lung donors, but not routinely, if you will. So just to summarize a big topic, neurological death is a widely but not universally accepted diagnosis, and the protocols differ. So work on uniformity through the World Brain Death Project, for example, is something to look forward to. Most of our deceased donors have neurological death, but cardiocirculatory death is a huge contributor in some countries. The donors that you'll see depend on where you are, and in Africa, traumatic brain injury may be a very, very common problem. But the take-home message for our intensive care colleagues is that good donor care is really just good ICU care. There's not a lot that is truly donor specific, but I think the clinician needs to take the attitude that an organ donor, while clinically dead, is still a patient that we should manage as aggressively as we would anybody else, because the donor family really wants this to happen, and the recipients, whoever they are clearly going to benefit from organs that are higher quality. Thank you very much for your time.
Thank you. Excellent talk, Steve, as usual. And it is an issue which we need to understand it very well in our area here about the deaths and brain deaths and how you utilize the organ. I know that you are busy and we keep you late, and I'm sure that if there is any question, the Prof. Jamal can address it to you and you will answer the people. So you will not keep you long as you are busy, as you mentioned before.
Well, yes. Thank you very much, Steve, for your excellent presentation. And let me ask you about the impact of the duration of keeping a case on the ventilator, and whether you benefit of that time by any pre-treatment with targeted immunosuppression to manage the dendritic cell and endothelial cell epitopes of the grafts.
Well, it's an interesting question. Certainly the time between declaration of neurological death and going to the OR for procurement is a bit of a balancing act. There is some evidence that continuing to support the donor to optimize potential organ donor function, for example, mostly optimizing hemodynamic support and giving the heart time to recover more so than specific immune modulation, may be of some value. So there are competing interests. In the one hand, extra time may very well enable us to optimize organ donor function and improve successful outcome with whatever modality, whether it's immunomodulation or it's appropriate hemodynamic support. But the other side of that is that you have families who have gone through the worst thing you can imagine. And very, very commonly, when the diagnosis of neurological death is made, many families are exhausted, and if it's going to happen, they just want to have it happen now. So extra time can be helpful, but not if it means that the family would withdraw consent. And so the situation is determined case by case as opposed to protocolizing it. A couple of days is often very helpful. If we're extending that to 3 or 4 or 5 days, which on rare occasions we've done mostly for social reasons, it becomes a major problem with the family. And it's also occupying an ICU bed and delaying transplants. So the balancing act has to take into account family needs as well as clinical needs.
Thank you.
Excuse me. Thank you, Steve. I'd like to talk to you about, I am Adel Adawi. I'm the former Minister of Health in Egypt. And basically, I'm orthopedic surgeon, so I'm not specialized in nephrology or in organ transplantation in general. But I'd like to thank you about your talk about how to take a critical decision regarding detecting and managing donors in the intensive care units. May I ask you, some patients in the intensive care units, they are going to suffer from multi-organ failure just before that. And this may last for some time. If the kidney or liver of these patients are capable to be properly donated after that, or it's much better to take a healthy kidney from a donor? This is a basic question, but I think this may open the door for a great discussion about if the kidney, for example, or the liver failed for a very long time, if this kidney would be healthy to be donated after death or not?
Well, if you suffer neurological death, then you may have single system problems, or you may have a neurological injury in the setting of a bad car accident. So a bunch of things are a problem. If you have a vascular injury like a stroke, then the same issue is in play, except you probably have vascular disease. So maybe your kidneys or your liver or whatever are a problem. The bottom line is that the conclusion that you've got other bad health troubles means you can't donate any organs is just premature. It is possible that somebody who has significant multi-organ failure and who's going to die from that might have an organ that's relatively preserved. We've certainly seen people who looked like they had severe multi-system disease that they were going to die from, but their liver was remarkably robust, for example, or people who have clearly got substantial trouble with their lungs, and yet their kidneys are quite good. So the assessment of each individual organ donor and each organ that might be used for a transplant is the key thing. You don't write somebody off simply because it looks like multi-system disease, but clearly the risk of being able to successfully transplant is dependent on how much is going wrong. So the key, I think, is that people who don't deal with this commonly need to understand that a complete medical assessment is necessary. Don't just write somebody off because they look like they're multi-system. Sometimes they are, but the kidneys are still good or whatever. And that message is often lost on the public. We've often had people who say, I'd love to be an organ donor, but I've got diabetes, so I guess I won't be able to. So the messaging around how you can donate needs to be almost patient specific and organ specific. Your point about multi-organ failure is well taken, but sometimes people who are very sick from a bunch of problems still have a liver or kidneys or something that could be transplanted.
Thank you very much, Steve, for your talk and for your time. Thank you.
No problem. I've got to run. Thank you. Have a good meeting.
Good. Take care.
Bye.
So, yes, that's okay. So Howard now, is it fixed? The problem is okay.
Can you see my screen?
Yes.
Can.
Great. Faisal, thank you very much. And Dr. Bede, thank you for your great lecture on ICU care and organ donation. One of the things that I wanted to discuss was to talk a little bit about organ procurement organizations and components of a successful donation system. I first want to congratulate everyone in the audience and the organizers for this wonderful meeting. And we're very honored that ISODP is a small part of it. So thank you very much. First of all, I wanted to talk about what's happening in donation throughout the world. You can see these are deceased organ donors over a period of time in what we call donors per million, or the number of donors per million population. And you can see over here, South Africa, we don't have all the data, but they're at about 3 or 4 donors per million right now. You're going to hear from Saudi Arabia, and they're at about 4 or 5 donors per million. And so you can see over time that some of the other countries like Canada, where Steve is from, is about 17 donors per million. And then Portugal, Croatia, and Spain are higher. And I just did want to point out the US is at 42 donors per million. And last year, we think that's one of the highest in the world. And then my organization, which is a regional OPO, which I'll talk about in Philadelphia, is at 64 donors per million. And we think that's one of the highest anywhere in the world. Steve talked about what happens in the intensive care unit. And what I've laid out here is sort of the process of how donation takes place. And first off, you'll see education. And education is crucial in educating the public about being an organ donor after death, and also educating the healthcare team to recognize donor situations, as Dr. Bede outlined. Detection, the declaration of death, and the referral is the key to the process. That's what Dr. Bede was talking about. Then that donor is evaluated to determine suitability of what organs are suitable, and there's a series of laboratory studies and tests that are done to do that. The approach to the family is a crucial part of that, and I'll talk a little bit about that more. The management of the time that the patient's declared dead and till the surgery to remove the organs from the deceased donor is called donor management, and there's techniques to improve organ function during that time. The matching and allocation, which I won't get into detail. The recovery by a transplant team or recovery team, transporting it, preserving the organ, and then transplantation and then follow-up. So in the United States, a law was passed called the National Organ Transplant Act of 1984. I won't get into the details of this, but the bottom line is a restructure from the government on how to have a national system, along with creating the modern organ donation system. It also prohibited the buying and selling of organs by individuals or by agencies. So this is a complicated picture, but here's our government Department of Health and Human Services, and there are several agencies, Medicare, FDA, Division of Transplantation, that oversee organ procurement organizations in the US. And there are 57 regional OPOs in the United States, which I'll touch on in a minute. UNOS is a national network, and it approves all new transplant centers and programs. They operate a computer system for organ sharing and manage the wait list. Every single patient who's waiting for a transplant must be listed on this list if they're waiting for a deceased donor organ. And the allocation and the policies for that are set by UNOS through a national matching system called DonorNet, which is actually accessible by your iPhone, very slick type of thing to do matching. All the data on every single transplant from living donors or deceased donors is tracked, and then they audit the system. And this has been established since 1986. So UNOS has oversight over the organ OPOs and the transplant hospitals who perform it. Now, in the US, there are 57 organ procurement organizations designated by the federal government for certain geographic regions. There are 266 hospitals that do transplants. And United Network for Organ Sharing is responsible for all the data and all the systems related to the matching and tracking of outcomes. In the United States last year, there were 13,863 deceased organ donors, as Dr. Bede described, either from donation after brain death or donation after circulatory death. Living donors represented 6,538, and that's a total of 20,401 donors, which resulted in 44,634 transplants just last year in 2021 in the US. And this is the track record over time with deceased donors. You can see that over time it's continued to increase, and and we're proud of that, the support of the community. And this is living donation. You can see that it plateaued and actually went down during COVID, and now is back up a little bit. So the maximum was around 7,000 living donors. In the US, there are about 106,000 people waiting for a deceased donor organ transplant. You see most are kidney patients who are on dialysis, liver patients, heart patients, etc. These are the territories of the 57 organ donor areas. Gift of Life is in this region, but each region of the country has a organ procurement organization, and they vary in population, but there's only one per service area. There's no competition among organ donor programs. So what's an OPO? It's an organ procurement organization. 51 of 57 of them are independent of a transplant center. They're separate nonprofit organizations designated by the government to be able to perform this task. They're separate from transplant centers and often serve many. They have agreements with the hospitals in the region to coordinate the donation process. So every hospital, in theory, can be a donor hospital, and we'll talk more about that. They're recertified by the government every 4 years, and all the deceased donor organs must follow the allocation process and the list at UNOS in the order of the patient's medical criteria, a matching and waiting time. So I'll tell you about Gift of Life. We're in Pennsylvania, New Jersey, and Delaware in the eastern part of the United States. We're a nonprofit organization, organ procurement. We also perform tissue recovery, as was described by Dr. Waleed before, and also an iBank. We were established a long time ago, 1974. We have 128 hospitals who refer us donors. 14 of those hospitals also perform transplants. We have 11 million people. Last year, we had 705 donors, resulting in 1,732 organs transplanted, and that's the highest volume in the US. We had 64 donors per million and 154 transplants per million. So we've been the largest donor program for the last 14 years in the US, and we're very proud of that. And this is over time. You see, we started with a small number of donors in 1974 and has continued to grow over time. And this is only deceased organ donors. One of the things that happened was that legislation occurred at our state level. And what happened is that referrals from intensive care units were not routine. And so we asked a law to be passed that mandated hospital ICUs and other places in the hospital to call us on every single person who died, so we could set the funnel wide so we wouldn't miss any potential donors. Well, we increased organ donation 43% over 3 years from this legislation. And it was unheard of when the rest of the country was only going up 1 or 2%. It was so successful, our federal government mandated that every hospital in the country have a contract with organ procurement organizations, and that every single death is reported to the organ procurement organization. Some of those patients obviously are not suitable donors. Some of them can be tissue donors, and then the ventilated patients can be potential organ donors. So the relationships between organ procurement organizations, donor hospitals, meaning intensive care units, as Dr. Bede described, and the transplant centers is crucial in order to set up a deceased donor program. The most important part is that phone call to the organ procurement organization on ventilator-dependent patients with a non-recoverable neurologic injury that may lead to brain death. And again, these could be car accidents, these could be gunshot wounds, these could be aneurysms of the brain. The thing in the US is that we send staff to the unit to evaluate the donor. We talk to the family and with the physicians who are present, and we do a collaborative request with the hospital staff. I won't get into this detail, but when we started, we had one employee, one transplant coordinator. And so a long time ago when we started, and this is to give people encouragement here in Africa, that donation starts small. We now have over 250 employees, and we have quite a set organization. When I was a transplant coordinator, I was the third coordinator here, and now there's over 250 employees with all different departments and functions, but the basic offering of donation to a family is the same. And this is done by a transplant coordinator. Often in the US, this is a former critical care nurse. In places like Spain, they actually use critical care physicians. And in Canada, sometimes the physicians and coordinators work together. But the idea is to have that referral to come on site to the hospital, to evaluate the medical suitability, to talk to the family, to perform that management process to improve organ function while the patient's on a ventilator that has already been declared dead, the allocation, the coordination, the recovery, et cetera. So our coordinators are crucial to the process to talk to the family along with the attending physician to offer this as an option when a family has no other options. Everything has been done. The person's either determined to be brain dead or the family voluntarily decides to withdraw the ventilator. When the heart stops, then that can be a donation after circulatory death. In the US, one of the ways that we did public education was to put organ donor on your driver's license. And most everyone who's an adult has a driver's license. So this system is in all 50 states, and it's called an opt-in registry versus an opt-out registry like in Spain and other European countries, and now and recently the UK. But there are 163 million people on the registry, and that represents about 63% of all people who have driver's licenses. So this is a legal document that we actually can act upon. It's called an organ donor designation, and it's a great way to educate the public that this is an opportunity. We do a lot of outreach in the community, particularly in churches and schools and youth education, and certainly with a lot of social media interaction between our organization and the public. So in general, what do you need to do to set up a donation system? Well, one of the first things is to have regulatory and legislative requirements for, as Steve said, for brain death declaration, for gifting an organ, we call it the Uniform Anatomical Gift Act, and for setting up some legal requirements eventually for hospitals to participate in the system. When you develop a national system, you need a system for sharing the organs that's fair and equitable and based on patient need and how long perhaps they've been waited. Collecting the data and following the transplants and the donations, and then an organ procurement organization to have best demonstrated practices for integrating with donor hospitals, having proper staffing, and community education. So that's the circle that needs to happen to develop a donation system. Going back to this process, with education, declaration of death and referral, et cetera. The idea is follow this ideal process, and donation is understandable to the public and to critical care physicians. We call it the power of one donor at a time, one family at a time, one transplant candidate at a time, and then each of you who have the opportunity to help develop this system in your country in Africa. Thank you very much. Happy to answer any questions.
Thanks, Howard, for this excellent talk.
Thank you very much for your excellent expose about the experiences of the transplantation system in the United States. Just a very small question for you about is there any support for the patients or for the donors from the societies or from the government?
Well, it's illegal to pay for donation in the United States. So there's no payment to a family in the US. The opportunity, we do actually have a law in Pennsylvania that allows us to offer a couple $100 for funeral expenses that's paid directly to the funeral home. But there's no cash compensation to the families.
Excuse me. We are not talking about compensation or financial compensation. His Excellency is just asking if there is any sort of any social incentives for donors or reimbursement of the effort that they have paid.
No, not in the US. In terms of social support, certainly we have family support services after the donation to support the family and counsel them and help them with their grief process. But there's no other, that's the level of support we're talking about, social support.
Okay. Who will pay for the hospital accommodation and the interventions and surgical intervention?
Yeah.
And also if there is any post-operative complications?
Yes, I'm sorry, I misunderstood the question. So the cost related to the donation process is the organ procurement organization. So our budget includes paying for the cost of the intensive care unit, for evaluating the patient as a donor, to pay the cost of the operating room, the matching, all that comes to this independent organ procurement organization from outside the hospital. The family is not billed for any of those costs.
Okay, if the donor is working in private company or his private special work, who will compensate for the loss of time and the loss of work for between 2 or 3 weeks?
Okay, so that's living donation. What I talked about was deceased donation. Living donation, there are programs that help compensate people for loss of wages or any of their expenses on the living donation side. But OPOs are only involved in deceased organ donation after death. So we're not involved with living donors as you have in your country.
Yes, excuse me, I understand that for living donations, there is the donor shield that so many benefits for the donor, for reimbursement, for the lost wages, for the travel expenses, accommodation, and to have a priority in case he needs to be transplanted himself, etc., etc. So this applies only for the living donations, not the cadaveric.
That's correct. So you're correct. There are grant programs to allow reimbursement of the person's wages for a couple weeks, and also related to priority. If this person needed a kidney, if they donate a kidney and they have kidney failure, they actually get extra points on the system to come to almost the top of the list to get priority if they need a kidney.
Let me ask you probably a last question for you, Nathan, please. For the living donation, is it centrally regulated by the UNOS system, or is it haphazard? Any donor can give any recipient? Is it regulated?
The living donor situation in the US is monitored by UNOS, and reports of every living donor and every living recipient, the data must be reported. But who is a donor and how they're evaluated, their suitability, whether they're relative or non-relative, that's all decided at the transplant center level. And there are guidelines for that, but it's still up to that transplant hospital to make the determination who's the living donor and who's the recipient.
Is it regulated on the level of each center alone or a central regulated system?
It is not centrally regulated.
It's not
It's
centrally.
each center on their own.
Okay, thank you very much. Thank you
Yes.
very much. Professor Faisal, proceed, please.
Very much, Howard, for this excellent talk. Now we move on with my friend and colleague, Dr. Bishr Attar. He is medical director in Scott, and he is, have a very wide experience in organ donation and transplantation and organization of a new program, either living or deceased. Dr. Bishr, please.
Thank you, Dr. Faisal. Good afternoon, everybody. And I'm really pleased for your invitation and participation in this Congress. So in my presentation, I will try to summarize the important stages in the development of our knowledge on the subject of death declaration and to address the challenges and what is agreed upon about the death declaration. So the death declaration always faces challenges. These challenges and difficulties arise from the differences in the philosophical, religious, cultural, spiritual, and even personal differences in the concept and definition of death. And as you know, the difficulty in performing research as prospective study in the field of dying and death process. And until now, we have a lack of understanding and awareness about the public and even among medical healthcare professionals about the death definition. So currently, if you look on the search in the biggest library in the world, which is Google, and I did this exercise only yesterday, if you put the what is definition of death, you will find differences in the answers. It gives you end of life, cessation of life, complete cessation of function of all body organs, or even complete cessation of all vital functions. And for this reason, we have till now the medical and public in general are using unscientific and inaccurate terms. So the word dead for somebody working in the field of deceased donation, we will have different understanding from other party as in public or not related to medical issue. So currently the general understanding among public and even medical society is that death is both the absence of heartbeat as flat ECG and the absence of consciousness, movement, and breathing as cadaver. But from scientific point of view, the biology of life is based on oxygen and nutrient delivery, in which the organs have functional characteristics. So we know that the lung oxygenates, heart circulates, liver metabolizes, and kidney filters. But all are controlled by the brain, which is the center of awareness, senses, speech, memory, and also breathing. So this brain is, in fact, the biology of life is all based on brain function. This brain considered as the most complicated computer in the world, includes more than 80 billion neurons and more than 100 trillion interconnection. And the dying and death is a biological process. So what we know in this process that organ and cells die at different rates depending on their resistance to anoxia. So organs respond differently to anoxic ischemic injury. We know that the brain is the most vulnerable that within 15 seconds, the injury starts, and within 4 minutes, the injury becomes irreversible, while kidney could resist better to the anoxic ischemia. And determination of this is an event in this biological process. Let's see now the most significant example of development of scientific theory. This is the discovery of circulation and the scientist's contribution to it. This theory started with the Hippocrates 2,400 years ago, who thought that the liver and spleen were the two main organs for the passage of blood from the heart. Then followed by Galenus, 300 years after, starting to mention about spiritual blood pressure in the left heart with pulsative faculties, without understanding how the blood transfer from the left to the right side in the heart. Then came Ibn Nafis, and he gave this landmark in the explanation of pulmonary circulation and contradict what has been said by Galenus and Avicenne 1,000 years ago, and mentioned that there is no blood passage from the right to the left, but the passage is through the lungs. But nobody took his theory for 300 years until William Harvey took the credit in the 16th century and make the complete the work of Ibn Nafis and describe the full blood circulation, including the pulmonary circulation. After that, 100 years later, Malpighi, he discovered the capillary vessels and blood exchange and between veins and artery. The other important landmark is the Antoine Lavoisier. He named and gave recognition of the oxygen and explained how between oxygen and CO2 are exchanged in the vascular system. And then the first one who invented the stethoscope, it was in the 19th century, René Laennec. And after that, within 20 years, the first doctor who starts to diagnose this by using the stethoscope is Eugène Bouchot in the mid of 19th century. So only using a stethoscope and to prove the heart stop done only in the mid of 19th century. And this remained valid for 100 years until we start to have the first report of brain death cases. They call it this Mollaret, the French physician, in 1959. He mentioned a report about 23 patients who cannot breathe independently and who are in the deep coma, and they call it le coma dépassé or beyond coma. Few years later, Harvard Criteria, this elegant work, published in the 1968, and this ad hoc committee, very interesting report, mentioned that in the 68, that from ancient times, when the respiration and heart stops, the brain will die in a few minutes. In those times, the heart was considered to be central organ of the body, but this no longer valid when modern resuscitative and supportive measures are used. So with the start of using the intensive care or critical care management, we start to differentiate the meaning of this at the cellular and tissue level from the death of the person. Few years later, after the Harvard criteria, somebody published, and it was known as Minnesota criteria, published about how to diagnose brainstem. And also in UK, this one was discussed in the Medical Royal College Conference 1976 about this elegant work done by Christopher Palace, who wrote about the ABC of brainstem. So the dilemma in the late 70s is brain death or brainstem death. Asked in the United States to form a commission. They call it the President Commission in 1981, in order to define death from the medical, legal, and ethical issue in the determining of death. And at that time, consider that irreversible cessation of circulation and respiratory functions, or irreversible cessation of all functions of the entire brain, including the brain stem. And this is get an international global consensus at the time. So the continuous scientific research, especially in the second half of the 20th century, led to the development of sciences and biological knowledge. This led to a better understanding of the death process due to discovery of physiology of the heart, the daily of heart transplant, heart surgery, the practice of ICU life support, even extracorporeal life support as ECMO machine, the cell biology, and organ donation, preservation, and transplantation. And what was being mentioned by Howard, that organ donation, if we look on the GODT, we have a great experience every year. As last year statistics, more than 36,000 deceased donors performed in the last year worldwide. The majority of them, more than 28, in the form of donor biologic criteria, while around 8,000 from donation after security arrest, and this with the practice of more than 130,000 organ transplantation performed per year. But of course, there are some variability mentioned by Dr. Steve Bede. Yes, we have some article came out, and this is example about brain death worldwide, accepted fact, but no global consensus in the diagnosis. Other mentioned about difference in the hospital policy, even among the same country. And even we have report about variability in brain death determination in Europe, asking for solution about that. But if you look on this examination, what are the variability on brain death determination? And this is presented by Dr. Sam Shamie from Canada. He is a critical care, well-known, and this published in the Canadian Journal of Anesthesia. We found that the variability is among the when to apply the apnea test, what are the observation time, what are the age-related criteria in order to document or declare death in children or small age group, what is the physician practicing the protocol, and are we using confirmatory tests or ancillary tests in order to confirm the clinical examination, and of course the variation in the legal standards in determining brain death. This is the paper referred to it, Dr. Bede, about national perspective on diagnosis of death, published in British Journal of Anesthesia in the year 2012 by Gardner and Shamie Manara. This is the known critical care practitioner from UK, Australia, and Canada, in order to adopt a universal clear definition for death and to review the physiological process for the cessation of the circulation and cessation of cerebral functions. And they came out with unifying medical of death, that all death is diagnosed by confirming the irreversible loss of the capacity for consciousness combined with the irreversible loss of the capacity to breathe. And the most appropriate set of criteria to use is determined by the circumstances in which the medical practitioner is called upon to diagnose death. So either is somatic criteria, when we have patient arrive dead to the hospital, we don't have to prove that to make the resuscitation measure, we have low body temperature, stiffness of the corpus, but we have security criteria that when we have a circulatory arrest, we have to adopt the CPR and it is failed after 20 to 40 minutes. We have to have 5-minute no touch before to pronounce death by security criteria. And for neurological criteria, this is in general patient in comatose and intubated in the ICU. Interesting paper also published by Sam Shamie and Dale Gardner about the physiology, the three physiology mechanism to when we have a death determination. So either it's primary or secondary brain arrest, it leads to respiratory arrest, which lead to circulatory arrest. We have primary or secondary respiratory arrest will lead to respiratory, lead to circulatory, and then it will lead to brain cessation of all function, or the arrest will lead to the cessation of all brain function. Here is the paper about variability and brain death determination. As you can see, there is no concern about how to apply the brain death documentation, clinical examination. But the problem and variability in European country is about minimum observation period. Should we wait 1 hour, 2 hours, 6 hours, and there are variability. How to determine, to declare death among the brain death? Is it vary from 1 to 4? The examination should be done 1, twice, or 3 times. Also, there are variation in this one. Example, in Canada, they have 0 minimal observation time. In Saudi Arabia, we are by law that we should wait 6 hours at least before to start the application of the brain death protocol. Our examination, according to our national protocol, it should be examined by 2 physicians and repeat the test twice. This is the definition of death biology criteria around the world, mentioned as well by Dr. Bede, that there is variability, but mostly this variability is about what is the accepted ancillary test and when to apply the ancillary test in order to determine brain death. And here the majority that they apply the ancillary test when we have inability to complete the examination or inability to complete the apnea test or even to shorten the decrease of the observation period. And the most important paper came out in August, published in August 2020 by the World Brain Project. And this is include all international society in the field of in the field of critical care, neurology science, neurosurgery. They came out with this report and they provide recommendation, minimum clinical standard for determination of brain death. And we can see that brain death worldwide is very consistent and based on clinical exam, which is deep unresponsive coma, established cause, absence of irreversible condition, absence of confining or confusing condition, and absence of the motor examination, areflexia, and breathing, inability to breathe. I will skip the study about test for brain blood flow. And just example before to conclude about for our colleague who still believe in the heart is the main for personality, that this is the first heartless man. He lived 5 weeks without heart, without pulse, without ECG flat, with personality and personhood. And this is the Britain woman who lived, she carried her heart in the backpack as artificial heart. And this is the living organ we use in daily practice from dead person before transplantation. So we have a living organ from dead person. I heard this last achievement this month that the first man get transplant from genetically modified pig heart. The age of 57, he received a heart from pig. So it is important for physicians to be aware of the medical, legal, and ethical issues regarding death declaration. And death for physician is the end of the human life in the body. And that does not mean the death of all cellular life in the human body. And the availability of strict criteria is very important, because if we apply the protocol, the exclusion criteria, inclusion criteria, and clinical examination, certainly there is no room of mistake in the death declaration. And on an ethical point of view, the eligibility to ask for deceased donation is after death declaration is being done according to the national standard or international according to what we live with. So in summary, ladies and gentlemen, that science and technology have always and will continue to profoundly change our understanding of life, death, and human identity. And there is only one death, is the brain function, based on the cessation and arrest of brain function. are two ways to arrive this, either direct injury, catastrophic brain injury, or arrest of circulation, which lead to the arrest of brain function. Thank you for your attention.
Thank you, Bishop, for this excellent talk.
Thank you very much, Professor Bashir, for the excellent presentation. And let me ask you concerning the variability in the different criteria worldwide about declaration of brain death. Regardless of this variability, are any conflicts about the criteria for diagnosing brain death considering the maximum requirements? Am I clear?
Yes, as the differences, as I mentioned briefly, that is about when to start. Should we give a more chance in the ICU before to apply the clinical examination? And what is the expertise level of the physician to practice the death declaration? And how many exams to be done? And if it should be repeated or not. I give you an example. In the United States, it's done by one physician, one time, need for confirmatory test of the blood flow. If
But
we have
beyond this, there is no conflict of diagnosing brain death criteria for declaration of death.
Right. There is no conflict, no variability in this. All agree about what is being published in the World Project, published in the JAMA in August 2020.
This is the point I want to reach to. I think if we have no more questions and we are running out of time, I would like to thank all of the speakers. I would like to thank the ISODP. I am really highly appreciating the efforts of Professor Faisal Shaheen for the support of the African Society of Organ Transplantation, the Egyptian Society of Nephrology and Transplantation, and please keep joining us for the coming session. Thank you very much.
Thank you. Thank you, Bro Jamal. Thank you very much. It was excellent talks.
تعالى من هنا السلم اهو يا دكتور. السلم من هنا. السلم اللي هناك.
تدي ولا نستنى؟
اتفضل يا باشا. انا على فكره التشير بيرسونز نقاوه ليا.
بسم الله الرحمن الرحيم. The second talk will be by Professor Dr. Gamal Saadi, the President of the African Society of Organ Transplantation. He will talk about obinutuzumab, anti-CD20 monoclonal antibody. تفضل يا فندم.
Thank you very much, dear Chairman. And actually, I will cover the topics of the B cell development and function and the targeting B cell targeting agents. You are all aware that surface markers of the B cells through their stages of development are epitopes for targeting these phases of development. And the B cell targeting agents include various categories, either targeting the CD22 epitope by epratuzumab or targeting the CD20 by the rituximab, ocrelizumab, or obinutuzumab. You can also target the immunoglobulin receptor on the surface of B cells, and you can notice that it is in close proximity to the CD20. Also, you can target the interleukin-6 receptor or the interleukin-6 itself. You can target the antigen proliferation on the B lymphocytes or the BAF, B cell activating factor, or the receptors. You can also target the interferon receptor or the interferon itself. Moreover, you can target the T cells, which can have a co-stimulatory effect on the B cells. We can have two types of B cells, either those short-acting or those who are long-lived. And the escape of the long-lived plasma cells from the effect of the monoclonal antibody attack is responsible for the primary failure. But if you have memory cells, this would result in a secondary relapse or failure after an initial response. We have two forms of antibodies which are targeting the CD20, while rituximab has dramatically improved the outcomes of CD20 malignancies. Responses are not universal and resistance can develop because of the long-lived or the escape phenomena I just explained. But obinutuzumab was developed to potentiate the activity and overcome this resistance, as I will show in the coming slides. The monoclonal rituximab has been modified to develop the obinutuzumab by two main changes. One of them is at the hinge modification, and it's a spatial distribution بتاعها and the FAB dispersity between the two FAB peptides and the glycation of the FC fragment. The type 1 monoclonal antibodies, which is the rituximab, is not very specific. And while it binds to the CD20, it binds as well with the immunoglobulin fragment or epitopes in the same time. And this results in internalization of the receptor, and the CD20 internalization is also associated by complement activation. But having developed the modification in the monoclonal antibodies by the formation of the two changes I explained previously, you get a more specific interaction with the CD20 without any interaction with the immunoglobulin fragment. So there is no complement activation and no internalization of the CD20, which is available for suppression by the monoclonal antibody. There is a lot of studies about the B cell depletion in autoimmune disorders, which I will skip. But many of them are targeting the lupus and other autoimmune disorders. And in these studies, you can notice that the suppression of the B cells by obinutuzumab is only for a short-lived period. By rituximab is for a short period and not maintained. But obinutuzumab maintains the suppression of the CD19 positive cells up to week 52 in 81% of the cases, if compared to only 13% of the rituximab. So the effect of obinutuzumab is long-lived and more strong. And the FDA granted a breakthrough designation to obinutuzumab for lupus. You all know that belimumab was the last FDA approved for lupus management, but recently the FDA approved and granted this clinical trial of obinutuzumab in lupus nephritis. And it is studied in the various aspects in lupus, which is not the scope of this talk now. Concerning the use of the anti-CD20 in desensitization protocols, there are various options to desensitize the patient, either remove the antibodies by plasmapheresis or immunoadsorption. You can inhibit the complement cascade by eculizumab, which is the terminal aspect of the antibodies, or you can inhibit the antibody production by destroying the B cells themselves by using the monoclonal antibodies, or using the bortezumab, which is a plasma cell suppressor. A splenectomy to remove the clones producing these plasma cells or B cells is another aspect to be considered, but it's not widely used. In the meantime, if you are going to use intravenous immunoglobulin, it can attack various steps in the development and activation step of the B cells and their site of action. As shown in this figure, it acts on all the limits, but excepting with the exemption of the plasma cells. There are many trials to use combinations, either IVIG alone or in combination with anti-CD20. Recently, for desensitization protocols, it's not only rituximab which is utilized, but in various centers or several centers are trying to induce this desensitization by obinutuzumab in a dose of in a dose of 1 gram intravenously titrated per package insert or per surface area. And there is a clinical trial to evaluate obinutuzumab for desensitization. And they use 2 doses, 1 gram and another dose after 1 month. Or they can give it, here they are comparing the rituximab and they are comparing it with the obinutuzumab, which is given as well for 2 doses and a booster dose 1 month separate and a booster dose 6 months after successful desensitization and immediately prior to transplantation. Yani يدي 1 month first dose and after 1 month another second dose, and then observe the MFA, mean fluorescence index, MFI, sorry. And then if it is stable, he gives another booster dose after 6 months prior to transplantation. And sometimes they give a booster dose after 1 month of transplantation and after 6 months of transplantation. Here in this study, they are studying the obinutuzumab as a single pre-transplantation dose and monitor the DSA. And then he would give obinutuzumab in the first 48 hours at the time of transplantation and after 6 months of transplantation. This is in the single pre-transplantation dose. In the other cohort, they give, as I mentioned, an initial obinutuzumab 1 gram dose, then another dose after 2 weeks or 1 month, and then they either monitor for the MFI. If it is successfully suppressed, okay. If not, they give a third dose after 6 months. And then they repeat the pre-transplantation and post-transplantation doses. There is several randomized controlled trials for HLA desensitization protocols, including the antibody-mediated rejection and graft survival. And you can notice here that using IVIG alone might not be successful, where you still have an incidence of 53% of antibody-mediated rejection and 80% graft survival only. But using combinations of IVIG in addition with the rituximab, you can notice that in these groups, you can get only a 0 incidence of antibody-mediated rejection and 100% graft survival. But IVIG alone is not successful. You need to combine it with rituximab. And also ATG with rituximab is successful. You need to combine the rituximab with another agent, either ATG or IVIG. And here, this protocol as well gives a 0% antibody-mediated rejection and 100% graft survival. And sometimes IVIG is frequently used in combination with plasma exchange and or an anti-CD20 antibodies, but in combination, they are very successful in performing 100% graft survival. In this clinical trial, they are replacing the rituximab by the obinutuzumab because of its longer duration of action and more sustainable suppression of the CD20 as measured by the CD19. And here, this is the phase 1 trial of this clinical trial. And it is implemented as well in Cedars-Sinai Center in the United States, where obinutuzumab is used for desensitization prior to heart transplantation and for highly sensitized patients post-transplantation. And it moved to use IVIG plus obinutuzumab in a similar way to the obinutuzumab replacing the rituximab. And instead of IVIG with the rituximab, they shifted to use IVIG with the obinutuzumab. What are the different strategies for antibody-mediated rejection? You can target the co-stimulation blockage to avoid co-stimulation by, for example, belatacept. Or you can target the CD20 by monoclonal antibodies, either rituximab or obinutuzumab, if you have an active antibody-mediated rejection as active rejection process. Or you can target the plasma cells by the bortezomib, the proteasome inhibitor. You can target the CD38 monoclonal antibodies to target the natural killer and the plasma cells. Or you can do apheresis to remove these antibodies, which by itself is a momentary process. Or you can block the final activation or process of the killer reaction by blocking the complement activation. Intravenous immunoglobulin will target several aspects of this process. You can combine it, as we mentioned, by the CD20 monoclonal antibodies in a similar effective process as the desensitization we previously talked about. And occasionally you can combine them with anti-cytokine reaction antibodies, monoclonal antibodies, but very frequently we are only using the anti-CD20 with the intravenous immunoglobulin protocols. Another aspect beyond the desensitization and beyond this treatment of antibody-mediated rejection is to use the B-cell depletion as an induction therapy. And as I have been discussing with Professor Hani Hafiz yesterday about the deficiencies in our immunosuppressive protocols, we are not targeting the antigen presenting cell, and we are not targeting the B cells which are responsible for the DSA, which is responsible for more than 50% of graft losses. So we need to consider targeting the B cells as well in our process of induction therapy. This shows the development of the different protocols for induction therapy. And you can notice that basiliximab, which is anti-CD25, is considered as well. We could notice that many centers as well are considering rituximab, which is anti-CD20, among the induction therapy protocols. In Sinai in USA, they are still considering a presence of panel reactive antibody positivity and known DSA for either ATG, or occasionally they consider using anti-CD20 as a single fixed dose for the induction therapy in such situations, if they are not donor specific, in particularly positive, only positive PRA, because they are working with cadaveric, where they don't have criteria of donor specific antibodies. And the rituximab induction on preoperative day 4 at a single fixed low dose is considered for the 1 minute for the induction therapy. And they focus on the modulation and depletion of the immune effector cells and memory B cells. But to target the memory B cells, we need to switch from the rituximab to the obinutuzumab, which can target the longest living plasma cells and the memory cells. And obinutuzumab is very promising in that aspect to avoid any secondary lymphoid tissue activation. In conclusion, Mr. Chairman, B cells play a pivotal complementary role in the immune response, and targeting the B cells depends on their lineage specificity, whether at which phase we are targeting them, and we should consider using the selective CD20 rather than the non-selective, or rituximab bind the immunoglobulin as well, while obinutuzumab is very specific. And it has proven a lot of success, particularly in malignancies and autoimmune disorders, and FDA is allowing it now in lupus. And extending use of obinutuzumab in HLA and DSA desensitization protocols are under proper evaluation now, and as well as the treatment of antibody-mediated rejection, and they are now considered as an important induction immunosuppressive regimen. And thank you very much for your attention.
Thank you, Professor Dr. Gamal Saadi. I want to ask a question. The obinutuzumab has a role in treatment of cryoglobulinemic vasculitis like rituximab?
It is, yes, it is used in, and I skipped this important aspects of using it in other autoimmune disorders, including lupus, rheumatoid, ANCA-associated vasculitis. Many autoimmune disorders now, including the vasculitis, which are considering obinutuzumab rather than rituximab. But I concentrated on the transplantation.
Okay. It has a less side effect than rituximab? Or the same?
Almost the same, but you can encounter infections in the same sequence. The probability of getting infections, if not under strict infection control, is a bit higher because you have a longer duration of suppression, or as I showed to you, more than 52 weeks compared to the rituximab. It works only for a few weeks. So you get the expense of having a longer immunosuppression, having the possibility of getting more infections if not under proper care.
The precaution before taking the drug, like giving him antihistaminic steroids, something like the same like rituximab?
Yes, yes, because the cytokine effect of destruction of the B cells and plasma cells would result in a reaction, and you can give it under coverage of antihistaminics and steroids.
Any question? Thanks,
Yeah,
Doctor.
thank you. Let us move to the next session, inshallah.
Thanks, Dr. Gamal.
Now we start for the next session. We discussed the organ donation. Now we start for the second session. We start to discuss session of organ donation. يعني احنا الحقيقة هنتكلم عن 4 موضوعات. First of all is suboptimal donor and living related transplantation actual scenarios هقولها انا وبعد كده الدكتور هاني هيتكلم بعد.
أستاذ الدكتور طارق فخر شرفتنا في المؤتمر وهنبدأ السيشن مع سعد.
بسم الله الرحمن الرحيم. I would like to thank all professors, especially Professor Gamal Saadi for my invitation for this elegant symposium, and I would like to discuss first of all it's suboptimal donors in living related renal transplantation actual scenarios. الحقيقة احنا هنتكلم على بعض السيناريوز اللي احنا بنشوفها خاصة بالنسبة للدونر ريليتد دونيشن. في الحقيقة هيبقى في ورقة يعني مشكورين يعني نشوف اذا كان يس اور نو according للسيناريوز اللي هنقولها بحيث ان احنا في الاخر نبقى عندنا فول فيل. بعد كده البروفيسور الدكتور هاني حافظ الحقيقة هيكمل او يعني بالاحرى هيجمل التوك منه هيكلمنا على موضوع مهم اللي هو في الغالب هيبقى سيفتي اوف ذا دونر. الحقيقه بقالنا عشرات السنين بنتكلم ان الدونرز مفيش مشاكل هيحصل شويه هايبرتنشن او بروتونيوريا افتر 15 or 20 years. يمكن الدكتور هاني بيه هيقول لنا حاجه جديده النهارده نسمعها فنحاول مع بعض كده. First scenario, a female patient, 31 years old, in the stage renal disease on hemodialysis of 5 years duration, planning for renal transplantation. The original disease is mostly occurring glomerulonephritis. The donor, her father, 57 years old. He has a history of CABG, coronary artery bypass graft of 6 years duration. ECG is normal. Echo, no abnormality detected except for ejection fraction is 60%, even the coronary angiography is free. Otherwise, the donor on investigation, there is no contraindication for donation. The compatibility 3/6. Our question for this scenario, is he a suitable donor? الحقيقة عايزين نسجل في البيبر اللي قدامنا إذا كان ده suitable donor ولا لأ، ولو كان في discussion إحنا هنعمل discussion 1.5 minutes بس عشان خاطر إحنا عندنا 10 سيناريو ولسه هيقول بعد كده الدكتور هاني. فلو كان في اي يعني obvious يعني contribution على السيناريو نفسه نقدر حد يبقى فيه اي يعني توك ولا حاجه يقول لنا ايه رايه بالظبط في الحاله. ما كانش يبقى بس هنعلم في الورق عشان خاطر في النهايه نخلص بقى. ده سيناريو نمبر 1. I will shift C2. Female patient, 29 years old, in the stage renal disease on hemodialysis 3 years duration, also planning for renal transplantation. The original disease mostly chronic intestinal nephritis. His donor, her mother, 55 years old. Her investigation was normal except for pelvic abdominal ultrasound showing chocolate ovarian cyst, which is most of the professor of gynecology is considered as a precancerous. Compatibility between both HLA was 5/6. Is she suitable donor for her daughter? Let me to shift. Male patient, 11 years old, in the CGL disease also on hemodialysis 2 years duration. His primary renal disease, Albert syndrome. He's planning for renal transplantation. His donor, his father, 45 years old, no abnormality detected regarding his investigation except for gallbladder polyp, 1.5 centimeter, otherwise liver enzyme and liver function synthetic are normal. Also, is he a suitable donor for his son? Next, male patient, 31 years old, in the stage of hemodialysis 1 year duration. His primary renal disease is mostly FSGS. He's planning for renal transplantation. The donor, his mother, 52 years old, who is medically free except for echocardiography showing ejection fraction is below normal. Mostly is normal from 50 to 65. This is 49 by otherwise cardiological assessment, and the coronary angiography, even for this mother, is free. Is she a suitable donor for her son? A male patient, 35 years old, in the stage of regular hemodialysis, 6 years duration. His primary renal disease is adult polycystic kidney disease. He's planning for renal transplantation. The donor, his wife, who is medically free, tissue timing show 0 match. Is she a suitable donor for her husband? Next, a male patient, 33 years old, chronic kidney disease, passing to end stage. His primary renal disease is primary amyloidosis. He is planning for renal transplantation. The donor, his sister, 31 years old, who is medically free, except for bilateral small stones of average 3 mm. Her renal profile is normal, and renal isotope showing also normal GFR. Is she a suitable donor for her brother? Let me to the next. A male patient, 44 years old, in the stage renal disease, regular hemodialysis 1 year duration. His primary renal disease is unknown. He's planning for transplantation. The donor is sister, 50 years old, who is medically free except for breast mass, which biopsy was taken and is found to be fibroadenoma, HLA matching 5/6. Is she a suitable donor also for her brother? Next, male patient, 30 years old, in the stage renal disease on hemodialysis, 3 years duration. His primary disease is chronic glomerulonephritis. She is planning for renal transplantation. The donor, his father, 54 years old, who is medically free except for thyroid nodule, which biopsy was taken and is found to be benign with normal thyroid function, HLA between 4/6. Is he a suitable donor for his son? Next, a male patient, 34 years old, in the stage renal disease on hemodialysis 2 years duration. His primary renal disease is diabetic nephropathy. He's planning for renal transplantation. The donor is mother, 56 years old, who is medically free except for history of HCV disease, for which he's received treatment 2 years ago. Liver function is normal. PCR below average 3 repeated times normal. Fibroscan for this is stage 2 fibrosis, HLA 3/6. Is she suitable donor for her son? Okay. Male patient, 44 years old, in the stage renal disease on hemodialysis 4 years ago, 4 years duration. His primary renal disease is adult polycystic kidney disease. He's planning for renal transplantation. His wife is a donor who is medically free. Tissue timing show 0 match at DR. HLA matching is compatible at A locus. Is she a suitable donor for her husband? I think this is the last. If any adding new recommendation will be done. And thank you very much. Professor Dr. Hani will back on.
عايزين حد بس يلم الورق من الشركة المنظمة بعد إذنكم. الشركة المنظمة بعد إذنكم حد يلم لإجابات من السادة الأطباء.
في حد يقول البرزنتيشن؟ في حد هنا يا جماعه؟ برزنتيشن بس بتاعتي. ثانك يو فيري ماتش. طبعا
أستاذ دكتور هاني بيه، يعني عايز أقول لك ألف مبروك على تنصبك رئاسة الجمعية الأفريقية.
الله يخليك يا بيه.
وحضرتك رئيس المنتخب حاليا للأفران، وده شرف لمصر، وحضرتك اد فاليو لهذا المنصب.
الله يبارك فيك.
مش هقدر اقول بقى الاستاذ الدكتور هاني حافظ استاذ الكلى في القصر العيني والحاجات كلها، الناس طبعا عارفين حضرتك عن ظهر قلب.
ثانك يو فيري ماتش. طبعا بدايه انا سعيد جدا، يعني ثانك يو فيري ماتش دكتور عمرو والشير بيبل. اتس ان اونر ان انا ابقى معاكم، واتس ان اونر الحقيقه ان انا اتكلم مع الدكتور طارق فخر. انا بقول يعني ان اخر مره اتكلمت فيها مع احد الزملاء كان مع رحمه الله عليه الدكتور حسين شعيشه، لما كنا بنقول مع بعض الابديتس. فالدكتور طارق فخر الحقيقه زي ما حضراتكم عارفين هو عضو اللجنه العليا اللي بتدي الموافقات على زرع الاعضاء، والحالات العشرة اللي هو قدمهم هي حالات من الواقع كان عليها question، يعني يا ترى اللجنه تدي عليها موافقه ولا ما تديش موافقه. وحضراتكم طبعا you are a panel of the highest rank nephrologists in Egypt، فرأيكم هام جدا، بمعنى انه العلامات اللي هتعملوها والكوميتي اللي هتقراها هتقول كان الحالات دي تزرع ولا ما تزرعش. احنا عندنا مشكله كبيره في مصر ان السيشن الجميله جدا اللي سمعناها عن الكادافيريك ترانسبلانتيشن ما زالت من الاحلام. يعني اي واز الحقيقه زعلان جدا وانا قاعد اسمع ان هم زرعوا 44,000، طبعا مبسوط ليهم يعني في امريكا ان هم زرعوا 44,000 كادافيريك ترانسبلانت واحنا ما زرعناش ولا حاله. فيعني I think ان احنا it's a shame for us and we need to move forward and it was a very good decision من اللجنه المنظمه برئاسه الدكتور جمال سعدي والدكتوره مي حسب الله انها تدعو الكي بلايرز الدكتور عوض تاج الدين، الدكتور عادل العدوي، ان هم يحضروا ويسمعوا الامريكان عملوا ايه. فاي هوب ان بعد ما حضروا يعني يبقى في نوع من الستيمولس ويتحرك الكادافير بروجرام في مصر. What we have now is actually the living donor. That's what we have. The question, are we doing something bad to our population by allowing them to donate or not? This will be the target of my talk. I will start by presenting this man, Frank Dewhurst, an 84-year man who wanted to help a neighbor, and he became the oldest living kidney donor in the world. So it seems that giving kidney is not, you can survive for over 80, 85 by one kidney. There is a growing need for transplantation. والUS government policy الحقيقة اللي كان عمل ده كان الليت ترامب، وما زال نفس القانون موجود. They wanted to double the number of transplant in the next 5 years. They wanted to put 80% of the dialysis to be at home. All living donor will be reimbursed for financial hardship. ويمكن ده السؤال اللي كان بيسأله الأستاذ الدكتور عوض تاج الدين. If you refer to transplant, you get a beneficial reward. كدكتور انت نفسك الدولة لو بعت حالة للترانسبلانتيشن you will be rewarded. This is the actual situation in the United States now. They are trying to decrease the gap between those who are on dialysis and those who need transplantation. This is the left index fingerprint from identical twins. زي ما حضراتكم شايفين هم مش زي بعض رغم ان هم identical twins. Therefore, kidney living donors, we expect that those will survive for many years, but the estimated graft half-life in living donors, which was supposed to be 25 years مثلا, is only, as you see, 12.5 years. So living donor does not make much difference from the curve اللي بعده اللي هو 11.5, which is a cadaveric donor with kidney donor profile index اللي احنا بنختصرها ب KDPI of 0 to 20. So we are not doing much better when we transplant living donors. يعني لو نقلنا على اللي جنبها اللي هي cadaveric donor هتفرق 1%، مش هتفرق كتير مع الارمامنتم of immunosuppression that we have. But of course when we go further يعني لما نبتدي ناخد KDPI of 21 او اكتر من 80% زي تحت، يبتدي الجرافت يبقى 5 years اقل بكتير. فرانس بتزرع اللي هم بيعيشوا 5-6 سنين. امريكا ما بتعملش كده. فرانس more than the USA. Recently امريكا قالت لا انا هاخد دول، هاخد even those with a high KDPI. So all the world is trying to move even to get marginal donors. This is the Amsterdam Forum guideline for screening living potential kidney donor، وده تقريبا هو الدستور اللي المفروض الحالات كلها اللي الدكتور طارق بيقدمها بتمشي على هذا الدستور. يعني ناخد هايبرتنشن ولا لا، اوبيزيتي ولا لا، acceptance of urine analysis proteinuria. مش I will not go in detail، بس هي دي الكرايتيريا اللي بيمشوا عليها اللي هي الامستردام فورم جايد لاينز. هسيبها لحضراتكم. smoking cessation، alcohol abstinence، اعتقد ان دي من الحاجات اللي احنا ما بنبصش عليها في الدونرز. معظم الدونرز بتوعنا are smokers، مش عارفين بياخدوا ايه substances. assessment of pulmonary issue، determination of cardiovascular risk and live unrelated donor طبعا with no incentives. There is a risk for our donors. Don't say no. Immediate post-operative risk is atelectasis، pneumothorax لما بيشيلوا الرب، pneumonia, urinary tract infection, wound complication, DVT with or without pulmonary embolism, and some percentage of cervical mortality. رغم ان هي قليله 3 per 10,000 donor، هنتكلم عليها بالتفصيل بعد شويه. The long term risk هم 8 حاجات هقولهم بسرعه جدا. هل المورتاليتي زايده؟ هل في اند ستيج رينال ديزيز اكتر من الطبيعي؟ في هايبرتنشن اكتر؟ في ميتابوليك بون ديزيز؟ في دايابيتس اكتر؟ جاوت اكتر ولا لا؟ What happens to ladies؟ لان احنا كنا شفنا بعض الدونرز اللي اتقال ladies بالنسبه لللونج تيرم ماتيرنال اند فيتال اوتكم. هل في malignancy للدونرز تزيد ولا تقل؟ في psychological consequence for donation ولا لا؟ وهل الريشيال ديفرنس ميكس ديفرنس ولا لا؟ واحنا اتفقنا امبارح مع الدكتور جمال اننا وي ار نوت كوكيزيان، وبالتالي الريشيال ديفرنس بالنسبه لنا مش هنقول احنا افريكان امريكان ولا هيسبانكس، بس يا ترى في ديفرنس في الديفرنت ريسز بالنسبه للدونيشن ولا لا؟ Let's start with the first point which is the risk of end-stage renal disease. سنة 93 زمان ده بروفيسور نيجيريان أو 92 الحقيقة نيجيريان في اللانست قال there is no problem one normal kidney is sufficient for life. سنة 97 برضو في السويد قالوا the long term risk appears lower than in the general population. وسنة 2002 برضو قالوا إن الدنيا كويسة جدا. ابتدوا الحقيقة يطلع 2 studies بعد كده ابتدت تغير المفاهيم شوية وتدي some concerns اللي هم 2 studies اللي أنا ببينهم هنا. خلاصتهم الحقيقة إنه كانوا larger cohort studies أكتر من 10,000 living donors with prolonged follow-up for 15 years quantifying the risk estimates. الاثنين طلعوا في 2014 وقالوا انه there is some risk. مش عارف البوينتر this pointer is working ولا is not working. I think this one can work. Yes. You see here the risk of the controls and the risk for the donors في الاستادي دي، وهنا the risk for the controls and the risk of the donors. So there is small absolute risk difference between donors and controls. According to these studies في 2014 اللي هي ما بقتش الدنيا very safe زي ما كانوا بيقولوا. ابتدوا بعدها يطلع في 2000 دي الديتيلز بتاعت الاستادي، وابتدوا يقولوا انه could be some demographic related risk, could be some clinical characteristics زي GFR والبلاد بريشر وكده، وبالتالي ده هو اللي بيخلي ان الناس يجي لها end stage renal disease on top. So we shouldn't be afraid too much. وركزوا تاني على ان اليونج ايج والفيرست degree relatives والبلاك races may have a worse prognosis. What about mortality? Mortality الحقيقه برضو في الاول قالوا انه تقريبا mortality is very low. ودكتور حسن ابراهيم اللي جانا last year in our transplant congress بين هنا في in this curve that a follow up for many years she didn't show any deviation except after 15 years. So it is almost ما فيش تقريبا mortality. معلش هعوز شويه وقت اكتر حبه صغيرين. So the conclusion here is cardiovascular and all-cause mortality were increasing among kidney donors compared with the controls, 1.4 to 1.3 respectively. What about hypertension? 4 to 6 millimeter mercury higher. ودي برضو اتأكدت في الاستادي اللي قدامنا. Although in here non-significant and it is not a contraindication to donate if the blood pressure is controlled. What about diabetes? This is a long-term follow-up of no difference in the GFR changes between diabetic donors, non-diabetic donors, or diabetics with 2 kidneys. نفس الكيرفات بالنسبة للديابيتس. What about gout? Gout الحقيقة بيزيد شوية في الدونرز عن non-donors. What about material and fetal, maternal and fetal outcome? There is definitely some data. This is 3 different studies with different results. What about malignancy? What is good الحقيقة the frequency of non-skin cancer was lower among donors. غالبا دي statistical bias بس هم طلع عندهم ان هم المالجنسي بيجي لهم اقل. لكن increase incidence in prostate cancer among donors. What about psychological consequences? Depression is generally lower among kidney donors who donate بمزاجهم relatives بتوعهم. But there is depression increased among unrelated donors, especially in the setting of recipient death or graft failure. And the risk by race is increased, as I told you. So the kidney donation, in short here, the lifetime risk is less than 1%, or in another way, kidney donation, 99% success. This is Hassan Ibrahim last slide in our Congress. 99 will never develop end-stage renal disease. 99 do not regret having donated. Hypertensive and pre-diabetic can safely donate. Donors with diabetes should be considered. We need to change some of our practices to maintain the absolute high standard of safety for donation. Thank you very much.
Thank you, Professor Hani, for this great knowledge you always talk about. احنا دكتورة سامي هتعلن نتيجة الأجوبة بتاعت الناس ودكتور طارق نراجع على الكيسز تاني. احنا عملنا نتيجة بس انت حضرتك هتقول كل كيس.
اتفضل. نرجع من فضلك تاني البرزنتيشن اللي قبل الدكتور هاني بيه.
ممكن اكمل؟
طبعا.
طيب. بالنسبه لحضرتك عشان موضوع كوكيجنز بس عشان ما نحطش كونسبت ونمشي ان هي كده، لا. كوكيجن باي ديفينيشن انا رجعتها من الويكيبيديا. inhabitants of Europe, Indian Peninsula, North Africa و West Asia، وفي اليو اس ضافوا لها الميدل ايست. فلا بتكونسيدر المنطقه دي كوكيجنز لان هي ليها تقسيمه معينه بيسد على حاجات في وبروفد باي ذا جينوم لما عملوا. النقطه الثانيه سؤال حضرتك سالته
ممكن ارد على حته صغيره هنا. دكتوره مؤمنه كامل من حوالي 10 سنين وبتصحح لي دكتوره ميرفت الانصاري لو موجوده، كانت عامله ستادي على 1000 ايجيبشن بيشنت بتشوف الجينetics بتاعتهم، وطلعت الكونكلوجن اننا in Egypt we are a mixture of 3 ناس من افريكا، وناس من تركي وناس من النورث افريكا اللي هو المغرب وكده. فده الايجيبشن ميك اب.
بس هو ده على فكره الهيومن ميك اب، كل الهيومنز ار ميكشر، يعني لما عملوا باي جينوم لقوا، بس اقصد ستيل ال definitions are valid up till now و was revised في 1978 وعدلوا ودخلوا فيها الميدل ايسترنز. فاحنا عشان لما نيجي نكتب او نعمل هنفضل ستيك لدوت، ما نقدرش نغيره، لان كمان 1000 حاله از نوت يعني طبعا ده. بس هو حتى الناس لان بيسموا كل المنطقه دي اسمها اندو يوروبيان باي ذا واي، يعني حتى اللغات بتاعتها وكده، فهي ستيل. حاجه ثانيه، حضرتك سالت سؤال في الاول is it bad to donate ولا لا؟ ده كان اول كلمه حضرتك قلتها، اللي احنا بنعمل حاجه وحشه للناس بتوعنا with حاجات يعني عايزه، لا غير البريكوشنز with emphasis on حاجه ان احنا donation بوضعه الحالي بالطريقه الحاليه لا it is bad، ان هو مش regulated. طبعا في regulation لكن
ده بس ده موضوع تاني غير الناحيه
يعني
الطبيه.
it is bad as far as انه احنا مش عارفين نوصل للسيت اب الصح ليه from the non-medical point of view. Thank you.
شكرا استاذ دكتور محمد.
احنا هنحاول بس نشوف الكونكلوجن بتاع الاساتذه بالنسبه للسيناريوز اللي احنا كنا بنقولها. فالدكتور عمرو والدكتوره سميحه هتقول لنا دي السيناريو 1
دي الكيس نمبر 1 النتيجه بتاعتها يس لعدد 7 من الاطباء قالوا يس و5 قالوا نو.
هو دي كان 20
يعني
ده كان سيكتور حوالي 20 بيبر، فهل ال 20 كلهم فول فيلد ولا في حد ما جاوبش خالص؟
في حوالي 15 بيبر.
اوكي نسجل بس ان الحقيقه انا كنت امبارح بتكلم مع الدكتور ونيمات بيه والدكتور رياض، الحقيقه برضو ما كانش عندهم مانع خالص ان احنا ندي العيان اللي عنده كابج. حقيقه هو الحقيقه الفكره كلها ان ده كلهم ريليتد، الحقيقه احنا بنحاول نشجع ريليتد على قد ما نقدر، لان الحقيقه كل دول ال10 ايتمز دول، والحقيقه في اكتر من كده. انا شخصيا بواجه في اللجنه العليا بعض الحاجات زي كده، لو وي دونت اكسبت الحاجات دي على فكره يبقى العيان ده هيحاول ان هو يجيب انريتد دونر بكل مشاكله، سواء المشاكل الطبيه او المشاكل الغير طبيه. فالحقيقه الاكسبتنس في الحالات، الحقيقه انا شايف حتى لو نعمل ثرالي انفستيجيشنز للحالات كلها، ايفن لو احنا يعني انا شخصيا مش عامل لبعض الحاجات ثرالي انفستيجيشن، لو بس ناكسبت الفكره كلها. الحقيقه بنفسنا نعمل ما يسمى طبعا بالايجيبشن جايد لاين. يمكن الدكتور هاني الحقيقه يعني عنده برضو يعني بعض الكونسيرن على حته زي كده، لكن هو ما ينفعش انا اكسبت دونر زي كده وبعد كده بعد شويه يحصل مشاكل حتى للريسيبيانت. فالورق ده لما يروح مثلا الدكتور صبري بيه للدكتور دولت لحد من الاساتذه يقول هو ليه خد دونر اساسا هو عنده كابج. الحقيقه عايزين اذا نعمل جايد لاين، زي ما بنعمل جايد لاين لموضوعات النفرولوجي، يعني النواب نقول لهم تعالجوا ازاي مثلا هايبركاليميا، تعالجوا ازاي عيان هايبوناتريميا، بالمونري هايبرتنشن، فتبقى برضو وكانها بروتوكولز في المشاكل اللي ممكن نواجهها. ده الهدف من السيناريو ما كنت قاعد مع الدكتور هاني، ده الهدف ان احنا نشجع الريليتد على قد ما نقدر. هنشوف طب النكست سيناريو اللي هو
النتيجه بتاعت النكست سيناريو.
سيناريو
اتفضل يا دكتور.
What's wrong when he has ischemic heart disease? ايه العلاقه بين انه عنده ايد واحده يجيب
حضرتك طبعا حضرتك استاذنا، وكنا دايما من 20 سنه واكتر بنكتب كده في التذكره بتاعت الدونر هيلثي دونر. انا الحقيقه اتعلمت من الراحل الدكتور مفتوح كان يقول بيولوجيكالي هيلث، يعني على مستوى البيولوجي. فهو العيان ده اصبح مش هيلثي دونر، هو دي الكلمه اللي المفروض نغيرها. الحقيقه بعد ما كمان شفنا الاكسباندد كرايتيريا اوف ذا دونر، عيان دايابيتيك وعيان هايبرتنسيف وعلى نورمال. اتفضل.
لا ده انا بقول ان هو اولا العيان عمل كبد وخلاص بقى كويس، انما انا بفترض حتى لو هو اسكيميك هارت وات از ذا كونترا انديكيشن انه يبقى دونيتد.
هسأل سؤال الحقيقة، يعني الحقيقة أنا مش عارف إجابته، بس هو سؤال بيتسأل يعني كومنلي. هو الواحد يواجه مشاكل كارديولوجي، مشاكل جول بلادر بكلية أحسن ولا بكليتين أحسن؟
هتفرق الكليه والجي اف ار بتاعه
ما هو لا، هو الجي اف ار كده اتقسم يا دكتور صبري بيه، هو الجي اف ار اتقسم.
لا ما بيتقسمش. ليه؟ اولا بيحصل كومبنساتوري تشينجز
يعني ده بياخد وقت. هو العيان حضرتك ده اتبرع النهارده وبكره حصل له كار اكسيدنت وهو اسكيميك هارت. اتفضل.
طب ما هو برضه لو هو ما عندوش اسكيميك هارت ديزيز هيبقى نفس السيتويشن، ان الجي اف ار هيقل شويه، نفس القصه.
لا، هو العيان لما بيكون عنده 2 كيدنيز احنا بنتكلم ان الجي اف ار بتاعته من 80 ل 120.
يا دكتور
لو 41
اعتقد ان يعني مع كلام الدكتور صبري ان النتيجه برضو معناها انها نتيجه مظبوطه، يعني احنا اتقسمت النتيجه 7-5.
طيب
فبالتالي هنا في ديبيت فعلا.
بس هو الدكتور صبري بيه في صالح انه العيان يتبرع، في صالح ان الدونر يتبرع.
ايوه هو الدكتور صبري قصده انه ما فيش ريليشن بين الكدني والهارت، ان هو يتبرع بالكدني ده مش هيأثر على الهارت بتاعه اكتر من اللي هو فيه.
هو يا فندم العيان الاسكيميك هارت متعرض بعد شويه يخش في كونجستيف هارت فيلير لاي سبب من الاسباب. على فكره انا موافق، بس انا بتكلم اذر سايد اوف ذا كوين.
لا احنا ما هياش مساله.
هو لو اتعرض لكونجستيف هارت فيلير بعد شويه،
ما هو كليه زي 2 يا دكتور طارق، ما هو لو بكليه واحده او ب2 نفس النتائج.
اي داوت ان بنناقشها بعدين بس على سكيل اوسع شويه. طب هنخش على السيناريو الثاني بتاع الفيميل عشان بس ما نضيعش وقت اللجنه ووقت الناس.
طيب انا استاذنك الدكتور سمير ليه راي في الحته دي.
هو حضرتك هو ايثيكالي احنا يهمنا صحه الدونر من 1 ل9 وبعد كده العيان من 10. القضيه مش قضيه ترانسبلانتيشن، القضيه قضيه از ات سيف ان احنا ندخل عيان العمليات دونر ممكن يجي له بروتونوريا، ممكن يجي له هايبرتنشن وهو عامل كابج. انا اعتقد ايثيكالي نو.
هو العيان ده يا فندم لو حصل له العيان ده لو حصل له كار اكسيدنت مش هتدخله تعمل عمليه؟
لا ده قصه ثانيه، انا بتكلم على دونيشن.
ده مش اختيار، ده مش اختيار.
الاثنين الاوبراتيف ريسك واللونج لما يكون عندك انسنس اوف هايبرتنشن ممكن يكون عالي وانسنس اوف بروتونوريا ممكن تكون عالي.
يا فندم احنا عملنا الانفستيجيشن اللي بتكسكلود، حضرنا الدونر واكسكلود ايفريثينج. العيان ده او الدونر ده ما فيهوش غير الهيستوري بتاع الكابج. فحضرتك يو اكسبت اور نوت؟
نو ايثيكالي نو. ايثيكالي
ده بيتبرع لابنه يا فندم.
ايوه ما انا عارف ما احنا في حاجات بتبقى مارجنال بس ما فيش فيها الكابج. مارجنال يعني مايلد هايبرتنشن.
فكرة انا عايز بس حضرتك دكتور صبري بيه وباقي الاساتذه يعذروا. انا حقيقه بقعد في الحاله، ويمكن انا كنت بشتكي ده للدكتور هاني بيه، بقعد في الحاله اكتر من ساعه عشان اخد ديسيجن، وكان نفسي ابقى في الفيلد ديسيجنز بس برضه ستيل هبقى.
هو دكتور طارق الحقيقه انا بحط بقى نفسي في وضع تاني خالص. انا لو اب وباخد من ابني وعنده مشكله في القلب هقول كفايه عليه.
الابن اللي هيلغي؟
يعني انا كاب انا هقول كفايه عليه، كفايه اللي هو فيه يعني.
يمكن الابن اللي ما يرضاش.
بمعنى لو انا هدي لابني هديله جميع الاحوال، بس هو هنا في الكيس دي هو الابن هو اللي عنده مشكله في الهارت. الاب
يا فندم.
لا يبقى تسيبها الاب بقى، الاب موافق خلاص.
هو يا جماعه
شوف بس عشان
فيري ديبيتابل ايشو، وفعلا زي ما الدكتور طارق بيقول احنا محتاجين نحط جايد لاينز للكرايتيريا دي، يعني دي كلها فعلا مشاكل بتقابلنا يعني. نعم يعني اصل احنا لو هنقعد هندسكس في مشاكل كتير جدا جدا جدا، ولازم فعلا نحط النقط على الحروف، فعلا بتلخبط يعني. الحاله اللي بعدها
الام اللي عندها شوكليت اوفيريان سيست، والاساتذه الناس قالوا ان دي ممكن تبقى في كانسرس.
كل الناس تقريبا مع الياس اكتر يعني 8 فيرسس 4. خلاص. اوفريان سيست ولا حاجه، هي تشيل السيست وخلاص وانتهت.
لا برضه دكتور صبري بيه، هي مش هيلثي دونر ده انا بتكلم عليه. يعني برضه العيانه دي لو انا وافقت وهي دونيتنج وبعد اسبوع حصل لها مشاكل.
لا يعني
طيب.
دي حاجه بعيده
أوكي،
عن
أوكي. طيب.
طب الحاله نمره 3 بقى يا دكتور، الحاله الثالثه.
حاله من 3 الاب اللي عنده جول
دقيقة واحدة
بلادر
بس يا
بوليب.
دكتور.
معلش عشان
ماشي يا دكتور
النقطه
أحمد.
دي اتكررت في الحالتين ورا بعض. احنا مش بندور على كومبليتلي هيلثي دونر، احنا بندور على دونر ما فيهوش بوتنشال انه يافكت الكدني فانكشن.
بالظبط.
يعني هارت فيلير ما ينفعش، لكن اسكيميك كنترول دي ينفع. واحده عندها بري كانسرس كونديشن مش ديفلوبد كانسر، ده مش هيأثر على الكدني فانكشن، بس هيحطها اندر سيرفيلانس اكتر شويه. فحته ان هو يكون كومبليتلي هيلثي دونر ده لا.
بس انا عايز اقول لك
يعني
دكتور أحمد،
مارجنال
هو الكونسيبت ده بيجب ان كلنا نعرفه، ان احنا نلغي كلمه هيلثي دونر.
هو في حد
لا مش ملغيه، لا خالص. ازاي؟ بالعكس احنا دايما
احنا نفسنا يعني.
لا ازاي حضرتك ما نقدرش.
هو عشان كده
بالعكس،
دكتور
ما هو ده اللي بيجي في اللجنه يا فندم، ده اللي بيجي في اللجنه، والمفروض ان احنا نبقى متفقين عليه.
طيب
بدليل ان في ناس بترفض هنا اهو. اتفضل
طيب
يا دكتور، اتفضل يا دكتور.
ده الكيس الثالثه
الجول بلادر، الاب عنده جول بلادر بوليب 1.5.
النتيجه كلها يس.
اوكي
تمام، اللي يس على طول هنعديه بقى.
اوكي، بس هو الحقيقه الافضل يتعمل له كوليستكتومي الاول، وحتى
ماشي
البيبر مكتوبه كده،
بس
يتعمل كوليستكتومي.
بس ما فيش مشكله يعني.
اوكي.
الحاله الرابعه ديبيتفول بقى، فيها نص كده يس ونص نو.
المذرز اللي عندها يعني كارديو مايوباثي مثلا، يعني ان اكسبليند كارديوميوباثي، والايجكشن فراكشر بتاعها بدل ما هو 50 52 هو 49، ودي مذر بتتبرع لابنها، فهل احنا وي اكسبتد من 50 ل 65 من 50 تو 50؟
وفي مكتوب برضه 45
النتيجه كام يا دكتور؟
يعني النتيجه طالعه نص ونص يعني.
انا بس يا فندم يعني هو ده الديبيت. الحقيقه كنت يعني لو كان الكل قالوا اوكي انا كنت هبقى مبسوط جدا، عشان ما نعرقلش الناس خاصه دول ريليتد، لكن هو هيظل الديبيت ده. طيب اللي بعدها يا فندم
الحاله الخامسه.
الحاله الخامسه اللي هي زيرو ماتش، هي زوجه الوايف بتبرع
برضه 50-50
زيرو ماتش. اتفضل دكتور محمد.
لو اونلي دونر
انا عارف مش عارف يتجوز واحده ثانيه.
هو الحقيقه لو كل البيبر او كل الاساتذه بيأكسبت ده ليتر اون يتعرض على اللجنه العليا لتغيير القانون، لتغيير. ما هو ده بالعكس، دي فكره في كده، ان احنا نغير، ان احنا هل احنا ممكن نزرع زيرو. الحقيقه برضه دكتور احمد، موضوع ان هو يبقى يقول لي دونر، يعني حضرتك لو الراجل ده معاه unrelated دونر 6/6 تاخد زوجته ولا تاخد الانريليتد دونر؟
لا اخد الانريليتد طبعا.
يبقى الفكره مش زقول لي يعني.
في نقطه هنا مهمه يا دكتور طارق.
اتفضل دكتور ربيع صبري بيه.
لو حضرتك شفت الليترشر هتلاقي ان في النون ليفنج في الديسيز دونر السيجنيفيكانت ديفرنس في الجراف سرفايفل في مكانين فقط. فرق سيجنيفيكانت ولو انه مش ماركت قوي بين 6 ماتشنج
6/6
و6 على 5 و5 على 6 ماتش، في شويه ديفرنس بتاع 8%. الحاجه الثانيه اللي هي بين 3 على 6 ماتشنج، النقطه الثانيه، و2 على 6 ماتشنج، وده اللي خلانا زمان احنا اخترنا ان المفروض ان يبقى عندنا احنا في بلدنا يعني يبقى في 3 على 6 ماتشنج، لان في برضه significant difference، ما هوش significant قوي لكن يعتبر significant بين 3 على 6 و2 على 6. خلي بالك ان الكلام ده في ديسيز دونر، لما تيجي الفرق بين في الحتتين دول لا يتعدى 12% جرافت سرفايفل ديفرنس. ده في الديسيز دونر. في الليفنج دونر الكلام ده ما اتعملش ومفيش ستاتستكس عليه. فانا اي ثينك ان زيرو ماتشنج بين واحد ومراته، وبعدين انا عملت حوالي 30 كابل
زي ما بقول لك كده اللي هم زيرو ماتشنج واحد ومراته الجراف سرفايفل بتاعهم فيري
انت عملت اتش 2 يعني اتش 2 وايف اتش 2 وايف هازبند وايف ولا لا؟
الاثنين هازبند تو وايف.
ما هي تفرق جدا يا فندم.
هنا في
تفرق
مصر
تفرق في
معظمنا-
الميموري سنتر، تفرق جدا في الميموري سيلز.
هنا في مصر معظمنا الوايف تو هازبند. انما
شو يا فندم
برضه
هو
فيها-
اللي مكتوب
فيها 3-4
هو اللي مكتوب H2W husband to wife. نو كاينيزم. طب يا دكتور عمرو بيه ده النتيجه ايه عند حضرتك؟
وبعدين ده
الكيس نمبر 5 دي اليس يساوي النو.
اليس ايه يا فندم؟
يس ونو متساويين. طيب اللي بعديها بقى الكيس نمبر 6 دكتور طارق.
طيب البيبر كلها بتقول ان احنا ممكن استاذنكم عشان الوقت. البيبر كلها بتقول احنا وين كان اكسبتد لو كان في سمول ستون 3 ملم على سنجل كدني او على كدني واحده. دلوقتي لو كانت بايلاترال سنجل انا اقدر اخد واحده واسيب الثانيه بال 3 مللي ولا اعمل ايه؟
الاجابه مع نو اكتر، نو 10 قصاد 5 اس.
مدرسه الدكتور هاني ما بيحبوش الحته دي.
اللي هو ستون فورمر ده الإجابة طالعة فيه 9 نو و5 يس.
الام اللي المفروض تتبرع الاخت تتبرع لاخوها والحقيقه عندها بريست ماس وتعمل لها بايوبسي طلع فايبرو ادينوما يعني بناين ماس.
مالهاش علاقه بالموضوع.
احنا شوف بس نتيجه فندم هو يعني لو براي حضرتك
دي نمبر 7 دي كله يس.
كله يس.
مالهاش علاقه بالموضوع خالص.
اللي بعدها كله يس برضه يا دكتور طارق.
اللي بعدها يا دكتور عمرو بيه اللي هي ثايرويد نوديول which is biopsy كله يس.
كله يس برضه.
مالهاش علاقه بالموضوع خالص.
طب رقم 9 يس 10 ونو 5.
نمرة 9 كله يس.
يس 10 ونو 5.
هو الستيج 2 فايبروزس يعني عن فايبروس كان قال ان في ستيج على الرغم من البي سي ار نيجاتيف توايس او ثرايس والعيانه كان عندها اولد اتش في واتعالجت لكن الحقيقه لسه في ريزيدوال فايبروزس اللي هو الحقيقه هيحصل له بريدج ويحصل له سكلروز بعد شويه فيعني برضو نحط في الاعتبار كده الفايبروزس بريدج سيروزس فهنوافق.
ايوه هو هيحصل له السيروزس بصرف النظر عن اتبرع ولا ما اتبرعش. يعني وجود سنجل كيدني او 2 كيدنيز مش هيأثر القرص بتاع ليفر ديزيز.
يعني لما يتبرع مش هيغير حاجه من
النتيجه كام؟ النتيجه كام يا دكتور عمرو؟
دي 10 يس و5 نو. 11 يس والدكتور جمال بيبرق لنا يا دكتور طارق. هنخش على الكيس الاخيره بقى. الكيس الاخيره متساويين 7-7.
الحاله الاخيره طبعا احنا بنهتم جدا بالدي ار هي الحقيقه فيها ميس ماتش في الدي ار لكن الاي لوكس فيها 1 لوكس ماتشنج. هل احنا نقبل ان احنا هنقبل برضو ان احنا نشتغل على من غير دي ار؟
زيرو ماتش. ايوه زيرو ماتش.
لا الزيرو ماتش ياخد بروتوكول. البروتوكول اللي بيتعمل في الزيرو ماتش نعمل عين بلازما فارسيس ندي له في اي جي اللي هو الديسنسيتيشن.
لا اندكشن لازم بس يبقى فيه اندكشن انما بلازما فارس
في الزيرو ماتش.
ايوه
في الزيرو ماتش.
ايه علاقه البلازما فارس؟ الاندكشن بس نعمل.
لا هو اللي مكتوب يا دكتور جمال ده 12 سنه ونص وده 14 سنه ونص فالديفرنس مش كبير خالص يعني الديفرنس مش كبير خالص اللي مكتوب سنتين بس. لا الزيرو ماتش يا فندم الدي ار 12% في اول 6 شهور بيتعرض لانتي بودي ميديت ريجكشن ولو احنا ضفنا عليهم من 5 ل 7% الانتي بودي الاكيوت سيرو ريجكشن يبقى من 17 ل 22% في اول 6 شهور بيخش في انتي بودي ميديت ريجكشن.
عشان كده نعمل له هيفي اندكشن.
هتفرق في ايه يا فندم؟ احنا ممكن نعمل ديسنسيتيشن يعني نعمل ديسنسيتيشن لكن اندكشن
هو مش سنسيتيف عشان نعمل.
انا فاهم قصد حضرتك.
طبعا
مبسوط طبعا بالديبيت واتمنى في النهايه يعني
لا في نقطة مهمة قبل ما تخلص.
اتفضل.
ايه حكاية ان الدونر ما يزيدش عن 60 سنة؟ مين قال
يا فندم،
الكلام ده؟
لا يا فندم، هو الدونر في القانون كان 50 سنه.
نعم.
الدونر في القانون كان 50 سنه. والحقيقه انا شخصيا كتبت يعني طلب للمستشار رئيس الوزراء.
مفيش قانون على
وخدت-
فكرة قال الكلام ده.
يا فندم،
لأن احنا لغاية من
قانون
سنة-
مكتوب، قانون يا فندم مكتوب، قانون مكتوب.
لا لا قانون يا دكتور صبري
لا 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 قانون فين بس احنا
هو في الأول كان مكتوب ودم رفع السن بقرار لجنة
قانون ايه؟ قانون زرع الاعضاء اللي اتعمل في 2010 ما فيش الكلام ده. وهو ده القانون اللي اتعرض على مجلس النواب.
لا يا فندم، اللائحه التنفيذيه رئيس وزراء.
يا جماعه احنا العبره بالبيولوجيكال ايج اوف ذا كيدني اند نوت ذا كرونولوجيكال ايج.
فندم، هي 6 months ago كانت 50 years old.
ايوه بس قبل كده يا طارق، قبل كده كان 70، كنا بندي 70.
نو سير، نو سير، ده هي خدت اكسبتنس، خدت اكسبتنس 65 سنه ل 7 8 10 عيانين بس. نو طول عمرها 50. اتفضل.
يا عم احنا طول عمرنا بنزرع، وكانت ماشيه 75 و70 كمان.
يس يس يس.
يعني في البلاد المتقدمه كلها، البيولوجيكال ايج مش الكرونولوجيكال ايج. وبعدين احنا
هو الموضوع ده لازم يتحط في الاعتبار يا دكتور طارق، فاهم؟
بندعو بعنف ان يبقى في اورجان كوميرس. الست اللي سنها 62 سنه مثلا هتتبرع لابنها، نقول لها لا عشان تروح تدور على واحد وتدفع لي فلوس وبتاع، بالذمه ده يبقى كلام صح؟
يعني انا موافق دكتور صبري تماما طبعا. يعني البيولوجيك ايج اهم، والايفالويشن الكلام ده يعني هو احنا لما غيرنا اللائحه التنفيذيه وخليناها من 50 الى 60 دي مش
هو ده مش
سوري في
معناه
الكلمه، مش جبايه للناس، دي من حق الناس. ولا زي ما بنقول لحضرتك واحد 62 سنه مثلا عايز يتبرع لابنها
60 سنه
يا دكتور طارق، في
خلاص يا دكتور جمال ما تزعلش نفسك. خلاص
75 سنه بيتبرعوا، الجرافت سرفايفل اقل والبيشنت سرفايفل اقل. يس اي نو، انما I shouldn't deprive الحق البيشنت والفاميلي انها تاكسبت فروم هير فاذر او هير ماذر.
دكتور طارق، انت حضرتك ممكن ترفض واحد سنه 50 سنه. مظبوط، ممكن ترفض واحد سنه 50 سنه. مظبوط ولا غلط؟
نو
لا، تقدر ترفض واحد سنه 50 سنه صحته تمنع انه يتبرع.
لا احنا بنتكلم هيلث دونر بقى،
يبقى في الاخر هو البيولوجي
يعني يا دكتور
لما بعتنا
واجبنا كدكاتره وكحكومه وككل حاجه ان احنا نعمل احسن حاجه في صالح مصلحه المريض، انما ما احطش ليميت واقول يا كفايه علينا كده. لا،
ما استطعت اليه يا فندم ان انا اكتب.
ما هو
لحظه،
ما استطعت
على
اليه.
فكره احنا مش مظبوط. طارق مش بننقدك انت، احنا بننقد القانون اللي انت بتقول عليه.
انا ما عنديش
ذنب في الموضوع
خالص، بالعكس. انا حتى كان الاقتناع للمستشارين اللي بيحطوا، قلت لهم هو اي اب اي شاب ابوه يبقى ايه 55 60 سنه.
allow me to say ان المستشارين اللي حطوا ده غلطانين 100%. غلطان في حق مين؟ في حق المريض.
يا جماعه
وحق الاب والام.
حق المريض بيهضم، وحق الاب والام انه عايز يتبرع. انت بتظلم المريض وبتظلم الاب وبتظلم الام وبتقول لي ده راي المستشارين. This is wrong.
الكلام ده ليس نقدا لك يا طارق خالص، ده الكلام ده نقد للقانون.
I think there should be no limit for the age of the donor so long that he is biologically fit.
Yes, I agree with you.
Thank you very much. I hope إنه this session
شكرا
يعني raised many questions وده كان الهدف منها يعني. شكرا جزيلا.
شكرا استاذ دكتور طارق فخر.
احنا بنطلب منك انك انت تساعد البوبوليشنز والناس الغلابه دول اللي هم مش لاقيين
بالظبط كده خلاص
انهم ياخدوا حقهم.
شكرا للاستاذ دكتور طارق فخر.
اعتمد عليك في هذا الموضوع يعني.
شكرا استاذ دكتور طارق فخر.
دكتور طارق
دكتور طارق نائب رئيس المعهد القومي للكلى.
issue يعني.
دكتور طارق هو نائب رئيس المعهد القومي للكلى، وفي نفس الوقت هو عضو في لجنه زراعه الاعضاء، وهو بيمر بالمشاكل دي كلها، والهدف ان هو يتعاون للمصلحه المظبوطه. فشكرا لحضرتك والله يعينك، واحنا ناصبنا كويس ان انت في اللجنه اللي هي كنا دايما عايزين حد كلى يكون موجود، هو اللي يبقى عنده الخبره الكافيه اللي يحكم في الامور دي.
لا بصراحه يعني حضرتك حطيت النقط على الحروف يعني. شكرا.
الاستاذه الدكتوره ميرفت الانصاري. الاستاذه الدكتوره ميرفت الانصاري former head of clinical and chemical pathology department faculty of medicine Cairo University, head of blood banks in Kasra Aini hospitals, and of course you know, all of us, we know that we are the founder of the Ansari labs in Egypt. دكتورة ميرفت هتكلمنا النهارده عن the dilemma of DQ matching.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizing committee and Dr. Gamal Saadi for his invitation to give this talk about HLA-DQ dilemma. This talk will include HLA class 1 and 2 structure, historical background, comparison between HLA-DR and DQ, problematic cases of HLA-DQ antibodies, and our recommendations. As regards the HLA, it is an important part of the immune system, which includes cell surface molecules specialized to present antigenic peptides to the T cell receptor on T cells. HLA molecules are divided into class 1 and class 2. And this shows the biochemical structure of class 1 and class 2. And one of the major differences between two classes of HLA antigen is the fact that class 1 antigens are encoded by a single alpha chain and beta 2 microglobulin, while class 2 antigen consists of alpha and beta subunits. And here is the antigen binding groove of class 1. It's formed of two domains of the alpha chain, the alpha 1 domain and the alpha 2 domain, in which most of the polymorphism occur in this area. And this structure of the HLA class 2 is formed of the alpha 1 and beta 1 domain forming the antigen binding groove, and most of the polymorphism occur in this area. HLA-DQ is a cell surface receptor protein found in antigen-presenting cells. It is an alpha-beta heterodimer of type major histocompatibility class 2. Both alpha and beta chains vary greatly. A person often produces two alpha chain and two beta chain variants, and thus 4 isoforms of DQ. Different isoforms of DQ can bind to and present different antigens to the T cells. Historical background: first, in 1958, Jean Doucet discovered HLA antigens, and in 1975, in the 6th International Histocompatibility Workshop, the name of HLA-D is given to the class 2 antigens, and in 1984, HLA-DQ officially named at the 9th Histocompatibility Workshop, and 3 provisional specificities are designated: DQW1, DQW2, and DQW3. And in the 3rd millennium, the anti-DQ antibodies are found to be associated with increased risk of antibody-mediated rejection, poor graft function, and the graft loss. Much of our understanding of the class 2 antigens has been limited to the DR locus. Why? HLA-DR was identified as an important factor in assessing compatibility between donors and recipient, predicting graft outcomes. Further studies revealed higher expression of HLA-DR in mixed lymphocyte cultures compared to HLA-DQ. Obtaining X-ray crystallography structures of the class 2 molecules proved much easier for HLA-DR due to its monomorphic alpha chain and more evident peptide binding motif. If you compare here the structure of HLA-DR with the structure of HLA-DQ, the blue color is the beta chain, and the purple color is for the alpha chain. And the yellow spots, it means the areas of polymorphism. So in DR, we don't have polymorphism in the alpha chain. All the polymorphism occur in the beta chain. While in DQ, we have a lot of polymorphism in the alpha chain as well as in the beta chain. So serological naming convention for class 2 antigen is based on the beta chain typing of the molecule. And while this has been appropriate for GR molecules due to its invariant alpha chain, it can be problematic for DQ. يعني احنا بنعتمد على التسميه بتاعتنا كلها على البيتا تشين. هي صح بالنسبه للدي ار وهي غلط بالنسبه للدي كيو، لان الدي كيو عن الالفا والبيتا الاثنين فاريبل، الاثنين فيهم polymorphism. Early studies investigating the impact of DQ mismatches on the graft outcomes found that it has little to no effect. It was therefore common practice in many transplant centers to focus on matching solid organ donors and recipient at only HLA-DR locus for class 2. وده اللي حصل عندنا ان احنا نعمل A و B و DR. It wasn't until the past decade that the prevalence of HLA-DQ antibodies and their impact on graft survival become fully appreciated. This is the structure of the major histocompatibility complex. It is found on the short arm of chromosome number 6. And we can see that the DR and DQ are very close together, very, very close together. That's why there is a much significant linkage, disequilibrium among the HLA antigens, particularly DR and DQ. And this made it challenging for early investigators to distinguish between antibody reactivity against HLA-DR versus DQ on cell surfaces. The introduction of single antigen bead assay changed all that. With the ability to isolate individual HLA molecules onto separate beads, researchers were able to identify and measure antibodies against specific HLA alleles. Prior to the single antigen bead assay, most of class 2 antibodies were reported as against HLA-DR. With the help of the single antigen beads, several studies reported high incidence of de novo HLA-DQ donor-specific antibodies, DSA, with increased risk of antibody-mediated rejection and graft loss. HLA-DQ antibodies, serology. Antibodies are typed for HLA-DQ using anti-serum reagent that differentiated DQ molecules into groups that shared similar beta subunits, termed serotypes. And this is a low resolution typing. And we have 7 HLA-DQ serotypes, DQ2 and DQ4 to 9. طب فين DQ1؟ هي DQ1 اتقسمت فيها 2 splits اللي هم 5 و6. و DQ3 اتقسمت بقى فيها 7 و8 و9. This forcefully gave the impression that patients developed antibodies mostly against the beta chain of the DQ molecules, while in fact, he is having antibodies against a specific combination of alpha and beta chains that the donor might not have. يعني انا كل الانتيبوديز اللي طالعه بعتبرها، خصوصا لو انا حطيتها قصاد السيرولوجيكال تايبنج، هعتبر الانتيبوديز دي اجينست البيتا تشين، في حين ان ده غلط، لان الدي كيو والالفا والبيتا الاثنين متغيرين شكلهم، فيهم بوليمورفيزم، فالكومبينيشن بتاعتهم وال3 دي ستراكشر بتاعهم هو اللي بيلزق فيه الانتيبودي. This leads to discrepant positive flow PRA and negative flow cytometry cross-match, and can even appear as though the patient possesses antibodies against their own typing. In such a case, those so-called anti-self antibodies be ignored because of high background or other technical issues, while in reality, those will be real antibodies that may lead to unfavorable transplant outcome. Why? Molecules non-self DQ alpha paired with self DQ beta have the same serological typing as self DQ alpha with self DQ beta. Alpha and beta chains contribute to the overall immunogenicity to those antigens and can thus induce antibody production. And that the epitope recognized by antibodies are likely influenced by three-dimensional structure created by both subunits. Can high resolution in typing solve this problem? This is how we name the HLA antigens. We put HLA and then the gene and then followed by asterisk or a star, and then the first 2 digits represent the allele group and the second 2 digits represent the protein present in this allele group. Up to the allele group, this is low resolution. If we have the 4 digits, the 4 first digits, it's enough for us because it's high resolution, and the following digits either represent synonymous DNA substitutions. It means substitution in DNA that and the protein is the same, or variation outside the coding region in the intron, for example, and not in the exon. فأنا اللي يهمني الأربع أرقام الأولانيين. First case عندنا recipient عنده anti-DQ antibodies DQ2. طيب ليه DQ2؟ لأن لو هنبص على البيتا تشين هنلاقي البيتا تشين كلها 02. فكل التايبنج ده ال6 أنواع دول ممكن يبقوا DQ2. في البوبيليشن ده درسوا البوبيليشن لقوا إن في البوبيليشن ده في 45% عندهم الألفا دي مع البيتا دي، والانتي بودي اللي عند الريسيبيانت بيرياكت مع ده. ولقوا ان 48% عندهم التايبنج ده و7% عندهم التايبنج ده. فاذا انا هذا الريسيبيانت اللي عنده الانتي دي كيو 2 منعته من انه ياخد كل الدونرز دي، في حين هو الممنوع عنه هو ال 45% دول، لكن يقدر ياخد من باقي الناس اللي عندهم دي كيو 2. فكده انا يعني في الحاله دي انا لو عملت هاي ريزوليوشن ده هيساعدني على ان انا اديله فرصه اكبر انه يلاقي دونر. دي حاله ثانيه بقى اللي هي نيجاتيف فلو سيتومتري كروس ماتش بيشنتس ويز بوزيتيف سنجل انتيجين PRA2، ودي بنقابلها كتير جدا في يعني ان براكتس. فده عندنا الجدول ده عباره عن ريسيبيانت ودونر. لو هنبص على الدي كيو تايبنج بتاعهم هنلاقيهم هما الاثنين دي كيو 7 دي كيو 9 والدونر دي كيو 7 دي كيو 9 على مستوى السيرولوجي. لكن وليه هو 7؟ لان عنده O3O1 وعنده O3O3 دي بتاعت ال9، وهنا برضو O3O1 و O3 بتاعت ال9. لكن لو بصينا على الكومبينيشن بتاعتهم في الالفا تشين هنلاقيهم مختلفين. المفاجأة كانت ان الريسيبيان ده كان عنده انتي بوديز to 7% to DQ8 DQ7 and DQ9. فدي اللي كانت غريبة باينة لما اطلع النتيجة، معناها ان هو زي يكون عنده انتي بوديز to self and the antibodies to the donor، يعني DSA positive and antibodies to the self. فممكن لما حد يشوفها يقول لا دي نويز، دي اي حاجة غلط. فالحقيقه ده البي ار اي سنجل انتيجين بتاعته. ولو بصينا هنا على الام اف اي هنلاقي ان الدي كيو 8 كان 20000 والدي كيو 7 الام اف اي كان 16000 والدي كيو 9 كان 13000. فيري هاي ام اف اي. فعملنا الكروس ماتش بينهم، الكروس ماتش توتالي نيجاتيف. طب ازاي كروس ماتش نيجاتيف وانا عندي انتي بوديز DQ7 with DQ9? If we go more deep, we go to the raw data on the Luminex for single antigen PRA. We can see the alleles to which the antibodies are present for DQ7 and DQ9, and it is different from the recipient and from the donor. That's why the flow cytometry cross match was negative. دي المشكلة الثانية. آخر حاجة بقى إن ال consequences of de novo donor specific HLA antibody development. In recent years, it has been increasingly recognized that a leading cause of graft loss is chronic antibody-mediated rejection, attributed to the development of de novo antibodies against mismatched donor HLA expressed on the graft. These antibodies are most frequently against donor HLA-DQ molecules. Generation of de novo donor-specific HLA antibodies also leads to increased sensitization as measured by PRA. Consequently, access to transplantation for patients returning to the wait list in need of a second transplant is compromised. أنا نقلت kidney different في الدي كيو. هو ابتدى يعمل de novo antibodies. هتعمل chronic antibody mediated rejection. هيحتاج بعد فترة second transplant. يرجع تاني الويت ليست. هتبقى العملية صعبة جدا لأن عندي antibodies to DQ. More than 50% of patients with 2 HLA-DQ mismatches in the first graft were highly sensitized on return to the transplant wait list, an effect that was significantly less evident with mismatches in other HLA loci. A key phenomenon of most of HLA DSAs is their strength and persistence, usually appearing as the most resistant antibodies to treatment. Conversely, patients with 0 HLA-DQ mismatch may experience less rejection, less late rejection, and less antibody-mediated rejection. Recent data suggests that the lowering the burden of HLA-DQ alpha and beta chains mismatching may support reduced levels of immunosuppression exposure with an attendant benefit on morbidity and mortality. Recommendations. Viewing DQ molecules at their current serologic definition is too simple and is not sufficient. Introduction of HLA-DQ into kidney transplantation system as a routine in both typing and matching. DQ antigen typing at a high resolution for HLA-DQ-A and DQ-B genes instead of current practice for reporting DQ serologic equivalence. High resolution evaluation of DQ antibody repertoire will help to understand and avoid impact of HLA-DQ mismatching in subsequent transplantations. وفعلا the French system had introduced the HLA-DQ matching into kidney allocation scheme in 2015, and the British National Health System Blood and Transplant is the only agency whose recently revised allocation algorithm consider 5 HLA loci for matching purposes: A, B, C, DR, and DQ. Thank you.
Thank you, Dr. Berta, for the very illustrative talk. Is there any question? Dr. Ahmed?
So, الحقيقة يعني thanks a lot. It's getting much more complicated. يعني أنا بس محتاج أسأل حضرتك سؤال. العيان الأخير اللي طلع اللي حضرتك عرضتيه اللي هو نيجاتيف فلو سايتومتري وبوزيتيف PRA with a high MFI على الهاي ريزوليوشن ليفل، ده يتقبل ولا يترفض؟
لا يتقبل. هو عنده انتي بوديز او لاول وهله الواحد يقول ده دي اجينست يعني دي اس اي بوزيتيف، لكن لما بنرجع فيه بقى الجزء رو داتا احنا ما بنرجعلوش عاده، بس لما نرجع له بقى على السيستم بنقدر نعرف الانتي بوديز دي طالعه قصاد اني بيدز باني اليلز بالظبط. فلو الاليلز دي مش موجوده عند الدونر يبقى دي اس اي نيجاتيف. يعني نعمل الدي سي اي على مستوى الاليفز، ما نعملش دي
اللي هو بعد الفور ديجيت ولا على الفور ديجيت يعني؟
لا هو اهم حاجه عندي الفور ديجيت.
على الفور ديجيت.
اللي بعد كده مش مهمين.
طب معلش ده هيجرنا لنقطه ثانيه حضرتك. احنا بالنولج اللي موجوده دي احنا از نفرولوجيست وترانسبلانت يعني فيزيشنز ما ينفعش نقرا لا الاتش ال اي ولا البي ار اي as simple as such. يعني اعتقد انه should be او we should have يعني annex من اللاب بيقول فيها الانبوت بتاعه على الابليكابيلتي اوف ذيس ترانسبلانت.
طب انا بحب برضه
ايوه
تطلبوا مننا على طول دي اس اي اون ذا allelic level طلع
يعني اولا يعني كده لازم اولا لازم يكون التايبنج هاي ريزوليوشن، ثانيا لازم ينكلود دي.
كفايه قوي التايبنج اللي عاملينه. احنا ممكن نلاقي صفحه كلام كتير والدوشه كتير بتاع الانيس ما بنحطهمش بس هم عندنا على السيستم. يعني we have the alleles and we have the antibody against what type of allele. هي it will take some time من اللي قاعد ان هو يشوف الانتي بوديز دي against الاليلز بتاعت الدونر ولا لا. فدي ممكن نعملها.
I think اوكي دكتور دولة.
حضرتك قلتي example ان الفلوسايتومتري بوزيتيف والسنجل انتيجين بيد نيجاتيف.
لا
ده
هو
معناه
العكس.
ايه؟
هو الفلو كان نيجاتيف، الفلو سايتومتري كروس ماتش كان نيجاتيف، معناه ان ما فيش دي اس اي،
مفيش
نفس الوقت في دي اس اي.
لا ده معناه ان هو
لا لو احنا خدناها سيمبلي كده، لو انا
انا اقول نون اتش
بعملها
ال اي انتي بوديز لما اقول السنجل انتيجين بيد نيجاتيف والفلو سايتومتري بوزيتيف.
لا العكس.
أيوة. هتبقى نون اتش ال اي.
العكس
حضرتك قلتي ان
الفلو سايتومتري كروس ماتش
الفلو نيجاتيف وده بوزيتيف، معناها ان لو تايتر اوف انتي بوديز صح؟
لا هي دي فيري هاي، ده 20000 و16000.
كان طب ليه الفلو سايتومتري نيجاتيف؟
ما هو طالع نيجاتيف لان الانتي بوديز اللي طالعه دي مش اجينست الاليلز بتاعت الدونر. هي مشكله الدي كيو ايه؟ ان انا النومنكليتشر بتاعتها السيرولوجيكال النومنكليتشر بتاعتها بتلخبط. السيرولوجيكال النومنكليتشر بتاعتها المفروض تتغير، هم عاملينها على البيتا تشين. طب انا عندي في فاريشن كمان في الالفا، والانتي بودي لما بيطلع يلزق على ايبيتوب هو بيلزق على 3 دي ستراكشر بتاع الانجين اللي طالع على السيرفيس، مش بيلزق على البيتا سبيسيفيكالي. فهو الانتي بوديز اللي طالعه دي لازم تبقى طالعه اجينست نفس التو اليلز من الالفا والبيتا. فحضرتك في النومنكليتشر بيطلع لك ان هو عنده انتي بودي تو دي كيو 7، بس دي كيو 7 دي ليه هي دي كيو 7؟ عشان البيتا او 3 او 3 او 1، يعني البيتا تشين او 3 او 1.
طب انا لما هيجي لي ريبورت ان السنجل انتيجين بيد بوزيتيف،
انا ما بقولش حاجه، احنا بنطلع ريبورتات ممكن ما تبقاش صح. ليه؟ لان احنا بنقول لكم في انتي بودي تو دي كيو 7 ودي كيو 9 وخلاص، لكن لما ترجعي لها بقى تانلايز تاني لا هو مش اجينست الدونر.
طب انا هعرف
هو دي اس اي نيجاتيف، واحنا بنشوفها بالعكس بقى لما يطلع عندنا الفلو سايتومتري كروس ماتش نيجاتيف. طب ازاي ده نيجاتيف وازاي ده؟
معنى كده الفلو سايتومتري هو الفايزر،
هو الاهم يعني.
هو طبعا يعني اهم حاجه الكروس ماتش اللي بين العيان وال
الكروس ماتش والسايد كروس ماتش الفلو سايتومتري نيجاتيف، يبقى ده اهم من الدي اس اي.
بس حضرتك دي اس اي برضه مهم، لان في ناس ممكن تعملها دي سنسيتايزيشن في ليفل معين يعني، بس هو المهم نطلعه صح، ما نلخبطكوش يعني يقول لكم دي اس اي بوزيتيف وهو نيجاتيف.
لو حضرتك بتقول ان الفلو سايتومتري نيجاتيف وطالع الدي كيو 7 بوزيتيف في
اللوينكس
يبقى نعتبره نيجاتيف.
ما هو غلط بقى ان احنا نعتبره
يعني بس احسن ان احنا نقول لحضرتك هو الانتي بوديز دي مش اجينست الدونر ولا حاجه. حضرتك قولي اعملي لي دي اس اي اون ذا allelic ليفل.
هنعمل ايه بعد كده؟
هنطلعه نيجاتيف. هنزرع لو الفلو نيجاتيف ودي اس اي نيجاتيف هنزرع. يعني احنا بالرغم ان هو احنا مطلعين فيه انتي بوديز دي كيو 7 والدونر عنده دي كيو 7، هنقول لحضرتك لا دي اس اي نيجاتيف، وهنطلع لك الاليلز ونقول لك لا الانتي بوديز دي اجينست الاليلز الفلانيه والدونر ده عنده الاليلز الفلانيه، فمفيش مشكله.
هو ايبيدوب.
ما هي يعني الاليل بقى ال 3 دي ستراكشر
ليه؟
هي محتاجه مننا احنا مور اناليسيز على الماشين بس.
دكتور ميرفت تاني ليه على مرتين؟ دي حضرتك مش يعني مش كونكلوجن فروم ذا فيرست، يعني ليه حضرتك بتعملي الاول بعد كده نطلب من حضرتك نعملها على القليل؟ ليه حضرتك ما تعملهاش مره؟
حضرتك لو جالك نتيجه ان في دي اس اي بوزيتيف سيمبلي اجينست سيرولوجيكال سبيسيفيستي، فحضرتك ممكن بس تطلب من المعمل يعملها لك على الدي ان اي القليل ليفل. دي اس ايه ده قليل ليفل.
طلبت ان هو يتعمل على القليل ليفل، هيبقى عندي تو سيناريو، يا اما هزرع يا اما مش هزرع. طيب ليه حضرتك من الاول ما يبقاش فيه كونكلوجن؟ هل ده مثلا كوست؟ يعني مش عايزين.
لا احنا ما بناخدش كوست خالص على دي اس ايه على فكره، حتى بنعمله فري لكل المستشفيات.
نطلبها ليه؟
ما انا ما بقاش عارفه مين الدونر بتاع مين ده اجينست ايه، فهو بس يعني في الروشته هنطلبها هي بالظبط. الحقيقه يعني انا من الحاجات اللي بطالب بيها وممكن اطالب مع التغيير السن والحاجات دي،
يعني ريبورت يا دكتوره
ان احنا نعمل دي كيو كمان مع
يعني الاثنين لازم يجي لي في الريبورت دي كيو للدونر ودي كيو للريسيبيانت ماتشنج ولا لا؟
بالظبط.
يعني يا دكتوره ميرفت لما يطلع لي في اللومينكس ام اف اي بوزيتيف للدي كيو 7 لازم نكون اصلا محللين للريسيبيانت.
يعني هو صح انه احنا نعملها الاثنين، لانه حتى نمنع يعني حتى لو هما ما فيش دي اس اي، هو لو في اختلاف بين الاثنين هو هيديفلوب هيعمل دونوفو انتي.
يعني لو الريسيبيانت بوزيتيف للدي كيو 7 وانا عندي الريسيبيانت عارف ان هو دي كيو 7، حضرتك تعمل لنا القليل من سكان وتقول لنا ده سبيسيفيك ولا نوت سبيسيفيك.
حاضر.
علشان ما ندخش احنا ازرع وما تزرعش.
لازم كل تيم ترانسبلانتيشن لازم يبقى فيه اميونولوجيست.
يعني بس عارف هيك الحوار ده
بيبقى الاميونولوجيست بتاعتك التيم بتاع الزرع بتاعك يبقى فيه واحد اميونولوجيست كونسلت او.
طب هل هي ماتش مور كوستي ان انا اعمل الدي كيو للدونر والريسيبيانت عشان يجي لي في الريبورت؟ ليه ما بتتعملش روتين؟
ما هو ده اللي احنا بنطالب بيه، احنا عايزينكم تعملوها روتين. يعني احنا عايزين نقاد ده للاي والبي والدي ار ومعاها الدي كيو.
ثانك يو فيري ماتش دكتوره ميرفت. ونخش بقى على الميرفت لاب، يقولوا لنا هيعملوا لنا ايه. فين ميرفت لاب؟ مين اللي هيخش على الميرفت لاب؟ يلا عشان متاخرين.
مش الاول في
لا هنخش على الميرفت لاب على طول، وبعد كده على الدي تي اي. الدكتوره مي خلاص هتقولها لنا بعدين. بعدين
في العشاء بقى.
لا بعدين. مين اللي هيقدم لنا من ميرفت لاب بقى؟ ياسمين. فين الدكتوره ياسمين الانصاري؟ يلا يا ياسمين، يلا خش بقى. عايزينك تبدعي بقى باللي هتعمله لنا بقى.
حاضر.
يلا.
Good evening. I will talk about the leading role of Ansari Laboratories in transplantation tests. To talk about Ansari Laboratories, we have to talk about the founder and chairman of the Ansari Laboratories, Professor Dr. Mirvat Lansari. An eminent of immunology in Egypt. She held a lot of posts. One of the main significant posts she held, the head of Qasr Al Aini Clinical Chemical Biology Department. She is one of the committee of the organ transplantation. She had a lot of achievements. One of the most important of them that she is the one who established HLA typing in Qasr Al Aini Hospital. She established transfusion medicine master degree. A lot of achievements. I cannot talk about all of them. Dr. Mervat, she founded Ansari Labs in 1987. Ansari Laboratories or Ansari Labs is a chain of labs all over Cairo and one branch in Alexandria. Our labs cover different laboratory specialties: chemistry, hematology, immunology, molecular biology, and opening soon our new core lab. Our staff is over 220 employees, integrated team of professionals of biomedical fields. Our labs, beside doing the routine tests, we are dedicated to do special and sophisticated techniques as karyotyping, FISH, molecular techniques for infectious diseases, and of course histocompatibility complex testing, HLA typing. The patient is the most important person in our organization. That's why we always develop quality management system to guarantee his satisfaction. We have the latest web-based LDM system for customer results. We're serving around 1 million patients per year. We have Center of Excellency in flow cytometry, cytogenetics, molecular diagnostic, immunology tests. As I said, the quality is important for us. So we are ISO 9001 accredited, and we are participating in the testing quality systems as the RICS, ECS, and the CAP. And soon we will be accredited GAHAR and ISO 15189. About the transplantation laboratory tests, we have to do a pre-transplantation test for the patient and the donor. All through the transplantation, we have a process, we have to do laboratory tests to check on them, and there are post-transplantation tests. These tests, there are routine tests. There is blood grouping, HLA typing, class 1 and class 2, ABC, DR, and DP, and DQ. Panel reactive antibodies for screening of presence of preformed antibodies to allogenic HLA and cross-matching. About the routine test, there is a lot of routine tests to be done for the patient and the donor. CBC, kidney functions, liver functions, screening, virology, microbiology, electrolytes, coagulation profile, all these tests is done in our labs. We are equipped with automated, regularly calibrated, controls checked, updated, result system, integrated system. Most of our techniques are automated, and the result is integrated with the LDM system to prevent the clerical error that may happen. We have an exclusive test. One of them is the antiphospholipase A2 receptor antibody. Phospholipase A2 receptor is a cell surface transmembrane receptor expressed on the cell surface podocytes. 70 to 75% of the patients of idiopathic or primary membranous nephropathy have antibodies directed to this receptor. The level of this antibody has a strong correlation with the clinical disease activity and thus help in monitoring disease activity and treatment efficacy. This test mainly differentiates between the primary and the secondary membranous nephropathy because it's absent in the secondary membranous nephropathy. As blood grouping has APO grouping has different methods, mainly slide method, tube method, and card gel method. In our labs, we prefer to do the card gel method. It's a proper way we can keep our cards for a while to detect to see it, and we can confirm it sometimes with the tube method, especially if you want to do reverse grouping. Tissue typing or HLA matching, a brief history that Professor Dr. Mervat Al-Ansari introduced HLA typing Kasr hospitals in 1987. The HLA typing of the first hematopoietic stem cell transplantation in Egypt was done in Ansari Labs in 1989. This is the HLA complex. What is concerned in transplantation, it's class 1 and class 2. Class 1, the A and B and C, and the class 2, the DR and DP and DQ. Tissue typing methods, there is cell-based assay, solid phase, and next generation sequencing. Cell-phase assay, lymphocytotoxicity, CDC. Now it's not as valuable as before because it's considered as low resolution and it requires viable cells, intense work. Luminex technology, the solid phase assay, or what they call bead-based, it's intermediate resolution. What's best is now is the next generation sequencing, because it's high resolution. It's in progress. Soon, we will bring it in our lab. In progress. This is the tissue typing proficiency testing by the CAP. We can see that we scored 4 out of 4, 100% in HLA class 1, and 2 out of 2, 100% in proficiency testing of HLA class 2. This is an example of our results of HLA. This is how the results is written for the security of the patient and for better confidentiality, and to make sure that this result is from our labs. We added the QR code. As for the methods for the antibody screening, there is a cell-based assay and there is solid phase assay too. The cell-based CDC cross-match and flow cytometric cross-match. And for the solid phase, the Lumnex technology, the bead-based we were talking about, in our labs, we have different types of tests. We have PRA mixed antigen class 1 and class 2 together. We have PRA single antigen class 1 alone and PRA single antigen class 2 alone. C1q, PRA, and non-HLA antibodies. Here we can see that these are the different types of antibodies screening. The CDC cross-match has the lowest sensitivity and specificity. The flow cytometric cross-match is more sensitive than the CDC, but the Lumnex speed is the higher sensitivity of them. Solid phase assay. I'll talk briefly about the difference between these tests. PRA mixed antigen class 1 and class 2, it's considered like a screening test. It may give non-specific antibodies, but the PRA single antigen class 1 alone and class 2 alone, they are more specific tests. They detect each single specific antibody, so it's more not likely to have any non-specific antibodies. The C1q is an assay to detect the complement fixing antibodies, which have the great clinical value. Non-HLA antibodies, these are antibodies we search for when we diagnose antibody-mediated rejection with the absence of anti-HLA antibodies. We detect 40 type of antigens. PRA result interpretation, we interpret the results with mean fluorescent intensity value. When it's less than 1,000, we consider it as negative. From 1,000 to 3,000, we consider it weak positive. 3,000 to 10,000, we require sensitization, desensitization. Above 1,000, 10,000, above 10,000, this is high positive. This is an example of the PRA mixed antigen class 1 and class 2 result. Here we like the class 1 is positive in here, and the class 2 is negative. And we write the B44, which antibodies are formed. PRA single antigen class 1 and class 2. Here the single antigen class 1, we have the C, and here and we have here the mean fluorescent intensity. C1q assay result, also we put QR code on it, and there is a positive result with 2% in the C1q on this side, and here is a negative result. This is non-HLA antibodies. These are antibodies that have value in transplantation, none other than the anti-HLA antibodies. I think it's not clear, but most of them, we have anti-endothelial cell, and we have against the collagen. They are about 40 antigen. We have may find antibodies against them, and here is some positivity against the VMN. the cell-based assay cross-match. This is a CDC cross-match. CDC cross-match is this technique. We see the cells under the microscope, and we see if it's viable or non-viable, if it did or not. This technique depends on the clinician eye to detect the percent of the positivity. When there is dead cells, it's positive. When they are alive cells or living cells, they are negative. This is an example of the results of a negative cross-match and a positive cross-match with the percent of the positivity. This is the flow cytometric cross-match, which is more specific, gating the B lymphocytes and detection of the shift, the cell shift. And we interpret it as follows. If the T cells and B cells are negative, this is a negative for DSA. If T cells is negative and B cell positive, so there is anti-HLA antibodies to HLA class 2 or low titer anti-HLA class 1. If T cells and B cells both are positive, so it's an anti-HLA antibodies to HLA class 1 or class 1 and class 2. If T cells is positive and B cells is negative, these are non-HLA antibodies. This is example of a positive and negative results. Dr. Mervat was talking about the DSA report, or what we call virtual cross-match. This is simply DSA donor-specific antibody report. It's simply comparing the patient's PRA against the donor or donors HLA typing to detect if there is any specific antibodies against the donor or donors HLA typing in class 1 and class 2 HLA. This is example of one of the DSA reports, and we commented on the DSA, the positivity with mean fluorescent intensity. The presence of donor-specific anti-HLA antibodies is treated with 10-fold increased risk of graft failure in haploidentical system, in a haploidentical stem cell transplantation. Consequent guideline from the European Society for Blood and Bone Marrow Transplantation set a mean fluorescent intensity above 1,000 as a cutoff, and the absence of an alternative donor is recommended the patient undergo desensitization when he is above 5,000. In this DSA report, we reported up to the allelic level. HLA typing at DSA report also predict the development of antibody-mediated rejection and adverse prognostic indicator for long-term graft survival. HLA typing and DSA reports is important and can be used for comparing the patient HLA with the donor HLA to detect the degree of matching. Here, the patient has a lot of donors, so we developed the degree of matching and comparing the patient PRA with the donor HLA to detect the DSA. And it's important to detect the best donor available according to the matching. Here we have donor number 5 and donor number 2, 14/16 matching. And we compare the PRA also, so we can choose the best donor. Recently added service, we have, as I mentioned, web-based results for our customer. And this web-based result, any patient with his username and password, he can take the data anytime from the system. Any doctor needs to his patient to be put in a special rank, he can easily access their results at any time. QR code on HLA test, and soon on the rest on at cross-match. And we try to put, for more security, the donor and the recipient pictures on the results. But this is in progress. Thank you. Thank you so much for your time. Thank you so much.
Thank you very much, Doctor. Now we are going
moving to the session of DTI.
اوكي. هو مين
We are now going to move to the DTI session, the Donor Transplantation Institute session, which is moderated by our dear colleague Marty Manialich, and he will be leading the session. It's a 1-hour session. Is the DTI group online, yeah, Muhammad? Dr. Marty, hello. Marty. Hello, Marty. How are you? Nice to see you. Hope to welcome all of you. I am face to face in Cairo.
Hello, Chloe.
Hello, Chloe. How are you?
Hello, nice to see you. Nice
Happy
to see you. Very
you.
fine.
Hello.
We
Lead
need some
session, please,
advice
Marty.
from the organizers, maybe.
Yeah.
I will start in 5 minutes. Excellent.
No, we are ready to start immediately.
That means that they are almost on time, no?
Yeah, almost, yes.
We are ready, Marty. We can start.
Oh, Dr. Gamal also there. Fantastic. Hello, hello.
Marty, I think they would like you to proceed. We
Yes.
could start, I think.
I was not hearing you. Okay, Gamal.
Yeah, go ahead, Marty. It's always a pleasure to have you with us, and thank you for your support for the transplantation programs worldwide. Marty, you are doing a great effort, and we are awaiting a lot of from you for the African society and African region.
Okay, the same is from DTI. It's a pleasure to share all these meetings of the African Society, Organ Transplantation Society with you, Dr. Gamal. And today's session, we have 4 speakers talking about the ICU as a key player in DVD-DCD and tissue donation will be Mariana Irazabal. And this presentation is recorded because of the inability of Mariana Irazabal. Later on, you have in the program the Nacho Revuelta, who is an eminent nephrologist working in the disease and living transplantation in artificial intelligence, and also a good friend. And he will talk about the quality, safety, and transparency in living donation. The next will be myself about how DCD can contribute to the donor pool expansion. And finally, also my colleague, the Dr. Chloe Ballester from the DTI, professor of Barcelona University, and a dreamer of Africa also, is how to develop the self-sustainability of organ transplantation in Africa. Then please, if the organizers can go ahead with the video of Mariana Irazabal, and any comment later on, we can answer the questions for her.
Start the recorded session. You have a recorded talk?
We don't have, she sent to you.
Yeah, I'm asking my colleague here, yes.
Okay, sorry.
You have a recorded talk?
Martí, jo la puc projectar si cal, eh?
If not, Chloe Ballester can share the screen and project it. We can proceed, Chloe, maybe. It's more quick.
Okay, give me 1 second.
Dr. Gamal, Dr. Ballester will share the screen and the video of Dr. Mariana Irazabal.
Okay, the talk which is recorded is of Nacho Revuelta.
No, it's the Mariana Irazabal, the first speaker. But don't worry, Dr. Ballester have the video of Mariana Irazabal, and now she is sharing the screen and the video. I hope it works.
Okay.
Well, 1 second, I'm just, it's a little bit heavy, so that's why it takes some time. So you're many people over there. We cannot see.
And I see Faisal Shahim is in the group.
But in face-to-face, I mean.
Ah.
Okay, here it is. 1 second, because it's...
Yeah. Hi,
Hello,
Marty.
Faisal. Nice to hearing you, my friend.
Thank you. Thank you. Hi, Marty.
It's very heavy, Marty. That's why it takes time, but it's almost here.
Perfect.
Okay.
Because very important, the role of the ICU, and Dr. Mariani Zabal is an ICU doctor. He's a master in donation and transplantation, have a large experience in all the process of the disease donation in the ICU with a death diagnosis, a maintenance, family approach and communication of the bad news. Also the important point was the identification of the potential donor, no? How the ICU colleagues have to refer these cases for the purpose of donation.
Okay, so here it is.
See the screen now. Make full screen. Yes, great. Go ahead.
Yeah, can you hear it?
We now no.
Okay.
It appeared and then vanished.
Okay. It comes from
Foundation. It is my pleasure to participate in this conference as part of the first African Society of Organ Transplantation Congress, and I will introduce the following topic: the ICU as the key player in DVD, DCD, and tissue donation. I am Dr. Marian Irazabal from Barcelona, Spain, and specialized in intensive care medicine and transplant coordination. First of all, I would like to say that I have no disclosure for this presentation. To introduce the topic, I would like to present in this slide the reality worldwide, published by the Global Observatory on Donation and Transplantation, to see that in 2020, less than 10% of the global needs in organ transplantation were covered, with almost 18% of decreased activity compared to the previous year, especially in deceased donor. In this regard, all the effort should be focused in maximizing the number of potential donors identified, because there's a fact that without no donation, there is no transplantation. As you can see in this figure published by the National Transplant Organization here in Spain, this is our current scenario regarding the donation activity. And as you can see, from 1997 until now, the proportion of DCD donors is increasing, and in 2020, the donation rate after circulatory death, represented in yellow, was 13.1 per million population, which means that almost 35% of the donation activity in Spain comes from the DCD pathway. So after presenting the general overview in Spain, I will move to the issues that we are dealing when talking about missing the potential donors, and that were actually collected as part of the quality assurance program in organ donation in the past years from the ONT. And as you can see here, from almost 43,000 potential donors, the conversion rate into actual donors. So passing to the next point, when we say lack of potential donors correctly identified, it is referred to the deceased donors, either from a donation after circulatory death or donation after brain death pathway, depending on the program available in each country. The non-identification of donors is one of the main causes of failure in the donation process. In this regard, a set of common terminology was introduced by an expert panel in 2011 to describe the different types of donors after deceased donation, either by neurological or by circulatory criteria. The main goal of the critical pathway, as you can see here, is to unify definitions to facilitate communication between healthcare professionals to be able to speak all using the same language. To identify donors, it is necessary to know not only the profile of the potential donors, but also to set up the necessary means to create a strong network according to each hospital reality. To follow up coma patients is an important element in identifying possible donors, some of whom may progress to brain death. In this sense, coordinators must work closely with those units that are able to provide mechanical ventilation. On the other hand, it is necessary to clearly define the circumstances that should lead to the goal for an assessment by the transplant coordination team. Within this context, coordinators can ensure the follow-up of these patients and also can evaluate the possibility of upstream organ donation earlier. Getting deeper into the donation process, as you all may know, the first part is addressed to donor detection, and in this regard, it is important to differentiate two possible sources, one from inside the ICU and the other from outside the department of the ICU. The main message to improve donor referral outside the ICU is to understand that early detection is key. Early detection and subsequent referral to the ICU of possible donors may account for important differences in the potential for donation after brain death. And this is actually aligned with the good practice guidelines in the process of organ donation issued by the National Transplant Organization. And in that regard, the important thing would be to maintain a proactive interaction among intensive care team and the rest of the healthcare professionals and transplant coordinators involved. The other scenario is inside the ICU, meaning that as intensive care doctors, it is our duty to detect every possible donor that is admitted after a severe neurological injury with the Glasgow Coma Scale below 5 to be able to have a close follow-up together with the transplant coordinator, and in this case the communication should always occur independently of the patient age and associated comorbidity and prognosis. Regardless of the unit where the patient is managed, the transplant coordinator must be systematically called upon to assess whether or not a donation could be considered. Many organizations can be involved in identifying potential donors. In each department where donors can be identified, certain elements must be put in place with the help of the coordination team. Here you have an estimation of donor potentiality based on the hospital size according to the number of deaths and the number of hospital beds per year. What about the causes that could justify the lack of donor detection? First, could be related to the lack of awareness or lack of familiarity with the process. Then could be related to the lack of communication, for example, from the ER department to the ICU, and this is very common depending on the size of the hospital. And another issue related to the conflicts that could exist in internal relations. The idea would be to identify those that are affecting us in our development. First, in order to propose different solutions that can add support to the whole process. For example, the necessity of training courses, or to implement some protocols, to perform an analysis of the problems, or to develop a different circuit design, or to create quality groups to address the issues. Lastly, I wanted to conclude talking about the donor management time, and it's true that the majority of the process takes place in the ICU. Up to 20% of the organs and a large number of potential donors are lost because the clinical management is still challenging, and in that sense, multiple tasks need to be completed in a structured way to maintain the potential donors. And for me, the key is to maintain the communication between the ICU staff and the procurement organization to ensure the optimization of a higher number and quality of organs. And the organ donation process has been improved with the involvement and commitment of many healthcare professionals from other areas. But despite of growing success of organ transplantation as the primary treatment for end-stage organ failure, the gap between demand and supply for organs continues to widen. As a result, nearly 20 people die each day waiting for an organ transplant, and the idea of critical care management to enhance the donor pool is not new. And in this regard, during the past decades, numerous studies reflect a paradigm shift in the transplantation area and have demonstrated that the implementation of organ donor protocols, promoting aggressive critical care management and specific training in this field results in positive donor outcomes. In order to improve the process of donation after brain death, an ABC approach to organ donation has been suggested. And while we are focusing here on donor management part, it is essential to highlight that as treating physicians, we could also help to identify medical conditions that preclude the possibility of donation even before the process begins. And this will avoid the unnecessary expenditure of time and resources required when assessing donor eligibility. Regarding the factors that could influence the management, these can be summarized into these. First, the lack of specific training, then the need to provide concomitant care to other critical ill patients, especially now during this pandemic. Lastly, the process can be physically and emotionally draining on ICU staff. So in these cases, a debriefing session in every case can be useful for supporting staff and throughout all the process. Another thing is that goal-directed protocols are useful to increase the number of donated organs and tissues. Still, we have some controversies about which one is the most appropriate. And also another factor that we have to consider is the change in donor characteristics to include a growing number of older patients with comorbid conditions to be able to expand the donor pool. And also to mention that in this era of new ex situ machine perfusion techniques, it is important to remind that intensive care of potential organ donors is the first and the most essential step in organ treatment aimed at preventing graft failure in the recipient. So without high quality of intensive care and professional commitment, all the traditional and the new advanced technologies of organ preservation cannot be effective. So the management of potential donors could be simplified by adopting clinical guidelines to increase adherence to the standards of care. And it's true that these adherence should be also systematically audited in the ICU. And for that, key interventions should be prioritized to guarantee the quality of care that can significantly impact on the donor, the family, the recipient, and graft outcomes. Quality in ICU management is a requisite for avoiding the shift from DBD to DCD in cases where we are not expecting that, and to preserve a higher number of organs recovered from DCD. And I will conclude this presentation with some take-home messages. First, to remind that organ transplantation is the best treatment indication for some terminal diseases, and organ donation is a life-saving hospital service. In this regard, early and active identification of all possible donors admitted to the hospital is key. That intensivists and anesthesiologists need to play a vital role in the management of potential donors. Protocols and checklists can help to guide and to promote successful organ and tissue donation. An early institution of the appropriate maintenance strategies is fundamental to increase the number and the quality of organs for transplantation. And lastly, that the proactive interaction among intensive care team, operating room professionals, transplant coordinators, and all the personnel involved is essential. And thank you very much for your attention, and I will be glad to answer any question or comment.
Okay. Thank you. Dr. Gamal, what we do? We proceed with the presentations or a matter of time?
Yes, please, let us proceed.
Well, because I will invite my colleague, Ignacio Revuelta, please, about the living donation quality, safety, and transparency.
Thank you to everyone. Thank you, Martí. Thank you, Professor Gamal. I think for me it's a real pleasure to be here with all of you. It's a shame not to be in face-to-face meeting, probably in the next year. For this, the first African American Organ Society Congress. For me, it's a pleasure because I think it's very important to keep in mind that we have to work together in the donation and transplantation field. And this is in accordance with this topic, because I'm not a transplant nephrologist involved in the living donor kidney transplant, but we need to keep these main principles: the quality, safety, and transparency. And this is in agreement with our thought. This is my financial relations, not disclosure, for this presentation. I think it's in accordance with what we believe the high quality practice in living donation. I think it's this safety, quality, and transparency. But we need to understand what is safety, what is quality, and why we need transparency in this living donation. This practice is one of the activities of LIDOPS. LIDOPS is the Living Donor Observatory. Then this is a process along the different 20 years that Martí is leading this very nice project with joining different process in Europe. Then I was very happy to be in this project because too many countries in Europe were involved. And then we at the first beginning, we need to understand what is the information we need to give to our potential donor or even our colleagues. And then after all, we organize a conference, international concepts funded by European Union, and too many countries were involved, and we discussed this high quality practice. And then at the end, was more than 100 participants, and some of you were involved in this conference and in this project. And then finally, we can give some kind of recommendations for this high quality practice. And recently, we tried to involve all our European experience in Africa with all of you, trying to be involved like in this Congress and other activities, because I think Europe and Africa have to work together in the future. And this is different experiences in our center in Kenya with started living donor kidney transplant progress. With this, our philosophy on lastly in 3 months ago, one living donor transplant from people from Congo. But we need to understand that the living donor is the best option. I think people know, and this is the collaborative transplant data that is published free with too many patients were evaluated, and then we can see the patient survival is of course with living donor is higher in the short and the long-term follow-up. And all of the patient is the raw survival. We can see in the long-term survival is not the difference are not so high because we are doing very good work with the disease donation, and probably we have so many facts to be addressed in the short-term follow-up, but at least in long-term follow-up, the results are very good that we can show in this correlative registry. But we need to take care about the recent security of living donor, and for me, it must be guaranteed. We know that there is perioperative mortality, and this is 20 years ago. Data is very long, but we can see it's very low, but at least it's not zero. We have some kind of risks, and we need to evaluate. At least in the long-term survival, this is the data at the end of the 2000 decade, and we can see here in a New England Journal paper that 4,000 living kidney donors was similar survival comparing the general population. But the same group published 1 year after that with 10 times higher numbers of living donor that it is worse survival in living kidney donor. There was like a starting discussion and very controversial the use in this case for survival. We have to take in mind that we are comparing different control population in both studies. One is the second one excluded probably contraindication for donation that is not really in our clinical practice. The same paper for Norway was published. But we need to understand what is the trajectory of the post-donation outcome. This is a very recent publication, probably previous to the COVID pandemic. This is very nice JAMA paper. Then they evaluate almost 10,000 living donors in United States, and we can see how it is very different, the different surgical problems or surgical aspect that we can be done in the first moments of the nephrectomies, and how the impact of the long-term follow-up of hypertension, diabetes, proteinuria. This is very important to check because sometimes we don't do long-term follow-up. In this paper, they separated the short complication related with the surgery, and in our group recently we published our experience with the nephrectomies in more than 700 nephrectomy, and we tried to do minimum invasive nephrectomies with laparoscopic nodes and LEDs, and we can see the donor's characteristic was similar in both groups. These three groups, and we can see the different surgical characteristics or surgical time, or ischemia time, hospital stay, conversion, probably a little higher in less, but in the different characteristics is quite similar in the three types of nephrectomies, but the early complications were quite similar, probably less, a little higher as the previous one, but I think it's very safe, the surgery, even if we are looking for minimum invasive nephrectomy. What happened with the long-term follow-up? We know as the same comparative articles in the New England Journal paper of Norway and US, and we can see that we have to take care because there is a little risk of develop chronic kidney disease if we are not evaluated correctly the potential living donors, but we need to follow up. Well, the first question we have, there is some kind of living donor profile affecting to the results. We need to look indeed. And this is a paper with a relief study group that is published 8 years ago, but this really clearly in the last 4 decades, there are no differences in the living donor profile in terms of age, BMI, serum creatinine, fasting blood glucose, blood pressure, or lipid disorder. But we need to go for the transparency, because if we know this evidence and we know this data, we have to show and to inform consent to the potential donor and the professional involved in the different fields in the chronic diseases or chronic diseases. And for us, we need to registry to know this, and we believe in this. The leaders believe in the registry model data. Then we have to integrate mandatory data. For example, in the first level, donor recipient nationality, resident relationship, organ and donor survival, probably the typical data that we are collecting in every clinical study. For us, it's recommended the second level in terms of the security in the pro and post donation parameters. But of course, we need to follow up. If we don't follow up the donor, we cannot register this recommended and mandatory data. And go for the excellent. The excellent is we need to check if the quality of life of living donor, the satisfactory or psychological follow-up. This is our model. We have 2 different modules for data uploading. There are some countries that are collecting the data manually enter in the module, as Russia, Latvia, Lithuania, Slovakia, and Portugal. And another countries, they are giving us or trying to upload different modules of their database, as Netherlands, Poland, Spain, and United Kingdom. But the future is to try to take the opportunity to use artificial intelligence for the registry. I think it's important to do automatically, because we are very busy, and sometimes it's very difficult to try to get the data and upload in a different web page or different model. But I think if we can create some product, so we can use some technology to integrate this data automatically. And then as we are addressing a consortium with Marti Majalik in trying to use this artificial intelligence technology and then federate data infrastructure to check to complete this registry. As a summary conclusion, I believe, I think our group believes that safety, quality, and transparency are the pillars of the high quality practice in living donation. Of course, we know that living donor may offer the best option. However, the security must be guaranteed. The territory work network for post-donation outcomes have to guide in the follow-up of the living donor. And we think that this registry model data based on this pyramid model with mandatory recommended and excellent step could help to get this safety, quality, and transparency of living donor transplant programs. And as Ernst said, the world we have created is a process of our thinkings. It cannot be changed without changing our thinkings. As Mahatma Gandhi said, the future depends on what we do in the present. Thank you very much for your attention, and thank to all of our colleagues, especially to Marti Majalik and Chloe Ballester, the TIA community, to invite me and to stay to these principles in living donation.
Thank you, Dr. Revuelta. Dr. Gamal or any chairperson, any comment or question about this
yes,
presentation?
I have a comment for Nasu, please. When we are considering extended criteria donors or living donors, extended criteria living donors, how are they comparable with the DBD, which is deceased brain donation, or the extended criteria DBD, or the DCD, deceased cardiac death?
Thank you so much for the question. I think it's very clever, and this is a key point. The thing is, in Spain, you can see the age of a living donor is almost 60. solve of all the living donors. Then we are now running the expanded criteria donor probably in the majority of living donor kidney transplant in Spain. But I think when we compare this standard living donor kidney transplant, we presented, I think 2 years ago in American Transplant Program with another option of deceased donor, is better results because you can see that if you are comparing old living donors with in terms of renal function recipient is 60 years old living donor is comparable with 20 years deceased donor. That is probably is not offered to a standard recipient. I think, but the problem is we need to understand the complexity of the donor and the complexity of the surgery, and sometimes we have some problems with this kind of nephrectomies in terms of to get good result, at least at the beginning. But we believe that even if we use expanded living donor criteria, is better than deceased donor. But we have to, of course, to compare different individual aspects.
Thank you very much. Let us proceed, yes.
Okay, thank you. Then it's my turn, I think. I will try to share my screen. Thank you, Nacho. Just to tell you that Ignacio Revuelta and Cruz Ballester are focused in Africa with many programs and are available to collaborate all the time. Try to share. Usted no puede iniciar la función. You have to stop to sharing, some one of you, to allow me to share. Okay, now I think it's that. Okay. You see now my screen?
Yes, Martin.
Okay, perfect. Well, my talk will be how can the DCDV contribute to the donor pool expansion? Maybe is a discussion. In some countries, like in areas like Africa, maybe rare death is difficult to understand. Why not circulatory death could be an option, no? We know that worldwide, this is the map that is no donation, no transplantation. That is the main issue, while here in Africa, many living donation is in practice. This, you know that Spain, with 48 donors per million before the pandemic, is the world leader. And we have countries like in Europe and in the States also with great results. But in the same graphics in red, I put the countries who also do donation after circulatory death. And it's only few of them, and always is a complementary source. It's not the unique source of donation. If you do the world ranking, donors per million of population from before the pandemic, Spain is 16 donors per million, they're followed by France and United Kingdom, Netherlands, US, Australia. This way you can see where you can learn this practice and where regularly donors are used. Living donation is a pure practice in Spain, only 7 per million, and for the liver is the same. Well, from all the world, this slide has been presented from Mariana Irazabal. 22% of the total deceased donors today are DCD. It's a quite important part. When we look at the source of donors for transplantation in Spain, in the States, in UK, you see that in red, 12% of the contribution is a DCD. The rest is living in green or DVD in blue. And we look to the Turkey or India, mainly is only living, probably the similar in Africa, and a few is a deceased donation. Why also the DCD in our developed countries? Because every time we have less traffic accident, we have more expanded donor criteria, older donors, there is not more sources. And the new sources could be the DCD. And that is what we published in 2018 together with Francis Delmonico, the opportunity for the donation after circulatory death worldwide. This is the cause of death in the world, 56 million every year. But look at that, 8 million, 0.7 die for ischemic cardiopathy. It's the first etiology of death. Some of us who have ischemic cardiopathy on the streets or in the office or at home, and we are potential, we call uncontrolled DCD. The second cause of death is a cerebrovascular accident, is 6 million. and that will be cerebrovascular accident, could be potential DBD if we evolve to brain death, but if not, they could be a controlled DCD. It's the two main etiologies who can move the people who die to the nation, while traffic accidents is only 2.3%. Well, this is what we published in together with also my friend Faisal Sahim. The TPM, the manager who procured for transplantation, have to start to identify any possible donors, means patients with a circulatory failure. And from that, we can evolve to the potential donation after circulatory death. This map shows, I don't know if I see my mouse, inside of the hospital, we can have control DCD, means patients with no good prognosis for life. We'll drop the treatment if that is acceptable in the practice, and after the desertification could be a potential organ donor. But secondly, and we started in 1986, any cardiorespiratory arrest outside of the hospital, if the transportation maneuvers allow to arrive to the hospital and after the death declaration also could be a potential donor. We have ischemic cardiopathies outside of the hospital. We have cerebrovascular accidents inside of the hospital as the main sources. Okay, then as Marianne shows in green, that is like the 30% of the donation in Spain, 15 per million. The other 33 is the DBD, so it's an important source of donation today. That is the total number in 2019, 665. But in 2021, I can tell you is a similar number or even better than 2019, even the pandemic of COVID. My hospital, a clinic in Barcelona, was a pioneer in the DCD in Spain. In 1985, we did the two first cases of uncontrolled, and all this blue is uncontrolled cases and kidneys transplanted from these donors. We start control in 2014, and our center is the leader totally in the number of DCD in Spain. Why we can do that? Because our law since 79, any deaf person, if there is not opposition, we can start the process of preservation and donation. And second, now there's a more concrete law in 1999 that for the purpose of preservation of the organs, physicians in the hospitals are allowed to start some maneuvers. That means that any death near our hospital, 5, 15, or 50 hospital with a potential cadavers of less than 65 years and less than 30 minutes of warm ischemia, means without CPR, we can be a potential. And this is how emergency service can identify these potentials. They bring by maneuvers to our hospital, but when finally the patient, the body is declared death, then we can start some maneuvers. Maneuvers of preservation by heparinization, cannulation, perfusion, continuous massage, and this is all together. We prolong CPR, we make cannulation to the femoral vessels to go to the aorta for oxygenation and to the calf vein to maintain the perfusion. And also we bring this body what we call normothermic regional perfusion. That was developed in Barcelona in the year 2000 that can improve the primary graft dysfunction, the kidneys, to warm the bodies instead to cool the bodies by my colleague Ricard Valero. And this is the dead bodies published in the American Journal of Transplantation and in Transplantation. And this body we maintain perfused, we maintain oxygenated, and we maintain at 37 degrees. And then we can assess the viability of the abdominal organs in a dead body, okay? When it's a control donor in the ICU, we can do this procedure by the cell injection technique. We don't have to do open surgery by cannulation of the vessels because they are beating. We can do this procedure. And this is how the body looks. Family says, okay, family say goodbye to the relative, and then the body goes to the OR for retrieval. Important point, my colleague here in the panel, is that to make the family aware, is the time is shorter, and second, to understand the wishes on life to donate or not. Well, our consent rate in the cardiocirculatory death in Spain is 90%, more than DBD, brain death. Death consent is 84, but for DCD is 90%. Well, we can do what we call a slow retrieval. We have time. We don't do a quick retrieval. We do a slow organ retrieval. We have 2, 3, 4 hours to organize that. And today we're lucky because we have machines that after the retrieval, we can measure the viability of these organs. You put the machines in the kidney perfusion machines or the liver, check if they produce bilirubin, how is the oxygenation of the lungs, and how is the heart beating and the prolonged preservation, etc. No? And what happened with these kidneys from DCD 10 years later with my nephrologist colleague, Federico Oppenheimer, that after 10 years, the survival is very similar to the other DBD closer to the living. That means it's the source of donors. The livers on the left with a cardiac arrest, 90 minutes of cold storage are, as you see, not viable. But if the liver from these cadavers, we can do NRP, normothermic regional perfusion in the body, plus for a few hours or normothermic ex situ machine perfusion, these livers survive. Well, we, TPM, Transplant Procurement Management, have been educated and training worldwide since 2000 in many places of the world. We have been here in Haman, together with a method and many colleagues with Faisal Shakim were inviting us for this meeting. And one example is in Japan, organ donation, it's 1 donor per million. Japan is 125 million inhabitants. And now, even with the pandemics, have less donors, 60 totally per year. But in Okinawa Island, 1.3 million of inhabitants, our colleague, Saito, starts a program of detection of the donors in the ICU, second phase in the hospital, third phase in the island. And he achieved like 20 donors per million, only implementing DCD in this area of Japan, where at this time, in 2007, even the law of brain death was not accepted. That is similar to probably to Egypt and other countries in Africa. Why not? Maybe we can plan a pilot together with Dr. Ballester, Ignacio Revuelta, and Gamal and others, okay? Well, just finalizing my slides, Spain, total donors in 2021, 655 have been DCD, 14 per million, similar to 2019. That allows to have more than 1,000 organ transplant. This is the kidneys, but also we use the livers, the lungs, and even a few hearts. Well, this is the OCAT, as a Catalan Transplant Organization registry, 5 years survival of the recipients, compare DBD and DCD, and is a similar data. After 5 years, 80% of these patients are okay. My conclusion for this, so happy for your invitation. The death potential exists in all the countries, in Africa and in the rest of the world. Social, religious, and legal accept the diagnosis of death. A cadaver is death. You see how the body looks when we make the cannulation. Then the system is possible to implement in all countries. The results in the survival today are excellent, and the cost benefit compared with dialysis or compared with no treatment, maybe in undeveloping countries, could be a possibility because it's not too costly to implement these techniques. Thank you very much. Shukran.
Thank you very much, Marty, for your elegant presentation. And we have a couple of questions for you. Professor Dalia Rojd first will ask the first question.
My pleasure.
Thank you so much, Professor. I want to ask you, when do you compensate your donors? Do you do any compensation for the donors?
No, there is no compensation in Spain because many physicians in the hospital in the emergency area, The compensation is to care this family well, is to make to understand the situation that the relative have died in the street and whatever, and then to have the maximum care to them. When they understand the situation of death, that is the example that Dr. Ballester was doing, then you can ask for donation if they wish. So it's not the compensation who makes the decision, 90% of the families accept. After saying that, the social service help any citizen in Europe because we have a national health service. All the citizens have the right to be recipient 5 times and the right to be donors 1 time. Yes, we know this message in our area, fortunately, not today. Thank you for the question.
Thank you. I have a second question for you. What are the situation or cases you don't take the donors or you refuse the donors?
Well, the cases that the family refuse the donors, if I understood you the question, we accept this, it's not a problem. Unfortunately, it's only 10% in the DCD. When the family reject, we just have to take out the cannulas from the femoral vessels.
I think the doctor, the doctors refuse to take the donors.
Doctors, no, the doctors in our case are in the same team. So our team is ICU doctors, nephrologists as Ignacio Revueltas, as Mireia Mosquera, and I will discuss, hey guys, Nacho nephrologist, Mireia urologist and surgeon, Chloe coordinator, and hey, we accept these donors by the age, by the time of the ischemia. I have the creatinine levels, I have the pH, I have the PO2, I have all this data. Sometimes could be a clinical contraindications if we find some kind of, mainly is infections or many is a neoplasia, but usually 85% of the organs of this donor are utilized. So is 1.7 of the kidneys from these donors are transplanted in less than 24 hours. In our practice today. Let me tell you an issue. For example, very curious, in Germany, it's forbidden. It's the law who forbid that. So Germany cannot do this procedure in Europe. Holland, Austria, Belgium can do. And even a kidney retrieved from DCD in Holland, in Belgium, or in Austria cannot be shared with Germany because the German law don't authorize. The machines to do non-thermic regional perfusion are produced in Germany. So it's some kind of open the mind and go ahead. But one day, one pilot in Africa, together with our team, with Nacho, Chloe, and many others, will be our dream. I think would be a solution. Many young people who die can donate the kidneys for the people who don't have the chance even to have dialysis. Will be the cheaper alternative.
Marty, please. In DBD, we have the circulatory assistance and perfusion of the organs almost maintained until the first or second call. But in the case of DCD, what is the time limit which would allow having good organs?
Well, with the normothermic regional perfusion, we can have this body perfused for 4 hours. But if we retrieve the organs, then with the ex situ kidney machine perfusion, we can go to 24 hours, ideally, but even longer, 36, 48. That allow the time to our nephrologists to prepare, to choose the candidate, to make the cross match, to prepare the dialysis, to schedule the transplantation in 6-12 hours. So it's a slow retrieval, as I show in my slide. It's not a quick retrieval of the kidney and just to put and that's it. No.
Thank you, Mark. Thank you, Mark.
For this, the outcome, as you see, at 10 years by Federico Oppenheimer is excellent. The kidneys from the street for the younger donors, Gamal, is a good option.
Yeah, thank you very much.
Thank you to you. Well, our next speaker is here on the screen, Dr. Ballester, please.
So thank you, thank you very much to all of you. I'm gonna talk about very interesting topic. I think it's how to develop self-sustainable organ transplantation in Africa. So it is my pleasure to try to talk about that. And first of all, I've organized it into first trying to understand the current status of Africa, and then to analyze the potential needs and obstacles that we might find. And finally, to propose a strategy. So we have seen that. We know what happens in Africa. Unfortunately, there are many gray countries there. So that means that no transplantation exists. And if you look at the deceased organ donors, then the gaps are even bigger. And if we look at the transplantation organ by organ, you can see that, yes, there is kidney transplantation, and we have seen some presentations in the Congress, of course, there is kidney transplantation. But here in these figures, you can see that in Africa, looking at the regions from the WHO, there is none of them comes from deceased donation. We know that part of Africa also is in this East Mediterranean region, and in here, yes, there is deceased donation. If we look at the liver, then we can see that only one country refers as having transplant activity, and 0% comes from deceased donation. And then then for heart and lung, there is no activity, unfortunately. And this makes sense. It makes sense because if we look at the global burden of diseases in Africa, it is clear that globally or in Africa, or if we look at the sub-Saharan Africa, we can see that the focus is in infection diseases, neonatal and other problems are there. But the second part in here, we can see that diabetes is there, cirrhosis. So there are many diseases that might evolve to chronic disease and with the need of transplantation. And what about the obstacles? Yes, of course, there are obstacles. And in this very interesting article that was released in 2021 from the ISN, they have analyzed these obstacles. And a part of that, I think that, yes, there is low number of specialists, and this is well known. There is no specific budget allocated in the ministries of health, which is something important also to mention. The healthcare system and the facilities are how they are. And they are, of course, economic factors that impact, and unfortunately, government instabilities. If we look at this health workforce density, that's a real problem, because if the WHO recommends to have one healthcare professional per 1,000 inhabitants, Africa is largely below, with one healthcare professional per 10,000 inhabitants. And back to the article, here it was analyzed and to see in red the shortage of healthcare professionals. You can see that almost all the healthcare professionals related to kidney failure providers is in red. And the ones that are in green are the dietitians and the radiologists of ultrasound. So there is a lack of specialists. And moreover, Africa, what is Africa? Africa is 54 countries with 54 different ministries of health, with different priorities, with 39 different languages. That means ethnicities too, regions, history. So Africa, it's not easy to talk about Africa as a whole. But what is important is that the transplant needs really exist. There is an increase on the chronic diseases. We have seen that there is a high cost of the kidney replacement therapies, and we know that transplantation is more cost effective. And there are professionals that are trained, that are ready to start. And moreover, if there is no transplantation in the country, patients will travel abroad to be transplanted. So this is something that means that we need this transplantation. So I had the chance to go with DTI and to have different relations with African countries. We went with DTI to South Africa to have a course about donation in 2009. In Sudan, we had a student for the master degree of the University of Barcelona, Abu Bakr. And in 2018, we were there together with some of the people in this Congress too. In Cameroon, with Gloria Ashuntatan in Yaoundé General Hospital, together with Tunisian colleagues in an ISN sister transplant program. In Nigeria, we have had people coming from Nigeria, a surgeon and a nephrologist in 2015. And in Morocco, well, in Morocco, it's also quite more intensive. We started with EMPODAT in 2014, a European project, and then we have continued being in contact and in congresses there. In Algeria, the same. In 2015 and 16, we were there, and we started a collaboration with a national organization in Spain, but unfortunately it couldn't go on. And in Egypt, also with EMPODAT, 2014, 2016, and then also with International Continuous Medical Education in Transplantation in Cairo in 2017. And then finally in Ethiopia, together with the Michigan University, we started a project to establish disease donation programs in the St. Paul's Hospital in Addis Ababa. And in fact, we have now a student in the master course from the University of Barcelona. So we did several visits in Addis Ababa, and we had people coming here in Barcelona. So as Marty was showing just before, how other countries have managed the organ source. So it's quite different if you look at these experiences. In Spain, we have more brain death donors. Then DCD is taking also a big part of it. And then living donation, it's a very small proportion. In USA and in the UK, living donation it has a higher proportion. And then if you look at Turkey or India, then living donation is the most common practice. But if you look at China, that started from scratch in 2015, you can see that it is really balanced. So I think that this is important to take into account. So we all know about this Declaration of Istanbul, and we know that it is a must to try to find this self-sufficiency and to be self-sufficient in transplantation. And this is feasible. It is feasible. Marty has also shown that Spain is leading this activity, but it was not so easy, and it didn't start from that 49 donors per million population. And we have been increasing, then getting into a plateau, and thanks to this DCD and expanding the sources of donors, we have been able to improve when everybody thought it was the top and we couldn't go further. So what is the secret of the Spanish model? Well, yes, there are several secrets. There are several keys for this success. But to make it short, let's say that what is really important in here is to have trained professionals in donation and in transplantation. It is also very, very important to have the institutional support to have a strong program. Then it is also very important to have successful first cases to get the confidence, not only of the population, but also of your colleagues in the hospital and of the own team. So we have to start surely. And we need, of course, a legal and ethical framework. And what is the most important is that it has to be self-sustainable. It has to be the African solution for Africa. So we have to find the way how Africa develops, each country develops its own model to be self-sustainable and do not depend on any other country. So how to start that? Well, why not to start with kidney living transplantation as it is happening in many of the countries? It is a good option because it's a scheduled procedure. You can have punctual assistance of other teams from abroad. So because you can schedule it, so you can ask for some advice and do cases when these this team from abroad can come and give you some help for the first cases. You can do continuous training of the teams meanwhile you are doing that. And it is easy to prove the cost benefit. So kidney living transplantation could be a good start. But of course, parallelly, you should work on a viability study to see the legal framework for deceased donation, the cost analysis for other transplantations too, the reimbursement policies, and really make sure that there is an institutional support. And then as a very short second step, we can think about deceased donation. And then for that, we need to involve ICU and emergency area professionals. We need to train people from all the departments that are also involved in the process, and to evaluate the potentiality of deceased donation. And then for the transplant programs, the creation of multidisciplinary team is a must. It has to be multidisciplinary. All the related departments have to be involved, and training. But do not forget tissues, because tissues is an activity that can make this activity also sustainable. And it is of great need in Africa too. So for skin grafts, for cornea grafts, for sure. And this is something that you get along with deceased donation. And why not DCD? And Marty was just pointing out that this can also be an option for Africa. So, and is it feasible to train people? Yes, it is feasible. You almost all know that we have trained people from 17,786 participants from more than 100 countries. And this works, just two examples, Thailand, doing training, you see that even if the numbers are not very high, they have proved that deceased donation is feasible. And a fantastic example is also Iran, that coming from very low rates of donation, of deceased donation, and having mostly living donation, now they have organized the things differently, and they have very high number of deceased donation that are equivalent to some countries in Europe.
Chloe, we have 1 minute more.
I know, I'm at the end. So what we need is experts. What we can do is to spread the knowledge and the competencies. And do not forget, and some of you have already seen this, but it is not only about knowledge, it is not only about experience, it's also about passion. And without passion and commitment, this cannot happen. But with this, I'm sure you will get it. So that's all. Thank you.
Thank you very much. Thank you very much, Chloe. Thank you very much, Marty. It has been a great session, and please keep joining us. We have now a talk from Professor Medhat Askar from USA. He's a clinical pathologist. He will give us his talk about eplet and epitope mismatching. And very sorry, Medhat, for keeping you late. The floor is yours. Keep joining us, please, Marty.
Okay, thank you very much. Thank you.
Thank you very much, Professor Gamal and the organizers for the kind invitation. It is really my privilege to present about the eplets and epitopes and the concepts of epitope compatibility. So just as an outline for my talk, I'll talk about HLA allorecognition. I'll talk about the conceptual framework of epitope matching, and I'll talk about their clinical relevance. So it just in a hierarchy of things is why this is important and how do we do it, and what is the clinical relevance of it. So the effect of matching, even until the very recent era under the most advanced immunosuppression, is still the effect of HLA matching remains clear. And we see this data until patients transplanted in 2017 with 3 years outcome. So these are data from 2019. We can see that the effect of 6 mismatches, and that's a deceased donor data, compared to 0 mismatch, we see significance. So why not match everyone? The barrier is that the mortality on the wait list, even compared, we look at this blue curve, compared to even the mismatch incompatible transplant, meaning patients who were transplanted not just across HLA mismatches, but even across donor-specific HLA antibodies, are still significantly higher mortality on the patients on the wait list. So to avoid that, we need to come up with a more creative ways for matching patients. So if we think about how HLA molecules are being recognized in a context of solid organ transplantation, here we have the HLA molecules that are made of polymorphic chains. The class 1 is made of the alpha chain, the beta 2 microglobulin. The class 2 is made of the beta chain polymorphic and the almost monomorphic alpha chain. But antibodies and T-cell receptors are not going to recognize the whole molecule. They're going to recognize specific parts of it, which are the epitopes. So this is the idea behind the matching at that level, is that, as we can see here, the paratopes, which are the binding sites of the antibodies, they gonna recognize just from physical limitation, is that they're gonna recognize specific portions of the HLA molecule. And these are what we refer to as epitopes, as defined by constellation of polymorphic amino acids. However, all our matching efforts and all our allocation system, with a few exceptions, are still definitely in the United States, are based on the antigen level. This is how we look at donors and we see who's match and who's mismatch. This is how we define antibodies and unacceptable antigens, and we calculate our calculated PRA, and at all of that at the antigen level. And if we look at how many antigen specificities we have, these are serologically defined specificities per locus. We have 28 at the A locus, 62 at the B locus, and 10 at the C locus, and 24 at the DRB1, and the 9 at the DQ, and 6 at the DP. And these really represent the most significant polymorphisms that distinguish different allele groups. So if we look here, if we compare an allele from the reference A1 allele versus reference A2 allele versus reference A3, we can distinguish among them via sequencing differences. However, the reality is, compared to these limited number of serologically defined specificities, the number of alleles keeps growing. And this is the snapshot of the IMGT database that just came earlier this month. And you can see that we have between class 1 and the class 2 over 32,000 specificities. And this is actually what is being recognized at the antibody level and at the T-cell receptor level. And here we can see all of these are A2, different alleles of the A2, and we can see that there are differences that could be recognized by the antibodies. So what have been the approaches to define epitopes? So there are serological approaches, and these were the earlier ones. And basically, it's a grouping based on serologic reactivity of allosera, monoclonal antibodies, antibody eluates, and site-directed mutagenesis. And an example of this approach is the cross-reactive antigen groups, or the CREGs, that are famous and popular. And there are also computational-based approaches such that relies on sequence alignment and molecular modeling. I'll just give you a few examples of each of the two models. So the HLA class 1 epitopes based on the serologic definition, the approach that have been taken by Nadim Lauer and colleagues from Terasaki Institute and One Lambda company, which is based on a recognition of binding sites of monoclonal antibody eluates and the antibodies confirmed with single recombinant antigens, such as the single antigen beads with the Luminex assay. And basically, if the serum is containing multiple antibodies, we absorb it against one of the cells, and then we elute different antibodies, and we do serial dilution to come up with single reacting species of the antibodies. And then we test those using the single antigen beads, and we determine the specificity. So just to give you an example, the A2 CREG that is made of A2 and A68 and A69 and B57 and B58, this actually could be due to two specificities, two antibodies that have, each one of them have the specificity. And through this elution and the absorption and the elution experiment, we can separate them into one antibody that recognize the 62G that would be reacting against the A2 and A68 and A69, but not the B57 and 58, or another antibody specificity against these two residues, 142T and 145H, that reacts with the A2 antigens and the B57 and 58, but not the A68 and 69. And so that's one of the approaches. Another popular approach for the computational approaches, which is based on sequences and molecular modeling, is the HLA matchmaker. And that has been described since 2002. And basically, you have definition of a specific polymorphic amino acids, and a constellation of these polymorphic amino acids would constitute what we call eplet, which could be 1 or 2 or 3. And then you have the epitope, which is occupies a larger physical area of about 15 angstrom radius, as you can see it here. And actually, it was I did my postdoctoral fellowship with René Dexnoy, University of Pittsburgh, and actually a definition of class 2 eplets was my postdoctoral fellowship project. And you can see each one of these yellow dots represent an eplet for DR or DQ, and these are top view on the top row and the side views. So just to make this very simple, you can think of these eplets as these like figures. So you can compare, you can see the idea is that you don't have to have the same constellation of eplets on the same antigen to count as a match. So basically, if you have, for each locus, you have first allele or first antigen and second antigen. And for those, you would have, for example, this is the patient, this is the donor. And you would look at each one of those and see if there are matches, however, on the same antigen or the other. So for example, here you can see that the first donor antigen is having the crown and the shares that are not shared by any of the recipient eplets. But on the other hand, the other antigen, it shares everything. It shares the bike, the bicycle, it shares the flute, it shares the dog, then the smiley face. So this is considered 0 eplet mismatch, while this is considered 2 eplet mismatch. And to compare the whole traditional antigen mismatch versus the eplet mismatch sum, is that here you have, it's just either a match or mismatch. So if you have 2 different DQs, then the antigen mismatch is 2. But if you look at the eplet mismatch sum, you have here, you count the yellow dots, and it's 12 in one of the pairs, but in another pair, it could be 0. In another pair, it could be 30. And based on this, you determine the level of molecular matching between the donor and recipient. And in an ideal world, you would like to see convergence of data derived from both approaches. And actually that has been attempted, and there were found correlation between that Terasaki defined the epitopes based on serologic reactivity and computationally predicted eplets from HLA Matchmaker. And there is a website that has a registry of all that houses all eplets for class 1 and class 2. And it shows you, however, there is a serologically defined reactivity that has been tested in the lab, or it is just predicted computationally. And I would like to caution here that it has been shown that the clinical correlation are stronger with eplets that have been tested by serological, that have been what we call verified eplet. And you can see here the difference between the correlation with donor-specific antibody is much higher with when you have antibody that has been verified, and that stands for both class 1 and class 2. There are other approaches to computation. It is true that HLA Matchmaker and eplet are probably the most popular because they have been around the longest and they have been tested more. But there are other approaches that are more sophisticated, such as the physicochemical disparities, the electrostatic score, and there are also just counting the amino acid differences, which is the amino acid score. And when they compare the amino acid score and the eplet matching score and electromagnetic score, you see that for class 1, the only one that actually correlates clinically is the electrostatic, but not the number of mismatches, not the eplet. It is true in the class 2, all 3 of them almost perform equally. And that's why we see most of the clinical studies about eplets and HLA Matchmaker are mainly DR and even more so DQ. There is another computational approach, which is the called PERSHI, or predicted indirect recognizable human leukocyte antigen epitope. There isn't enough time to go through this, but it has been tested in comparison to HLA Matchmaker, and we see for the for the most part, they both equally predict the development of donor-specific antibodies. So just to keep in mind that eplets and HLA Matchmaker is not the only way to predict the epitopes. It is not equal to epitopes. It's just a depiction or prediction of epitope matching. Why this is relevant, why I'm bothering you with all of this, because there has been clinical correlation based on the level of eplet or epitope matching burden, if you may. So the epitope load have been used to identify kidney transplant recipients at risk of allosensitization following minimization of immunosuppression. There has been a study that showed that trough levels combined with the epitope mismatch could predict the development of donor-specific antibody. And we can see here that if you have higher eplet mismatch, and you can see that if you have higher trough level above 5, then you don't have statistically significant difference. But if you have below 5, then patients with higher eplet mismatch load gonna be at higher risk of developing donor-specific antibody. And if we look at antigen, if we try to stratify the risk of development of donor-specific antibody based on antigen, however, TR or TQ, it is not statistically significant. It is 0.1. And that's because you could have one antigen mismatch that have higher eplet mismatch load compared to low eplet mismatch load in 2 antigen, and the same applies for DQ. And that's why when we stratify based on the eplets and we divide them into 0 and the low risk and the high risk, we see statistically significant difference in terms of risk of development of donor-specific antibody. And this actually has been validated in another study that looks at the prognostic biomarker for primary allograft, which this stratification of low risk, intermediate versus high risk can predict the de novo donor-specific free survival, the antibody-mediated APMR free survival, and surprisingly, even more than A1 clinically significant T-cell mediated rejection free survival. And currently, this has been used for acceptable mismatch program in Eurotransplant for over 2 decades now, with outcomes that are actually comparable to when you have acceptable mismatch. It's comparable to patients with who are non-sensitized. And this also is being tried recently to optimize outcomes in Australian paired kidney exchange program. So just to summarize, HLA as targets for alloimmune responses are recognized at the level of epitopes, and lower HLA mismatches at molecular level are associated with less risk of de novo donor-specific antibody, antibody-mediated rejection, T-cell mediated rejection, less immunosuppression, and better graft survival. I'll stop here and thank you very much.
Thank you very much, Professor Medhat, for this very elegant presentation. Let me ask you, please, a very short question. It is very clear that the epitope matching and mismatching carries a better indicator of the patient and graft survival. When would it be implemented and to replace the HLA matching, and we would shift from the Luminex donor-specific antibodies against the HLA antigens?
This is really a great question. I mean, because now trying to find the specific antibodies for the 32,000 alleles that we have in the registry is going to be impossible. It's just that we have to define antibodies in a more intelligent way. And definitely epitope is the way to go. But again, how do we define epitopes? Because as I mentioned, eplets are not epitopes. It's just a way of predicting epitopes. I think until we find a more consistent and reliable way of predicting epitopes, which really shouldn't, be undoable. It's just, I think the community there is still more work to be done.
Thank you very much, and accept our apology for the disturbances in the schedule.
I appreciate it. Okay, bye.
Thank you very much for joining, and looking forward to welcome you physically next time in our Congress. Thank you very much. Now we are going to move to the session of the Arab Society of Nephrology and Kidney Transplantation. And I would invite the chairpersons to co-chair this session, Professor Tariq Elbaz, هاني حماد, مصطفى وفيق, رشا عصام, أسامة محمدي, عز الشماع. دكتور طارق الباز. اتفضلي دكتور رشا. وطي شويه. الدكتور طارق الباز فين؟ لا لا هو بيتكلم على حاجه difficult patients بس اللي هي prepare the talk of Professor Ahmed Halawa. I think he's online with us and we will start immediately. Dr. Tariq, تعالى chair the session, please. It's a real pleasure and honor to have the Arab Society among the institutes having this conjoint and collaborative activity. And when I first contacted Dr. Tariq Al-Baz, he asked me to first contact Professor Ahmed Halawa to arrange this session. I told him, how are you going to manage it? 4 talks, 3 talks, 2 talks? But he agreed to have this important session to be in conjunction with our dear Professor Ahmed Halawa and discuss the important topic he will going to present. Dr. Give the introduction and the talk of Professor Halawa.
Professor Az is going to introduce Professor Ahmed, but I just like to make an announcement related to his talk. Is not what's written in the program about informed consent, but he's going to talk about something else, which is managing the difficult patient, something that we are meeting regularly, the angry patient, the depressed patient, something very applied and something that we are seeing so frequently. How are you going to deal with such an angry patient who's coming shouting and depressed, and maybe he's even aggressive? You're going to hear some interesting points. You'd like to introduce it?
It's a great honor to introduce Professor Dr. Ahmed Halawa, Consultant Transplant Surgeon, Sheffield Teaching Hospital, United Kingdom, Program Director of Postgraduate Education in Transplantation, University of Liverpool, United Kingdom. Dr. Ahmed Halawa always supporting and help his colleague and his patients in his home country, Egypt. Dr. Ahmed Halawa حبيبنا كلنا.
I guess you're aware as well of the fellowship in clinical transplantation program is going on right now. It's very a new form of teaching online, very easy to handle for everybody in his busy schedules. And I know that a lot of people from Egypt have joined the program of this fellowship, and we want more and more. Okay.
Come on, start sharing the talk of Professor Halawa. And I would like to announce that we will have the dinner immediately after that session and have the 2 symposia of the companies during the dinner. بس الدكتور حلاوة مش هياكل معانا بقى. Prepare all your questions and inquiries for the discussion, which will be directed by Professor Halawa. He is online.
You're online. ده انت ضحكت عليا.
والله انا خلصت بدري.
Nice to have you. Very good.
Thank you very much.
Thank you.
It's not uncommon to face a difficult patient. Is he really difficult, or we made it difficult for him? This is what we need to address by this lecture. I'm going to reflect back on my practice, and I'm asking you to do the same. I am Ahmed Halawa, consultant transplant surgeon. The objectives of this talk, we need to identify who is a difficult patient and why he is difficult. What are the early signs of difficulties? We need also to think how to prevent these difficulties and how to handle it when it happens.
I would like to remind you that our duties as professionals to make difficult patient an easy-going patient rather than labeling him or her a psychopath with personality disorders or any other unfair judgment. The blames do not lie exclusively on the patient. We share the blames. The organization as well shares the blame. I would ask you a question, and you have to think about a reasonable and satisfactory answer. Why and how do patients complain? I will invite you to read these statistics. 38 or nearly 39% of patients want an apology, just an apology. 73% want to save others from bad experience. Nearly 49% want you to be more honest with them about your service and policies. Only 13.5% complain just to damage your reputation. So you can tell from these statistics that the vast majority of complaints basically are novel and innocent complaints. They are not after you. They are not after compensation. How they complain, how patients react to the quality of the service they received. Word of mouth, pass it on to others, and 95% they share the bad experience, and 87% they share the good experience. Don't forget the social media now. On the social network, 30% will share the positive experience, 45% will share the negative experience. You can tell clearly that more negative experience being explained and passed on compared to positive experience. Some of them will write personally to you, expressing their negative experience and expressing their concern. They may also take you to the court. So what do you think, based on what I have presented in the previous few slides? Are they really difficult, or we made it difficult for them? There are certain key points I would like to address and highlight during my talk. Managing difficult patients and families is an essential part of our medical practice. There are always reasons for the patient or his family to be difficult. They were not born difficult. Recognition where the difficulties are coming from is the first step in resolution of the patient's concern. Effective communication, mindful listening, and empathy are the key points to respond successfully to the patient's concern. You should not be afraid to ask for help if you have difficulties in dealing with a patient or his family. I would like to remind you with this important wisdom: you will never get a second chance to make the first impression. Let me give you a rare scenario happened to me, and I'm sure similar scenarios happen to you as well. A 41-year-old single mother is being treated for depression, chronic daily headaches, and twice weekly dialysis for 3 hours each. All parameters demonstrated clearly insufficient dialysis. Her blood pressure is always running very high, around 170 over 110 mark. She's still working, she's still doing full-time job, as she has to pay the mortgage and look after her son. She came to see you for kidney transplantation to assess her for kidney transplantation. Of course, giving all this history and biochemical results, she's not fit for transplantation. Potassium, was high, blood pressure sky high, insufficient dialysis, evidence of non-compliance. You advise her to continue on dialysis, but 4 hours 3 times weekly, to take her blood pressure medications, and regular blood tests to check biochemistry. She shouted at you when you declined her a kidney transplantation. She said, "You don't care about me or even understand my suffering because you have obviously never been on dialysis yourself or have a mortgage to pay." The index case indicates an example of a difficult patient, which is not unusually encountered in our day-to-day practice. It was estimated that around 10 to 60% of our patients demonstrate a difficult behavior. When we started medicine, all of us dreamed of solving medical problems and curing diseases. However,